Okay, good morning, everybody. Um, we have, thank you for joining us this morning in person or on Zoom. I'm very proud to welcome you all to our 34th annual Fraser Gurd Surgical Research and Graduation Day. It's really, for all of us, I think it's a really important day, really a highlight of our academic year, where we can really take that day, take a step back from our usual activities, learn about the research in our department, and really celebrate our graduating residents and fellows. So I'm just going to take a few minutes because as I'm sure all of you have read this article that we wrote and published in the Canadian Journal of Surgery this month. And if you haven't read it, then feel free to take a picture of the link. You need to be signed into your McGill account to get to it. But it got me a little bit interested in some aspects of the history of our department. And so, you know, this is our Fraser Gurd Day. But so just a few words about why this is Fraser Gurd Day and how and who were the Gurds, and also some nice connections with our very generous visiting professor with us today, Professor Reynolds, who's come to us from Dublin in Ireland. And Fraser Gurd Day has been a department research day for, as I said, 34 years, since 1990, and we've skipped 2020. And the goal of that in 1990 was to bring the disparate parts of the department together at that time to try to build a more unified department of surgery. Before that, there was a Fraser Gurd Day, graduation day at the McGill General Hospital, and that was set up in 1978. So the Gurds actually also came from Ireland, like our visiting professor. They came a different way. They didn't take a plane and be here in six and a half hours, but they came in 1847, fleeing famine in Ireland with millions of their compatriots. And in 1847, there were 100,000 Irish refugees, essentially, who came to what would become Canada. There was no Canada in 1847. And of those 100,000, 70,000 came to Montreal, which was the largest city in what was then British North America, which had a population of 50,000. So you can imagine 70,000 refugees in 1847 coming to a city of 50,000. The Gurd family gave rise to 3 generations of McGill physicians and surgeons. The grandfather, David Gurd, graduated from medicine in 1879 at McGill, practiced family medicine and obstetrics. His son, Fraser B. Gurd, was really a giant in Canadian and internationally. Graduated in 1905. Like many McGill surgeons and physicians, served in World War I at the #2 General Hospital, which is the McGill Hospital. And that was where he developed his interest in fractures. He also, when he came home, his practice included tuberculosis and chest infection. He established the diploma course in surgery, which was the first unified training program in the Department of Surgery that included the Vic, the General, the Children's, and Queen Mary's veterans. He was vice president of the American College. He was a regent. And he was president of the Central Surgical. He was president of the American Association for Thoracic Surgeons and also the American Association for the Surgery of Trauma. And he was surgeon-in-chief at the MGH and chair of the Department of Surgery at McGill. His son, Fraser N. Gurd, that's who this day is named for, graduated from McGill in 1939, completed an internship at Johns Hopkins, also served in World War II, and went to do research fellowship at the University of Pennsylvania, which is another link to Professor Reynolds today, then joining the staff at the MGH. He was also a regent of the college. He was also president of the Central and the American Association for the Surgery of Trauma and chair of our Department of Surgery as well. In fact, when he came to come back for his training at the MGH, his father was a surgeon-in-chief and chair, which might be an interesting situation. And then in 1971, he joined the Royal College, where he had a lot to do with the implementation of standardized specialty training in Canada. So I think Dr. Gurd really exemplifies that kind of lifelong pursuit of surgical, academic surgery and excellence in education and in research. And so it's a very fitting namesake. I just wanted to spend a couple minutes in case you didn't know that history. And you can see from our program today that we've had many outstanding Fraser Gurd visiting professors in the past 34 years, and this year is certainly no exception. And I'd like to introduce Professor Reynolds, who's going to speak to us in a few minutes. Professor Reynolds is academic head of the Department of Clinical Surgery at St. James Hospital and Trinity College, Dublin, cancer lead at the Trinity St. James Cancer Institute, and principal investigator at the Trinity Translational Medicine Institute. He had also completed his research training at Penn, and was the first international fellow at Memorial, where he also had the chance to spend time with the late Dr. Alan Turnbull, also a great friend of the department. He's national lead in Ireland for esophageal and gastric cancer, and he holds several other leadership roles, including serving as president of the European Society of Diseases of the Esophagus, the Irish Society of Clinical Nutrition and Metabolism, and is a council member of the International Society for Diseases of the Esophagus. Professor Reynolds has obtained many research awards. He's published very widely in cancer with over 450 publications and 5 million euros in external grant funding, which is like 100 million Canadian dollars. He's also, we had a wonderful day. I know Dr. Ferry had a wonderful day yesterday at the Fraser Library and the Mount Abbott Museum. Spending time together and learning from each other is a great aspect of this day. We're really looking forward to Professor Reynolds' comments today, and he has very wide-ranging research interest and expertise, ranging from clinical trials, carcinogenesis, obesity, and fatty liver, and also perioperative nutritional support, rehabilitation, ERAS, and cancer survivorship. We're very honored and privileged to have Professor Reynolds with us today, and I'd like to invite him up to speak to us. Thank you.
Good morning, everybody. Bonjour. Thank you, Dr. Feldman and Dr. Ferry and faculty, ladies and gentlemen, for this great honor. I'm very proud, very honored today, and very humbly appreciate being part of this most illustrious role of honor of previous professorships, the great name of Fraser Gurd, the great tradition of this day. First slide. There we go. Green button. Sorry. A previous visiting professor, John Berkmar, 2016, assembled a paper from him, which informed centralization policies internationally, but really highlighted this was a 30-day mortality after many operations, including major cancer surgery. It highlighted a few things. One is the centralization. Secondly, just how serious a problem the esophagectomy is. And for this young surgeon at the time, even celebrated US institutions, I felt there was nothing to be super proud of, where 1 in 12 patients were dying within 12 days, 30 days of elective operation. So I knew this was a challenge. A lot could be done, and the likelihood is that all that go in the right direction. So immersed myself in esophageal cancer is what I did. But sometimes specialization can go too far. And at one point, and I've never said this before, but I was an authority on the lives and works and writings of people who actually died of esophageal cancer. As sad as that, as slightly mad as that, kind of cured now, but people like Carl Pinter, Christopher Hitchens, John Paul Bogey, they all died of esophageal cancer. So just completely immersed. In terms of background in science, I'm going to talk about that a little later on. I was fortunate in that my background before going on to higher surgical training was in tumor immunology, which was at 10, but also at a great, wonderful home of nutrition that was equipped with a wonderful laboratory research environment for 2 years, and then one further year here at the college. It allowed me to read and write science. It allowed me to, I think, have a measured perspective on claims in science that come out that are sometimes overhyped, game-changing, and so on. And it certainly allowed me to have wonderful respect for the work of scientists throughout my career. And the wonderful thing for me, given all of this with esophageal cancer, is I often say it as it's an exemplar, it's the perfect example of complex surgery with a high risk of major morbidity and mortality. Post-operative, a systemic immunoinflammatory response and disruptive challenge to organ physiology, particularly lungs, muscle, and associated function. It is a wonderful model, unfortunately, of malnutrition, cachexia, and sarcopenia. It is also adenocarcinoma as a model of obesity-associated cancer, and the pathway from Gurd through Barrett's through adenocarcinoma is also a very good model, clinically and scientifically, to study of carcinogenesis. And also, like many cancers, esophageal cancer management currently lends itself to that search for more predictability in understanding responses to standard therapies like radiation or chemotherapy or indeed immunotherapy more laterally. But I'm going to digress for a moment, and you're probably taught at school in Canada to be a bit wary of the Irish because, you know, we sometimes lay claim to people we admire on the flimsiest of evidence. Sometimes American presidents, not them all, I might add, but I'm going to risk running the gauntlet here with you by actually claiming some influence and credit and pride in your most esteemed son, William Osler, the father of modern medicine. And nothing made him more happy than to teach students at the bedside. He desired no other epitaph. And in 2 minutes, I'll give you the connection to Ireland. Foundations of bedside teaching were from Leiden, in the small city in the Netherlands, led by Herman Boerhaave. And people from all around the world came. That people went back and did what was done in Boerhaave, which was basically simply to bring medical students to the hospital to teach them at the bedside. When Boerhaave died, Edinburgh was the dominant centre, and from Edinburgh arose McGill, and from Edinburgh, big impact on people from Ireland, from Dublin, including my own institution, the Trinity College Dublin, to found the better days, if you like, of the medical school. Medical school was founded in 1711, but the golden age was in the mid-19th century. And two people were to form this. One is Robert Graves, who was influenced by travels in Europe and time in Edinburgh and so on. And his thing was that students were attached to patients at the bedside. They were, and then instructed by teachers. And they had their perceptive facilities, observation, all of that was done at the bedside. And these methods became ultimately the American way. People traveled far and wide because they had developed to such a fine art. Of course, his most famous legacy is in Graves' disease. And he was accompanied by somebody who was a little bit, 1 or 2 years junior to him, was William Stokes of Chain Stokes or Stokes-Adams attacks. And he was the authority in heart and aorta. But together, they developed this model, a clinical model in the Trinity College teaching hospital. Now, the connection is this. Always in his career, but also specifically here on a visit to Dublin for the bicentenary of the Trinity Medical School in 1911, William Osler credited Robert Palmer Howard on influence on him, and he did this many times throughout his career. But I quote my teacher in Montreal, Palmer Howard who lived, moved, and had his being in his old master's Graves Stokes. There's the connection. So in the talk, I want to talk a little bit about morbidity and mortality and the advances and unresolved questions. I want to take on a little bit of a journey. I can't go too deep into anything really, but a journey around my patients through fat, muscle, and brain. Lessons from a recently completed academic investigator-led RCT, which I did, and some elements of advances and challenges in translational research and a personal sense of realism, rigorous questioning, and optimism in that space. But first of all, probably the biggest impact on reduction and improvement in outcomes is there's so many different things, but they all come together in centralization. And when centralization policies have been pursued for esophageal cancer, they've worked. We were centralized in 2012, and very clearly, our outcomes, mortality, and oncological outcomes have improved since then. I know in Montreal, it's centralized to two centers. And it's very intuitive and simple that what happens in the centralized model is a virtuous circle of high volume experience, multi-disciplinary team working, governance, audit, quality assurance, no operative debt being really unquestioned or acceptable. That sort of culture emerges from the right sort of centralization model, and inevitably, it's to benefit of the patient. And I've got to give credit to a great Canadian, Don Lowe, who's based in Seattle. What he really did with missionary zeal was to travel the world and create friends, really, of everybody in the esophageal community. It's quite extraordinary, but also very importantly, that we speak the same language, like a lingua franca for esophageal, but the same language of complications. Just the easiest of easy collaborations with respect to data sharing, benchmarking, and reporting. And what he did was amazing, really transcendent, and has to be given great credit for that. In one of his papers, which I love the title of, it's called Esophagectomy. It's not just about mortality anymore. Is good, and it's true. That's not just about mortality anymore, thankfully. But it's still, in my view, mostly about mortality. The only source of knowledge we have is experiences, Einstein. But I suppose the essence of what we really learn is from our experience, the existential reality of, what happens in an anastomotic leak, for example. There's a big stress, but any operative death is massive, and you learn so much, must learn so much from that. So I was quite happy when we benchmarked our national data, post-centralization, against the Don Lowe massive consortium that we're part of, and against the Dutch national data, which is very well maintained. And we observed a very low mortality rate, less than 1%. It's about 1.8% now, to be FYI. Quite a low anastomotic leak rate of 5.4%. The big thing for us was pneumonia. And because pneumonia is a big thing for us, that has been the focus of my current research in this particular space. And what I struggle with in the pneumonia space is that none of the definitions that we ascribe to pneumonia was built on a thoracotomy patient or an esophagectomy patient. And whether what they really describe as an infection, which pneumonia should be, or whether it's just acute lung injury from one lung anesthesia, some trauma to the lung during surgery, maybe a pre-sensitization of the lung from chemotherapy or particular radiation therapy, or all of those elements. And there's no severity classification for pneumonia. So there's a gap in that space. And also the other question is whether whether it's a big deal at all, but that's certainly from an academic point of view, that's been a recent focus. So for example, with the CDC, the Central Disease Control classifications of pneumonia that we use, I mean, it's very easy to have a little bit of an infiltrate. The low bar, it's very, to have a little bit of infiltrate on an ectatic piece of lung after an esophagectomy. It's very, very easy to have a white cell count over 12 just from the trauma, the effects of controlled surgical trauma. And it's easy to have a cough or a worsened cough or something after surgery or a little bit of dyspnea. So it's a very low bar for class with definition of pneumonia, but is it really pneumonia? When we looked at a lot of cases with open surgery and reported on this, we reported 16% at CDC defined pneumonia, respectively documented, but just 23% of that cohort with 6.4% overall had positive cultures. And we'd be very aggressively pursuing sputum cultures, blood cultures obviously, but maybe sputum cultures. So, and for culture negative pneumonia, neoadjuvant chemoradiation therapy was significantly associated. But the conclusion, my conclusion was suggested that pneumonia, CDC or ATS, fine, reflects a spectrum of etiology, acute lung injury of sorts, with infection rarely proven. And this is important. From the point of view of academic rigor and influence of studies on practice, and I'll tell you why. The one trial comparing minimally invasive esophagectomy with open surgery, that's level 1, complete minimally invasive versus open surgery, that's level 1, it's called the time trial. And what this showed was that the incidence of pulmonary infection within the in-hospital stay was 34%. And that compares to 6% in our experience. So difficult to understand that and interpret it, but we must do so. And a lot of people went through minimally invasive esophagectomy training programs with a very, very high learning curve, on this, partly on this basis. And the other thing that's slightly confusing in this space is when you looked at all the ESA data and you compare minimally invasive, which I love, with hybrid, which is a mix of the two, or open, what it shows is that the pneumonia rate is higher in the open, but the anastomotic leak rate is higher in the totally minimally invasive. How do you explain that? I don't know of any operation at all where an anastomotic leak cohort, a higher anastomotic leak cohort, would result in less overall complications. So go figure, can this really be so? And so my point is that the definition and the recording of pneumonia needs to be tightened up, probably, and made a bit more uniform. It's nothing against any of the publications, it's just saying these raise questions for me. And robotic surgery, we've started that's becoming our standard, we love it. And within the robotic surgery space, there's only one randomized clinical trial from Utrecht, a very small trial, 112 patients. Primary pneumonia is defined as just the clinician's decision to give an antibiotic. But not even the CDC or ATS definition. That's it. And that's obviously highly subjective. So a final point here is there's a lot we can do in this space. Atrial fibrillation is atrial fibrillation, a leak is a leak. Pneumonia is a lot of things, I think, in terms of how it's currently. That's the point. So we tackle postoperative pulmonary complications in a multidisciplinary way. Here comes the research. So we're very fortunate, like you have here. We don't have physiologists, but we're physiotherapists, academic physiotherapists, clinical physiotherapists, and dietitians who are the physiotherapy team that work on with our patient from the time of diagnosis through prehabilitation to surgery and beyond surgery into multidisciplinary rehabilitation. And they've brought in a few million grant funding, many publications, a few randomized clinical trials. And the current clinical trial is taking our patients 2 weeks out from surgery and randomizing to high intensity interval training, which is really periods, 30-minute exercise period with 30 seconds of getting to VO2 max based on CPET testing and rest and so on, as opposed to standard And we're going to see if that's going to make any difference in, particularly in postoperative, in preoperative and post cardiopulmonary fitness and postoperative complications, particularly with early complications. The other study, just to share with you, which we're doing, about 50 patients recruited, is to try and understand the microbiological, particularly the immunological condition of the lung during and after surgery. So we do catheter bronchoalveolar lavages at the end of one lung ventilation, taken from both lungs for microbiology and immunology, a whole load of things being looked at, and then very detailed postoperative cytokine, procalcitonin, etc. This is just pursuit of accuracy. That's all I want to this sort of let's face it. Hopefully something. So moving slightly on to another topic of great interest to me throughout my career. This is probably familiar to you, and certainly from the esophageal adenocarcinoma, maybe with hepatocellular carcinoma, are really fantastic models of the obesity cancer link. So again, having the opportunity and the mechanism you probably know, but in the simplest cartoon, the description, dysfunctional fat, central fat in particular, interfaces with insulin resistance and all the hallmarks of cancer through signals, through ligands, receptors, signal transduction pathway, for example, with the overlapping impact of leptin, insulin-like growth factor 1 on mTOR, MAP kinase pathways on cell proliferation and survival, or the prototypical inflammatory cytokines, IL-6 and alpha, working through STAT3 and NF-kappa B, or indeed VEGF and plasminogen activator inhibitor 1, again promoting angiogenesis. So this is the model. And being an esophageal surgeon, whether it's open or minimally invasive, you have access to fat. So every single operation that we've done pretty well since 2011, we've taken fat from the visceral area, or mental fat, subcutaneous fat, liver biopsy to correlation with fat. And muscle as well for different projects. And all I can tell you is that in that type of patient, particularly patients with metabolic syndrome, is just teeming with activated cells, and particularly CD8 T cells, activate macrophages as well. With all the research we've done, one of the things I really want to know was there a symmetry fat, central fat? Central fat is very different from subcutaneous fat, but there's symmetry between central for a lot of patients with non-alcoholic fatty liver disease. And there is. So looking at memory effector T cells, CD4, CD8, activated T cells, gamma interferon producing T cells, TNF alpha producing T cells, TH117 cells, chemokines like CCL5, gamma interferon inducing IP10 T cells, all of those incredible parallels between the central fat and the liver. But the frustrating thing about it all is that everything we look at, whether it's a cell or the conditioned media from an explant of fat or liver, everything just is driving hallmarks of cancer or the emerging hallmarks of cancer. But in terms of feeding back and impacting this way, nothing really emerges that we can give to patients who have this cancer that makes it uncertain. Treatments, preventive sense, bariatric surgery may result in a 33% reduction in deaths, I think, some report. Overall, not really clear in esophageal adenocarcinoma. You need 50,000 patients to study it. So, got a bit tired of that. This is Christopher Hitchens' incredible essay on rhetorician, wrote that theory, wrote several essays for Vanity Fair, which they can put together in the totality. He talks about living dyingly, but this quote is relevant. You lose weight, but cancer isn't interested in eating your flat, but once you're muscle. That's true. And it's subject to me once you're muscle. complications after a self-injectomy, one pure muscle. So, and everybody, because the bar is so low for cachexia, 5% weight loss, pretty well everybody with esophageal cancer will be cachexic. So the focus now very much is there's a paradigm shift in the approach to weight is the past. The current is muscle and function. That's intriguing. And this comes into enhanced recovery protocols, is the amount of muscle mass that we never measure and probably don't even appreciate. We know we should mobilize our patients. If you don't mobilize her early, massive amounts of muscle are lost. Like in 1 week, 6 fillet steaks worth of muscle will be lost from bed rest, for example, or from immobilization. So it's quite extraordinary. So this resulted in a lot of interest in this area. What we're trying to do, get into prehab, but this restore randomized clinical trials taking patients who are a few months out from curative gene cancer treatment. And we take them and we do 12 weeks of structured training, which is a mix of aerobic and a mix of resistance. And a lot of particular endpoints. Again, the study is nearly finished, like the pre-hit is nearly finished recruitment. There's nothing really to tell you, but this is what we're trying to do. But an increasing focus on muscle and measurement of muscle, and even taking muscle biopsies, looking at other structure, like the immunological stuff. It's kind of interesting, and I kind of love it. And we don't, we could go to extremes in terms of aerobic and resistance, but the study of the fractional synthetic rates of myofibrils within the stomach from resistance exercise and mitochondrial function within muscle from endurance exercises. It's interesting, and we can learn from that. I'm not saying that's an everyday thing for our research, but I think it's a very important area to study. And this is the muscle itself is like an organ in terms of the amount of studies that can be done around it, not just for esophageal cancer. And the impact of brown adipose tissue, liver, the microbiome, the heart, all of those things are important. But what's very interesting is the brain. And I never thought
is still paying for a resident global conference. I think they're not allowed anymore, right?
Is that okay? So I never thought in starting off that, the arcuate nucleus of the hypothalamus. I thought of that. Never thought that was to be of any interest to me. And neuropeptide Y and agouti-related peptide and pro-opioid melanocortin and cocaine and amphetamine-related transcripts. Never thought it was a fascinating area. I've been fortunate to collaborate with experts in the field or in studies around our patient. And what's important, it's relevant to all of cancer, but what's important for patients who undergo esophageal cancer surgery is that they lose the ghrelin drive, because usually the fundus is stomach is removed, for ghrelin drive for orexigenic drive to stimulate appetite. And then without that, nutrients within the lumen of the gut stimulate the L cells, the endocrine cells, to release glucagon-like peptide 1, which everybody knows about now, and peptide YY. They have negative influences on satiety. Clearly, GLP-1, everybody knows the impact of Ozempic, semaglutide, and that sort of thing. So why is that important for our patients? Well, they lose the ghrelin, as I said, but what happens with GLP-1 response? So GLP-1 is an incretin as well, so it increases. So there's glucose challenges as well, it increases insulin. So when we study this, the response to a meal in patients who've had an esophagectomy at all times from 10 days post-op to 12 months post-op is massively increased compared to control. And the area on the curve remains high. It's happening for GLP-1. We also know it's happening for insulin. And the clinical relevance that is obviously its effects of satiety and also the effects on glucose. If you do glucose monitoring on these patients who have esophageal, astonishing how many of them will have hyperglycemic episodes because they can't handle it properly, and many hypoglycemic episodes which would correlate with the dumping syndrome we all know about and could never really fully understand. So there's opportunities for research in that area, and even inhibition of glucuronide receptor. There are drugs out there, and we're hoping to actually do some studies in patients with advanced cancer with those drugs. Sorry. And the other thing, if you really look at these patients as well, the other things are that of interest that we've found is that almost half the patients have pancreatic insufficiency 2 years out. Not sure how, but that's true. But it's at least it's modifiable by pancreatic supplements. And high percentage of patients have bile salt malabsorption again, which is modifiable, not as many. And a lot of patients have small intestinal bacterial overgrowth, microbiome, whatever is going on there, and that's easily diagnosed, and it can be treated as well. So all these things, it's a treasure trove of research from many, many different angles around these patients. So I'm going to move on. We all have heroes in life, and maybe Murray Brennan is my Osler, if I can put him on nearly the same pedestal. And he's the chairman of surgery for Memorial Sloan Kettering for many, many years and influenced a lot of fellows. And the style of teaching was described as in the Socratic style. So he would just get everybody grouped around, probably Oslerian as well. Everybody grouped around, he just had to work things out, critical thinking, case discussions, no didactic teaching. But I think it's like probably a good hockey coach or football coach. He just was able to bring people to the next level, fellows to the next level, and become more ambitious. One of the things he said, and I hated him for it for a while, was yes, any ambitious fellow should lead one ambitious randomized clinical trial in their life, and I did. And it's just been published recently, and it's trimodality therapy versus perioperative chemotherapy in our common cancer, adenocarcinoma of the esophagus and junction. Let me tell you just a little bit about that and what I've learned from it. So back in the day at the start, when I decided to do it, 2012, this paper came out, and it was chemotherapy and radiation therapy prior to the way better surgery, no brainer, slam dunk. At the same time, in many countries in Europe, perioperative chemotherapy, particularly with a regimen called MAGIC, based on a trial, pre and post surgery, was common, particularly UK, France, Germany. So they were the standards. And then in 2018, years after the trial was developed, the trial came out from Germany called the FLOT4 trial that blew MAGIC regimen, perioperative chemotherapy, out of the water in terms of its impact. So as a surgeon and a surgeon investigator, I really felt maybe there should be a standard of care, and the purpose of setting up the trial was to see if one existed. So the major question for me in 2012 was, in locally advanced AEG, is radiation therapy really required? Where, excellent surgery increasingly, like Dr. Berry and his team do on block resections and radical lymphadenectomies is increasingly the standard. And the second question, this always bugged me, and it was always an area of great research interest of mine, was does preoperative radiation therapy increase operative death rates, particularly major respiratory morbidity and anastomotic leak rates? Even though that was my way always, this was the question that bugged me and one of the drivers for doing the trial. So this is en-bloc surgery. Everything is basically skeletal. So do we really need radiation therapy? It really would have been the proponents of against it would have been saying that. The radiation question is interesting in that many patients with modern radiation before surgery will have some degree of lung injury, certainly even with clinical measurements and everything like that, very, very carefully done, target volumes and so on. And the thesis is that radiation may impact on an injured alveolar cell, particularly a type 2 alveolar cell, then through a process of epithelial mesenchymal transformation, form fibroblasts or myofibroblasts that can lay down collagen and interstitial fibrosis. Also, that everything that goes on with pre-operative radiation, it may prime the immune system in the lung, be more pro-inflammatory. And so all of this may be a priming, if you like, so that other hits like bundling anesthesia or even infection could result in, catastrophic changes like ARDS and diffuse alveolar damage. That's the cartoon. So The trial is this, it's called Neo-Aegis, I was the PI. Ended up with a non-inferiority trial, so the cross regimen versus initially the magic regimen, laterally flot was accepted. Primary endpoint, the usual primary endpoint of overall survival. And this is what it showed. Cut to the chase, overlapping lines, no difference whatsoever. Detailed briefly, 377 patients randomized, follow up over 3 years. Most of our patients who relapsed within 2 years, as many of you know. Median survival was 48 months versus 49 months, the same. 3-year survival, essentially pretty good, but the same. And I suppose the messages to communicate to an audience, if you're going to be a PI in the trial, is become best friends with the statistician early on. Statisticians and scientists should be your best friend. And we started off with a power calculation that was a little bit abstract. It was based on non-contemporaneous trials, the cross trial and the magic trial, 6 or 7 years between them. Things can happen in that period of time in terms of improved outcome. But that resulted in a target of 366 patients. Then my British friends, before they would come on the trial, they said, no, we want to make this 10%. So we go up to 594 patients. Then the flop comes out of the blue. And so we have to go to a non-inferiority design. And that goes up to 628 patients needed. Then we do our first interim futility analysis, and it's overlapping lines and arm A. So beware the unexpected is my first message. Arm A, the magic arm, way, way, way better than the anticipated in the sample size calculation. And then we did a second futility analysis in November 2020. Again, overlapping lines, not futile, no change, but with that, unlikely to change, long follow-up, and COVID, the trial closed as per the DSM recommendation. So what do we show? We showed that the preoperative chemoradiation didn't have any impact on those complications that I was worried about, like pneumonia or NS1 leaks, or mortality about 2% in both arms. We showed naturally enough that chemotherapy had more neutropenia than chemoradiation therapy, but in fact, for quality of life during treatment and 1 and 3 years in follow-up, much the same. So again, if the primary outcome is going to be the same, then you've got to go to the secondary outcome, because in MDT decision making, they may influence the decision making, but they were essentially okay, except that the radiation, trouble coughing, or a little bit troubling cough was more, and some discomforts and pain, but no great difference. And the other thing that's important is that, and this really is important, that all this happened, this equivalence, equipoise, fact that the pathological response on the primary site and upper regional node was much greater for nodal downstaging, PCO rates, major pathological response rates were much greater in the patients who had radiation with chemotherapy. But the clinical response rates were the same, out of interest. And very interestingly, and again, it's just not to believe every cartoon construct is, the failure rates local regionally and systemic were the same. Wasn't massively better in chemoradiation local regional, massively better in the chemotherapy systemic. It is what it is. That's what the trial showed. And we're entering a new era, and this was happening during the trial, and these things happen quickly. And this is a fantastic new era, and there's Tatsuki Hanjo and Jim Allison, and these have really revolutionized the world of cancer, particularly for lung cancer and for some other cancers, but not yet so much for esophageal cancer, I have to say. But a trial came out towards the end of our study called Checkmate 577 trial. And David Ilson, in his editorial in the New England Journal, said it defined it as a new standard of care. What is it? And this is the trial, and basically, with early follow-up, the disease-free survival of patients who had chemotherapy and radiation therapy, followed by an esophagectomy, had still residual disease, so not a complete pathologic response, but just residual disease, were randomized to nivolumab for a year or placebo for a year. And it showed a dramatic difference in median disease-free follow-up. Survival, 22 months versus in the treatment versus 11 months. But Here's the question. In the NeoAges trial, perioperative chemotherapy, disease-free survival over 32 months, prime modality 24 months, 11 months there. So what does that mean? And the point is that the vast majority of published literature in this space will show much better disease-free survival than that trial. But the questions that are still outstanding are the poor disease-free survival placebo group and no overall survival data, limited follow-up. And also 107 known is like 170 centers in 29 countries. Hardly very few designated high-volume esophageal cancer centers included, mainly done through medical oncology community. And you just wonder. So in Ireland, for example, there was a massive rush to get it approved for everybody. Initially just insured, and then a year later, everybody. Put so much pressure on the government. But some more measured countries like the Netherlands haven't approved it yet because the evidence isn't complete. We don't have the overall survival data. But there's still some questions about that. And then also many times over the last number of years, I was told that preoperative immunotherapy was definitely going to be a way for adenocarcinoma like it is for some other cancers. And this is a trial that's just been published, the Keynote 585, and this used Pembro with cisplatin and fluorouracil, or with FLOT more laterally when the FLOT trial came out. And again, that showed no differences in overall survival. To many people's horror and surprise, it did show an improvement in pathological response rates, what we've seen from earlier on, but that doesn't necessarily, with good surgery, doesn't necessarily translate into a difference in survival outcomes. So I'm not cynical about this in any way. I'm just academic and like to have real rigor and understanding to trials and look deeply into trials. And Stephen Rosenberg was a superstar, still is, back in the time I was in Philadelphia. And he was doing, New York 60-minute front page New York Times stuff, curing cancer in experimental models, and then in certain elements within in humans as well, melanoma, particularly renal cell cancer. Just was mind-blowing stuff. But I used some of high-dose IL-2 and interferon, whatever, in clinical practice in London when I went there. And I suppose the bottom line, considering the expectation that was there then, of what actually happened, I know we're much more precise now, is just to give a sense that all that glitters is not gold, and you have to be absolutely measured and critical about what's there. So in contrast to non-small cell lung cancer, for example, we have a long way, sadly, to go with esophageal cancer. In terms of the big question, the plot, which is docetaxel containing, it's something used in Montreal for a long time, PCF, or crossed chemoradiation. There's a trial going to be presented in ASCO in a month's time. And this is called the EZAPEG trial from Germany, and it compares very like our trial, except it's pure FLOP versus cross, and we'll see what that shows. But it's interesting that it's powered on FLOP being 13% superior to cross based on a very, very small data set. And look, when me and Dr. Ferry put all our cross and FLOP data together and propensity matched them, again, overlapping lines, cross versus FLOP. So we'll see what it shows. You study every randomized trial in detail based on what it shows. And you really want to know all the data rather than just kind of a headline. The lessons for me from being PI on this trial, Murray Brennan was right. I think if you're academic and ambitious, please lead a randomized clinical trial as a surgeon. You get so much from it. Surgical quality assurance should be increasingly explicit. RTQA, which we had in our trial, was very explicit and important. Power calculations key. Statisticians from ab initio are essential. And they'll give you a load of added work, including the journal statisticians, the best journal statisticians, which will give you the 6-page review of your paper and a huge amount of work to do, keep you up at night. In terms of the interpretation of the trial, and my conclusion from the trial is that both perioperative chemotherapy and chemotherapy are equivalent for the cohort of patients that the trial includes, which is CT3 and 0 are involved. And so clinical equipoise is the only conclusion from that trial. There is no standard of care. There are two gold standards, but no absolute standard of care. And again, the lesson for young investigators with trials is just prepare to be surprised. Our outcomes for the MAGIC regimen, for example, way better than the outcomes for the MAGIC regimen in the FLOT4 defining trial. And it's so just be wary of oversimplistic cartoon expectations, or those that hammer the podium and say there's certain something is going to happen. So brings me finally to science and briefly. And I mentioned collaboration with Lorenzo Ferri with a lot of clinical work, and that would absolutely be wonderful to be able to connect Trinity College Dublin with this wonderful university and hospital in terms of science. It truly does know no country. And it needs to tell us a few things in my area, similar as parallels in yours, I'm sure. Can we recognize a complete pathological response and permit a watch or wait or surgery as needed approach? Can we measure absent or minimal residual disease post-induction therapy or surgery? They connect. Can we predict responses either before or early during neoadjuvant chemotherapy or neoadjuvant chemoradiation? Or determine drug or treatment sensitivity in vivo? And can real precision be added to immune therapy considerations? Can we convert cold immune tumors to hot tumors, for example, immunologically hot tumors, more likely to respond to immune checkpoint inhibitors? And it's really important in my space and Lorenzo's space, because there's a move out there, a bit like rectal cancer, similar treatment paradigm. It's different cancer, towards treating or holding on patients who have a complete clinical response, expecting that they're going to be cured, and just operating on those that relapse. It's okay in rectal cancer, but that whole thesis is being propagated and tested, to be fair, in esophageal cancer. So Jan van Lanschot, is a great guy in Erasmus Medical Center, is the architect of it. And what it's built on is the idea that patients who are 12 weeks after chemotherapy and radiation therapy in this context and have negative PET scan, negative endoscopic ultrasound, negative biopsies, even with deep bite-on-bite biopsy, would be safe to leave. What's interesting is that their pre-major trial testing of this hypothesis, the pre-SANO, showed that the sensitivities are really poor. And it's like a toss of a coin. And the reality is that even somebody who looks perfect in all of those criteria, there's a much greater than 50% chance that if you operate on them, you're going to find cancer. Now, sometimes it'll be just submucosal or whatever, but you will find cancer. So we're going into delicate ground here, but the SANO trial was permitted and has just been completed. So patients who have this disease, adeno or squame, who have the chemoradiation, tested at 6 weeks, looks good, tested again at 12 weeks with PET scan, looks good, then they're randomized to surgery or surveillance. What they've recently reported, and this is the big thing that needs to connect with science, is a non-inferiority of the two. Now, the trial hasn't been published yet. There's a lot of criticism out there. Won't even think about going into that here. But this is the direction of travel for esophageal, like it has already traveled, for example, for rectal cancer. So science is hugely important, and we've come a long way in terms of better understanding from the Cancer Genome Atlas and all those wonderful work Adam Bass and others have done, that, for example, squamous cell cancer and adenocarcinoma of the esophagus are completely different cancers. And also, very importantly, that adenocarcinoma of the esophagus injunction is the same as most gastric cancers. And this is rhetorical, we should not mind the gap, which is great for biological research, molecular research in this space. It's very important. However, we should recognize that these chromosomally unstable cancers, which identifies in CIN, can be highly unstable. Chromotripsis means literally massive genomic rearrangements based on a shattering of the chromosome, and that occurs in 30% of cases. Catechesis is Greek for thunderstorm, and again, hypermutation of genes within that denotes that. And this is what we see commonly. So it's a real challenge to get in on and understand and really defeat this type of cancer when you have that. And it's hugely a heterogeneous cancer. So we have to trust our scientists, and our scientists have become our closest collaborators, obviously, in this area. I don't know there's much more Dr. Ferry and myself can do as surgeons. When we skeletonize everything we can do, there's nothing else you can do. So it's going to be science and drugs and new therapies and better understanding and precision that's going to make the difference. Very briefly, what we focus on in our center is the tumor microenvironment, the study disease progression, resistance to therapies, immunotherapies, development drug therapies, and with so much kind of work going on in this area, without there being a kind of a major, huge understanding, but no major kind of breakthrough that would inform everyday practice. At one point in my life, and spent years on this, I felt an NF-kappa B, which is like the master switch, master transcription factor that turns on everything to do with inflammation and everything to do with inflammation as it relates to carcinogenesis, and was a huge factor in predicting response and resistance to chemotherapy and radiation therapy in our models, in our ex vivo models and in clinical studies. Yet it's very difficult to manipulate that, and all the far reach of that is very difficult to do. We've looked at gene signatures, microRNA signatures, energy metabolism, oxidative phosphorylation, glycolysis, balance within cells, and all these are really interesting for identifying predictors of response and resistance. Again, not easy to bring into clinical practice, but what is interesting, I think, is a study we did a number of years ago using proteomics and mass spectrometry and taking sera from patients before treatment and early after, the first few days after they had treatment, see was there anything that would predict response or resistance to chemoradiation. And we saw all these peaks, there's about 9 peaks, and we kind of studied them and ELISAs and everything, and lo and behold, 2 of them were for activated complement, C3A and C4A, which are produced by the tumors, and they're the alternative pathway of complement activation. And again, we've done a lot of work in this area, and we're still working in this area because it's something that's very usable and simple to use, but again, nothing that has really got into day-to-day practice. So where are we going in the future? Lorenzo gave a great talk a few weeks ago in Oxford, and he gave me this slide. And I think this is one area of very much that's for the future, and that's the disease on a chip and the patient-derived organoids, and that in a meaningful amount of time, you'd be able to define from the organoid as to whether the drugs that you're using are new drugs could have an impact. And it's great science, and an enormous amount hopefully will come from that towards more precision and more like an in vivo chemo and radiation sensitivity assay. We've developed organoids for gastric cancer in our center, and we're building a live biobank here. So hopefully, I hope there'll be a collaboration between both our institutions going forward. And the other area, just to mention, I think, is again looking for cell-free DNA or circulating tumor cells, because how wonderful it be and how necessary it is to know for that watch and wait policy if this can be developed, whether that can be done. And also, wouldn't it be wonderful for patients who don't need post-operative chemotherapy, that they don't get post-operative chemotherapy, which is very difficult unless they have evidence of cell-free DNA. So in conclusion, we and our great institutions should aim very high towards trying to cure these cancers, notwithstanding the incredible complexity and challenges they face, and to alleviate the suffering of these with these cancers. I like this. Franny Moore was a great, great Harvard professor. And this is a famous quote from him, and which I believe in, the surgical investigator, can do a lot, but at minimum must be a bridge tender, channeling knowledge from biological science to the patient beside and back again. And I'd even add to that, I've seen it here, the bridge is metaphorical here, but really build bridges and structures to connect them, and if you enable structural developments and are the right sort of person to build the bridges amongst a broad team, then that's the direction of travel. That's the optimal direction of travel. So a bit like this, when team medicine and team science coalesce, going in the same direction, like this murmuration of starlings, it's a thing of beauty when everybody is same purpose, same direction, and working together. And I wanted to pick a quote for a final slide that might be opposite to the day that I'm not sure if I did that, but Seamus Heaney is 100% Irish and Nobel Prize laureate from 2020. Oh gosh, can't even remember that. But his probably some of the most famous lines, and probably very relevant to the world we live in today, relate to hope and history rhyming. So our hope, your hope, my hope, and history rhyming. In other words, for world peace and the end to war and famine and all of that, and how relevant all that is. But the last line is also relevant. The last two lines to believe in miracles and cures and healing wells. And I think we can all keep up the good fight together in that regard. So to find, I'd like to dedicate this to Alan Turnbull, who's a great surgeon, a fine surgeon, even finer human being, who loved Montreal, as do I, and thank you very much for this honor. Thank you.
That's a great talk. I think a really great example of the surgical scientists seeing clinical issues, challenging clinical issues and informing science, and then back again to the patient. We have a few minutes for questions. Dr. Ferry will start us off.
That was outstanding. Really, really inspiring talk. It's remarkable how you've really taken everything from your patients. Like it has driven your entire career from basic science to clinical to trials and everything. So if it's sort of like paraphrases those sort of statement, listen to your patients. They're telling you the diagnosis. Yours is like, listen to your patients. They're telling you the clinical research questions to ask. Going forward for the young sort of surgical investigators or young residents who are finishing right now, what do you think is the most important in what are some of the more important things to get in a job, issues that you like to look out for in order to start a research career as a surgeon?
Well, we're going to talk about this at lunchtime today, but I think having a background in research and science, it doesn't have to be laboratory science, but and I looked out being it wasn't by design, but it was tumor immunology and nutrition. How perfect that is for esophageal cancer, as it turned out, but that's serendipitous. But I think laboratory science experience is great. I think a lot of young people now I see are taking their time to go through. They're not in a mad rush to go from A to B. And if you're taking your time and you get the value of research time, the best centers with the best mentors, and obviously very good scientific supervision and oversight of what you do, I think it's invaluable. But research is much more broadly around the patients now, and we know very much from Dr. Feldman's world as well, and from ours, that there's so much good research that can be done by doctors, but also physiotherapists, nutritionists, and nurses. I have so probably one of my proudest achievements over years anyway, is to have physiotherapists, nurses, and dietitians do PhDs with me, in addition to giving as much encouragement as I can to those who want it and who have who have a natural curiosity and bent, to be like, for academics to try to create the structures that give them the opportunity to do research and do it well. I don't know if that answers your question, but Lorenzo, thank you.
Right. So I think we have our marching orders. Everyone here has to run a randomized trial. At least,
That's right. Oh, that's right. That's right. Well,
I want to, on behalf of the department, give you a few souvenirs
Thank
of
you very
your
much.
visit with us. We're going to go on, obviously, with our research day. We're going to take a few minutes to set up the first session, which I believe is the oncology session. So I think it dovetails very well with this great talk that you've left us with. I want to congratulate in advance all the presenters today. There was great interest in submission, and it was difficult task. But I'm to thank Professor Violet as our Vice Chair of Research, the abstract committee, Misha, Wynn, who put the program together. It's obviously great work. All the short poster quick shots are all online, but there was also one from each session that was judged to be shown at the end of each session. So we'll take a quick stretch, and I believe it's going to be Professor Garcia who's going to moderate the first session, and so we'll be back in just a few minutes. Thank you again.
Thank you very much. And thank you.
Great. Thank you very much.
Hi, I'm Dr. Anthony Bozzo, and I'll introduce our keynote speaker, Dr. Livia Garcia. We'll start moving on with the next part of our day. So Dr. Garcia initially trained in Europe and then completed a postdoc in the University of Toronto. She has explored genetics and osteosarcoma and aggressive pediatric cancers, and her work has been featured in Nature Communications and Nature Cell, and she's the winner of R1 grant, and she's the driving force in our research in orthopedic oncology. So it's my pleasure to present Dr. Livia Garcia.
Thank you, Anthony, for the nice introduction. And I also would like to thank the organizers for giving me the opportunity to present some of my lab recent work here today. And I'm looking forward to a nice discussion with you all. And I'm excited to tell you about our recent efforts in trying to decipher epigenetic players in osteosarcoma and bone sarcoma pathogenesis. Can you all hear me? Okay, great. So we're gonna jump. No, there is a new one. No, everything is good. Okay, thumbs up. I'm just gonna give a very quick introduction about sarcomas for people that may not be fully familiar with this family of disease. There is over 160 different histological subtypes of sarcomas, so highly high intratumoral heterogeneity, and they all have in common an origin in the mesenchymal tissue, so they can be found anywhere in the body from blood vessels, lymphatic vessels, fat, muscles, and so on. Importantly, they can be subdivided in soft tissue and bone sarcomas, with soft tissues being the most abundant, and malignant bone tumors representing between 10 to 15% of this type of tumors. And among the bone tumors, primary bone tumors, the most common are osteosarcomas, which in Canada are famous because it's the cancer that unfortunately killed Terry Fox, which is one of our national heroes. So osteosarcomas are disproportionately affecting children, young adolescents, and young adults. And in 20 to 30% of the cases, patients unfortunately succumb to their disease because of metastatic dissemination of these cancers, or because of refractory behavior in the face of chemotherapy and surgery. In the last, I would say, 15 years, we have collected an impressive amount of evidence pointing toward the fact that osteosarcoma is really a disease of aberrant genome structures. I'm happy that before we had the opportunity to actually see my pointer works. Oh yes, to introduce a few concepts about cancer genomics. And so you should be familiar now with this pattern, which represents chromatopsia, which is this shattering of chromosomes that is found very frequently in osteosarcoma tumors, as well as specific pattern of clustered hypermutations, which importantly are not recurrent across patients. They don't specifically point toward your classic tumor suppressor gene or sites of that confer selective growth advantage to that specific tumor. So in summary, osteosarcomas present with extensive structural variants and extensive chromosomal abnormalities that converge on the inactivation of important tumor suppressor genes like p53, RB, BRCA1, and BRCA2, which are known drivers of this type of disease. Importantly, though, all the structural variants that we have been able to identify in osteosarcoma do not correlate with clinical course, a kind of suggesting the hypothesis that there may be other molecular mechanisms that may explain aggressive features of these cancers like metastasis, chemoresistance, and relapse. So in my lab, we have been looking at one of the most understudied levels of genomic regulation in bone sarcomas, which is the chromatin landscape. As you probably know, chromatin modification on histone proteins are very important to shape the transcriptome in normal and pathological conditions in bone and in general during development. And I don't want to go into too much details in this presentation, but I just want to focus your attention here on the octamer of a nucleosome formed by histone proteins and the DNA wrapped around it. As you can see, there are these little protruding N-terminus domains, which are the site of post-translational modification of histone proteins. So today I'm going to talk mostly about this lysine residues that's called lysine 27 or K27, which is a site of modification by methylation or acetylation, and in presence of methylation deposited by this complex, which is called PRC2, genes are silenced. So when during development, progenitors or stem cells are acquiring their lineage commitment, sets of genes that are supposed to be downregulated and repressed in that lineage are progressively accumulating lysine 27 trimethylation mark to turn off and then be bookmarked for DNA methylation. However, this process, which is common during development, may actually be altered in case of neurodevelopmental syndromes or genetic syndromes where, for example, histone proteins are mutated in the germline, or in specific cancers when these proteins are mutated somatically. Mutation of the lysine 27 induces a global downregulation of the PRC2 complex and an increase in transcription of genes that are supposed to be silenced. This stalls development of progenitor and stem cells, locking them in a condition which is more prone to accumulate following mutations and DNA damage. That said, this is just a quick summary of the whole spectrum of cancers where we detect modification in histone proteins that affect their post-translational modifications. We have brain tumors, head and neck cancers, and as well as some evidence of alterations in bone, benign and malignant bone sarcomas. One thing that I would like to point out is that the number of cases which bear mutations in this type of tumors is actually lower than the tumors that actually present with dramatic loss of lysine 27 methylation, which prompted us to look into possible mechanisms of loss of the lysine 27 M3 mark more broadly in high-grade sarcomas. So we collected a cohort of 55 patients from our hospital, together with a validation cohort of 28 patients, and we detected the expression of this gene that's called the EZH-CHIP, which is an endogenous inhibitor of the PRC2 complex. EZH2 is expressed in 20% of the osteosarcoma patients, and as you can see, at different degrees, and cases that have high expression of EZH-CHIP also have downregulation of the lysine 27 M3 mark. And importantly, I want to point out that tumors that lose K27 M3 mark usually are present in poor responders. And when we compare the lysine 27 M3 mark between biopsy and resection, we see a loss of the repressive mark, as well as when we compare therapy-naive resection and metastasis samples on a cohort level. that takes us to actually ask whether this gene is actually a driver function in osteosarcoma. And we used the classic approaches of knockout and overexpression in two different patient-derived models of sarcomas. And we performed knockout experiments using CRISPR, and we showed that deletion of EZHF in these tumors restores the K27ME3 mark, as well as restores the chromatin landscape. So as you can see here, the chromatin is the lysine 27ME3 mark is a spread when we remove EZHF protein, and is then restricted at very smaller domains in EZHF wild type and EZHF rescued clones. And most importantly, when we implant cells that have been engineered for loss or gain of EZHF in mice, we see a dramatic effect on animal survival, indicating an EZHF is sufficient to induce tumorigenesis in vivo, and is also important necessary in cells that express it to be maintained. Next, we looked at the effect of EZHF on progenitors that are going to give rise to all the connective tissue, which are the mesenchymal stem cells. So mesenchymal stem cells have been engineered to express high levels of EZHF, are blocked in their ability to differentiate into adipogenesis, osteogenesis, chondrogenesis, and they actually acquire an aberrant a disposition to develop in differentiate into smooth muscle-like cells that stain positive for calponin. We also confirmed that this experimental findings bioinformatically using deconvolution and single sample GSCA type of approaches using single cell derived atlases that have been available in the literature, and we detected increases of stem cell signatures physiologically discovered in osteoblasts in cells that have high levels of EZHF. And lastly, we also identified EZHF as a mechanism to sensitize cells to EZH2 inhibitors in vitro and in vivo. So cells that have high levels of EZHF are more sensitive to EZH2 inhibitors to cells that have physiological levels of the protein, which is low levels. And we were recently also able to show this in vivo during the painful paper revisions. So in summary, today I've told you that we discovered a negative regulator of EZH2, EZHF, that is important for K27ME3 deposition, that is ectopically expressed in 20% of osteosarcoma and causes loss of lysine 27ME3. This lysine 27ME3 loss correlates with bad response to chemotherapy and metastasis in our patients, and sensitizes cells to respond to EZH2 inhibitors, which are now in clinical trials for other type of cancers, and may be of help in a subset of patients with osteosarcomas. And with this, I just want to thank all the people that did the real work. I'm just a cheerleader. So especially Waji and Geoffroy, who are the lead authors on the EZHF study, and all our collaborators and funding agencies. And thank you all for your attention. I'll be happy to take questions. Otherwise, in the interest of time, we're going to go quickly to some housekeeping notes for the cancer session. Okay, very good. So we have 9 presenters today in the cancer biology session, and I've been instructed to give you a few introductory notes on how the day is going to work. So in one of the, sorry, this is an extra slide. It doesn't really matter. So this is the most important slide of the day. This is the Q code that you guys are going to use for scoring the presentations. And you'll see that this slide is actually going to come up before each presentation. So you can log right in and score each presentation. Please note that at the bottom of the scoring form, it seems to require your email. You don't have to put your email, so you can just skip that step and go ahead with scoring. There is no opportunities to do this retroactively, so do it, be on the ball, and please, when before focusing on the content of the presentation, open the scoring form so that you can judge in real time. And I'll invite all the presenters to be close by so that we can streamline the rest of the presentations. And yeah, so be interesting. And now I'm going to introduce you our co-chair for today, Dr. Anthony Bozzo. He recently joined the Department of Orthopedic Surgery from the Memorial Sloan Kettering. We are very fortunate to have him. He's a surgeon scientist and has an interest in AI and for predicting outcomes in sarcoma patients. And you'll hear more about his research later on in the day. And today he's going to be helping me introduce all the cancer biology presentations. So I think we're going to go with the first one. So I'm going to leave the floor to Anthony, who's going to introduce the first speaker.
Okay, our first speaker is from plastic surgery. I'd like to call up Varsha Durgampudi for your talk.
Very good morning, everyone. I'm Varsha, and I'll be talking about soluble CD109, an important regulator of epidermal growth factor receptor signaling in head and neck squamous cell carcinoma. HNSCC is the 7th most common cancer worldwide, which affects the squamous epithelial cells present in the oral cavity, lips, larynx, hypopharynx, oropharynx, and nasopharynx regions. So despite many advances in the research and the therapeutic approaches, the recurrence rate still remains substantial with poor overall survival, especially for HPV negative HNSCC. So the epidermal growth factor receptor, which is otherwise referred to as EGFR in this presentation, is overexpressed in almost 70 to 80% of HNSCC tumors and is also correlated with poor overall and progression-free survival. Also, the molecular targeting of EGFR involves using cetuximab, which is an FDA-approved strategy for inhibiting for targeting treatment in HNSCC. So on the other hand, CD109 is a membrane protein which our lab has previously discovered as a pro-tumorigenic protein which promotes SCC tumor growth using animal models. Also, our lab has previously shown that CD109 associates with EGFR and stabilizes its expression levels on the cell membrane, which leads to activated EGFR and AKT signaling and increased tumorigenicity and metastasis in SCC. So our previous findings also showed that the CD109 could be endogenously released from the cell surface by multiple proteases such as purinase, PIPLC, etc. So, which led us to ask the question whether the released CD109 acts differently compared to its membrane counterpart. So, our current hypothesis is that the soluble CD109 exhibits potent anti-tumorigenic properties and inhibits HNSCC progression by opposing the membrane CD109 mediated pro-tumorigenic signaling. My key question is to determine whether soluble CD109 inhibits EGFR activation and responses in HNSCC cells. The clinical significance is that soluble CD109 could be used as a potential prognostic biomarker in HNSCC. Also, the inhibition of EGFR signaling by soluble CD109 might work synergistically with other treatment approaches such as immune checkpoint inhibitors or other targeted therapies, which might increase the effectiveness of therapy and overcome resistance mechanisms. So briefly, methodology was to use the HNSCC cell lines and patient-derived primary cells, which were treated with soluble CD109 protein in the presence or absence of EGF, and the effect on signaling and responses were studied by several techniques such as biotinylation on streptavidin pull-down, immunofluorescence, flow cytometry, and circular wound healing assay. Let's dive into my main results. So the first question we asked is if soluble CD109 regulates the interaction of membrane CD109 and EGFR on the HNSCC cells. So in this co-immunoprecipitation experiment, the CD109 is precipitated from the lysate sample, which contains a pool of other proteins and was Western blotted with EGFR. So in this result, we can see that the soluble CD109 inhibits the EGF-mediated interaction of membrane CD109 and EGFR. So the next question was to check the co-localization of soluble CD109 with EGFR. And in the immunofluorescence experiment, we can see that the soluble CD109 co-localizes with EGFR in FADU cells. Here, Here, his tag is present in the soluble CD109, which was probed by Alexa fluorophore 88, and the EGFR by red fluorophore. So the yellow colocalization is proving the interaction of soluble CD109 and EGFR. So the next question is to check the regulation of soluble CD109 by on EGFR. So by flow cytometry, we showed that the soluble CD109 is decreasing the expression levels of cell surface EGFR levels. And we proved the same result by biotinylation and streptavidin pull-down experiment as well. Also, we observed that soluble CD109 is facilitating the decrease in total EGFR levels by immunocytochemistry. So the next question, now we know that soluble CD109 is negatively regulating the expression levels, but we wanted to check its role in the activation. And we observed that the soluble CD109 is inhibiting the activation of EGFR, as proved by fluorescent Western blotting as well. And we observed the similar result in patient-derived primary cells. And by immunohistochemistry, also, we checked the role on the EGFR degradation, which showed us that it's being promoted. And the nuclear localization of EGFR is being inhibited by soluble CD109. Also, CD44, as we know, it's an important cancer stem cell marker in HNSCC, which is being inhibited by soluble CD109. One of the final results is that soluble CD109 also inhibits cancer cell migration. So the take-home message is that we know that the membrane CD109 is pro-tumorigenic. However, the soluble CD109 opposes this membrane CD109 mediated pro-tumorigenic in HNSCC cells. Thank you so much for giving me this opportunity, and I'm happy to take any questions.
We're going to move to the next speaker. Thank you. And who is Kusum Tai from Dr. Sverri Lab.
Hi, everyone. My name is Kulsum, and I'll be presenting my project on identifying CAF populations driving therapy resistance in gastroesophageal adenocarcinoma. So GE patients have a 5-year survival rate of about less than 20%. And the current standard of care treatment that's given to a lot of patients is a docetaxel-based chemotherapy known as DCF. And although this is the most effective treatment that has been provided to date, is still one of the main issues that a lot of patients face is recurrence due to either innate or acquired chemoresistance. And along with looking at genomic and non-genomic alterations, the tumor microenvironment has also been shown to have an effect on the response to therapy that many patients will face. And so fire loss being one of the major and most heterogeneous components of the TME have been shown to be chronically activated in cancer and also promote tumor progression as shown below. So CAF heterogeneity and subtyping has been performed for several other cancers, such as breast cancer shown over here. And these CAF subtypes have been given certain functions or have been shown to be even involved in resistance to therapy. In this case, for breast cancer, it was to resistance to immunotherapy. But for GA, this CAF heterogeneity and subtyping is still unclear. And so our goal for this project is to identify the CAF population heterogeneity in GA and also understand the underlying mechanisms that for this CAF-induced chemoresistance and correlating that to patient chemo response. So to do this, we performed single-cell RNA sequencing on both pre-treatment and mid-treatment biopsy from 26 patients. And we then performed CAF subtyping and looked at several markers that were associated to chemo response, and then validated that in multiplex IF on the patient's biopsy tissue, as well as on primary fibroblasts derived from the patients directly. And alongside with the single-cell RNA sequencing, we also performed or established a 3D CAF organoid co-culture model in order to better understand the tumor and CAF interactions and how that may confer resistance. So just an overview of the patient cohort. We have a complete patient cohort of about 48 patients based off of pathological response as well as clinical response. And we selected them based off their availability of single-cell RNA-seq, as well as their primary fibroblasts and organoids that were isolated. We also show over here that the overall survival and disease-free survival correlates well with the pathological response, where good responders have a greater survival than non-responders. So to develop the single-cell RNA sequencing browser, we selected patients first from our live biobank of 360 patients, and were able to then narrow down, select patients that we wanted to use for this browser. So here is the overview of our single-cell RNA sequencing browser with all the cell types from our patients, and they've been separated by their marker expression and cell type. And here we can see the proportions of each cell type from the different treatment time points that we have for our patients. So we see the 3 time points, which are untreated, mid-treatment, and post-treatment. And just to highlight some major differences between the 3, we see neutrophils arise in mid-treatment more so than the other 2 time points, and fibroblasts more so in the post-treatment section. So in order to perform the CAF subtyping and understanding how heterogeneous they are prior to treatment, we looked at pre-treatment biopsy CAF populations. And we're able to identify 2 major CAF subtypes that have been described in the literature. So we have our myofibroblast CAFs or MyCAFs and inflammatory CAFs, also known as ICAFs. And each of these populations have a distinct gene signature that I show on the panel, the right over here. So for ICAFs, we have PDGFR alpha that is used to define it. And for MyCAFs, we have ACTA2, which over here will define this population. And so we validated these 2 markers on using multiplex IF on a good responder biopsy tissue. So we used 2 sections in order to do our staining. And we have over here in green, we've stained with vimentin, which is a pan-fibroblast marker. We also stained our ACTA2 or alpha SMA in yellow and PDGFR alpha in pink. And then on the second section, we stained for pan-CK, which is a tumor marker, and CD45, which is an immune cell marker. And what we can see here is that the ACTA2 is mostly localized to the stromal component, while PDGFR alpha kind of goes to the periphery of the tumor and closely associates to the immune cell marker. And so the multiplex IF not only allows us to spatially localize our markers, but also allows us to see how different cell types interact with one another. And in addition to this, we also performed IF staining on primary fibroblasts. Over here, we have PDGFR alpha, which we see on the stained on a good responder on the left and a poor responder on the right. And we see a high expression of this marker in poor responders, which may point to a role of inflammatory CAFs in conferring resistance to therapy. And so moving on to looking at the mid-treatment biopsy CAF populations, we want to see whether there was a shift in the MyCAF and ICAF populations. And what we see is that from treatment naive to mid-treatment, we have a greater proportion of ICAFs that are being expressed in the mid-treatment after therapy. And although this was not correlated to response, we do see several markers that are not only associated to response, but also treatment time point. Finally, we also established our organoid calf co-culture that we want to use in order to first understand how calves interact with the organoids. And so what we see here on the bottom is a organoid calf co-culture in a control condition, and we see these network-like connections. And when we treat the co-culture with DCF, which is the treatment of choice, we see that these fibroblasts still have the networks between the organoid and the tumor. So in order to understand better how the fibroblasts are affecting the tumor response, we looked at the diameter as an indicator of tumor survival. And what we see is that in both conditions, the fibroblast allows for the tumor to have a greater growth and allows it to have a greater size as well. So this may point to a role of calves promoting tumorigenesis. And so to conclude, our single-cell RNA sequencing analysis demonstrated two major populations that we have also seen in the literature and several markers that are associated to pathological and clinical response. And our calf co-culture not only shows a pro-tumorigenic role, but also can be used for further validation of markers. And just for future work, we will hopefully be able to identify the spatial localization of candidate markers, as well as validating them in the co-culture model, and to then characterize also post-treatment resection calf populations. And I'd just like to end off by thanking everyone that has supported with this project, and thank you all for listening.
Thank you for your talk. Next up, we have Luisa Fernanda Baca Gonzalez from Urology.
Okay, thank you so much for the introduction. I'll go ahead. By 2023, prostate cancer was the most commonly diagnosed male malignancy in Canada and the third leading cause of death among men. Interestingly, lifestyle components such as diet can also modulate prostate cancer progression and outcomes. This epidemiological study shows that although most cancer sites directly associates with obesity, type 2 and type 1 diabetes, prostate cancer appears as an exception, where a pre-diabetic condition inversely associates with the prostate cancer development. However, a diabetic condition is also linked to increased prostate cancer mortality and also all-cause mortality. Therefore, we are highly interested in better understanding this ongoing conundrum, where a pre-existing diabetes decreases prostate cancer incidence, but it also increases the mortality rate. A plausible mediator of this conundrum are advanced glycation end products, which are the main product of a non-enzymatic glycation reaction, also called the Maillard reaction, which is the product of the binding of a sugar with a protein at body temperature to finally and irreversibly produce AGEs. AGEs are found enhanced in diabetic patients and modulate their activity via the activation of the rate receptor, which subsequently will activate signaling pathways linked to inflammation. In our lab, we harness the Maillard reaction by mixing a diabetes-associated sugar with a circulating protein with a further incubation of 3 weeks at 37 degrees to finally produce AGEs. We validated the production of AGEs through a phenotypic and molecular validation. Initially, we assessed the effect of AGEs in 2 human prostate cancer cell lines, 22RB1 and PC3. By treating them with increasing concentrations of AGEs, we observed that AGEs decrease prostate cancer cell proliferation in a dose-dependent manner. To better understand if this effect was irreversible, initially we treated 22RB1 cells, our most AGEs-sensitive prostate cancer cell lines, with AGEs for 3 days. After that, we performed a treatment switch to control media. Interestingly, we observed that 22RB1 cells after the switch could not recover their proliferative capacity. Although we saw the significant decrease in cell proliferation, this not translated into increased cleaved caspase 3-7 activity, translated into apoptosis induction. Thus, we confirmed that the effect of AGEs did not induce cell death. To better understand the role of the AGEs receptor, also called RAGE, in this phenotype observed, we assessed the basal expression of this receptor across our prostate cancer cell panel. By comparing it with our positive control, we saw no basal expression of this receptor compared with our control, thus suggesting that this receptor was not mediating the phenotype observed. Finally, and to better understand the effect of ages, we perform RNA sequencing. 22RB1 cells treated with ages had a significant upregulation and overrepresentation of senescence-linked genes compared to control, thus suggesting that ages induce cellular senescence. A senescence phenotype is regarded as an irreversible arrest in cell growth. It's characterized by deregulated metabolism, secretory phenotype, and macromolecular damage. To better confirm the senescence phenotype, I assessed for beta-galactosidase activity, one of the most common biomarkers for senescence. After 5 and 10 days of treatment, in 22RB1 cells with ages, we observed a significant increase in the percentage of beta-galactosidase cells, suggesting increased beta-galactosidase activity. Additionally, 22RB1 cells treated with ages had a significant upregulation of P21, a cyclin-dependent kinase inhibitor on charge of the cell cycle arrest at both the translational and transcriptional level, as well as IL-8, a pro-inflammatory chemokine commonly found in senescent cells. This was the same for at the translational and transcriptional level. Thus, we confirmed that ages induced cellular senescence. Therefore, our current hypothesis is that ages induce a synthetic lethal interaction with senolytic agents, which are drugs that selectively target and induce cell death in senescent cells. Senescent cells, as part of the deregulated metabolism, they upregulate pro-survival pathways, including the BCL2 anti-apoptotic family members. Navitoclax, a senolytic, specifically target these BCL2 family components and redirect senescent cells into apoptosis. In our lab, we perform a drug combination assay by treating 22RB1 with ages for 3 days to induce senescence and combining it with navitoclax to target the senescent cells. My dose-response metric results, combined with my growth curve and high single-agent synergy method, all of them confirm an additive and synergistic effect after combining ages per treatment to induce senescence with navitoclax, thus also suggesting a redirection into apoptosis. My conclusions are that advanced glycation products inhibit prostate cancer cell growth through the induction of cellular senescence. This is confirmed by the induction of a senescence phenotype and also by the synergistic effect after combining ages per treatment with the senolytic navitoclax. For my future directions, I will evaluate the effect of ages on prostate cancer progression in vivo. I will demonstrate the ages capability to sensitize prostate cancer to senolytics in vivo, and I will identify essential genes activated by ages to trigger senescence. Overall, I expect that my findings will provide a basis for the development of a much-needed novel treatment strategy capable of inducing exploitable vulnerabilities such as senescence for the treatment of this deadly disease. I want to acknowledge my team, collaborators, and funding agencies, and all of you. Thank you.
Lisa is in time, so we have time for one question. Maybe I'm gonna ask you, so in your cell culture experiment, I noticed some of the cells were not beta-gal positive, but not senescent. So do you think that the senescence induction phenotype is a spectrum of responses, or all the cells are presenting this phenotype? And what do you think could be happening to the other cells?
Yeah, thank you.
So I was just asking about the heterogeneity of the senescence response in the in vitro experiments, and what the hypothesis is that the cells are not turning senescent. What do they do in culture?
Yes, thank you for the question. What we've seen is because we assess different concentrations, so depending on the concentration used, higher concentrations increase the population of senescent. However, it is decreased when we decrease the concentration of the ages used. In this case, what we've seen in the long term, because we perform experiments until 10 days, is that perhaps those cells that are non-senescent continue proliferating. However, those that are senescent remain stable until the end. And that's with we also confirm that with our RNA-seq data, which we'll still see after 10 days, like a population of senescent cells.
Thank you. Okay, thank you. Next speaker is Yifan Wang from Dr. Zogopoulos' lab. Thank you.
Managed to screw up your instructions immediately. All right, good morning, everyone, and thank you for the opportunity to present an interim analysis of our molecular profiling trial for patients with advanced biliary tract cancers. We know that biliary tract cancers are an anatomically heterogeneous group of cancers. And in recent years, we've also learned that these are molecularly heterogeneous groups of cancers. And there's been a lot of interest in trying to develop molecular therapies that target these individual alterations. The purpose of our trial was to perform real-time whole genome sequencing and whole transcriptome sequencing of patients with advanced biliary tract cancers to inform treatment selection and also to serve as a platform for biomarker discovery. Patients with advanced biliary tract cancers who are chemo-naive underwent a percutaneous core biopsy for molecular profiling. They went on to receive first-line gemcitabine-based therapy, and in parallel, their tumor was sequenced with return of results after discussion at a molecular tumor board to inform treatment decisions in second line. Our primary endpoint was one of feasibility, to see if we could return whole genome sequencing results prior to the patient's first restaging CT scan at 8 weeks. Secondary endpoints are as shown and are primarily discovery questions. To date, we've registered 34 patients, of whom 29 have been molecularly profiled with return of results. This shows the cohort demographics. You can see that the majority of these patients had intrahepatic cholangiocarcinomas. And the median turnaround time to molecular profiling results was around 6 weeks. And those patients that required laser capture microdissection for tumor cell enrichment had a bit of a longer turnaround time, as expected. This oncoplot summarizes the landscape of somatic mutations across the cohort. And we can see that the most commonly mutated genes were, as expected, in P53, SMAD4, KRAS. I want to draw your attention to this figure, which breaks down the patients in whom we identified actionable variants, about a third. There are 2 patients with FGFR2 mutations that went on to receive pemigatinib, which is an FGFR inhibitor. And we're also able to access targeted therapies for patients who had a class 2 BRAF mutation, as well as a patient with a HER2 amplification. This is a swimmer's plot showing the cohort. And I think what's interesting here is that you can see that the majority of patients are able to tolerate a fairly meaningful duration of first-line therapy, which is shown in green. But there's really only a minority of patients that go on to receive a meaningful duration of second-line therapy in yellow. I'll draw your attention to the first patient here on the first row. This lady presented with this locally advanced lesion, had reasonable disease control on gemcitabine in first line, but she was developing dose-limiting toxicity. And when we profiled her tumor, we found that she had an FGFR2 activating mutation. Now, FGFR inhibitors have been approved for FGFR2 gene rearrangements, which are typically gene fusions, but there really has not been much data looking at activating point mutations and whether they're sensitive to these inhibitors as well. A handful of case series, but we didn't really have any other treatment options for her, and we were able to access pemigatinib. So she was on pemigatinib for over 2 years with normalization of tumor markers and radiologic evidence of disease response. She had stable disease for 4+ years, and at that point, we considered her for liver transplantation. After a negative staging laparotomy, she underwent her liver transplant 2 months ago. And I think this is only a single case, but it does show the ability for targeted therapies to achieve durable clinical responses to the point where curative intent resection becomes a consideration. I'll finish by switching gears and talking a little bit about how we can use transcriptomic data. This is a graph out of the TOPAZ-1 trial. which recently showed that the addition of durvalumab, which is an immunotherapy, to the traditional backbone of gemcitabine and cisplatin had greater efficacy. But we're talking about a 1-month improved overall survival. It's debatable whether that's clinically significant. So the question is, how do we better select patients who are going to respond to immunotherapy? Our lab has been interested in a 4-chemokine signature, which is derived from whole transcriptome sequencing data. And what we've shown is that patients who have a high C-score, as we call it, tend to have tumors that are more T-cell inflamed, and these tumors respond better to immunotherapy. So then we apply the C-score to our patient cohort. This is a proof of concept slide showing that patients with a high C-score had increased metrics of T-cell inflammation. And when we looked at patients who received immunotherapy in first line, those who had a high C-score, shown in red, tended to have fairly good responses. And the numbers are small, but perhaps with increased numbers, this trend for better overall survival in those patients receiving immunotherapy with a high C-score will mature. So to summarize, real-time whole genome and whole transcriptome sequencing of advanced biliary tract cancers is feasible, but access to matched therapy still remains a challenge. There's really not a lot of patients who receive a meaningful duration of second-line therapy, which is typically when matched therapies come into play. So this provides rationale for moving targeted therapies into the first-line setting. Patients with activating FGFR2 mutations might benefit from FGFR inhibitors, and it should probably be considered for inclusion in clinical trials going forward. And a 4-chemokine transcriptomic signature may be able to help us better identify those patients who are more likely to benefit from immunotherapy. Thank you.
Thank you, Yifan. We do have time for one question.
That was really great work, Ethan. Could you describe a little bit about your sort of the sequencing and analytical pipeline and how you got it down to that short period of time to a clinically relevant timeline? You obviously weren't waiting for other samples. You were burning the cost with one lane, right? Is it all in-house? Is computational aspects in-house, or do you use a facility?
Yeah, so the nice thing about this trial is that it's all in-house at McGill. It is costly because as you mentioned, because we have to turn it around in a clinically meaningful timeframe, we can't batch samples. So it's one and done, one and go. What's helpful is if the tumor cellularity is high enough for us to do bulk sequencing. That saves us a lot of time because laser capture microdissection, as you know, is extremely tedious and laborious. So that saves us about a week's time. So I would say, let's say for a bulk sequenced case, takes about a week for the lab to process, extract the DNA, extract the RNA. We get it sequenced at the genome center. It's on a single chip. We just use it for that one sample. And then the bioinformatics is analyzed in-house as well by bioinformaticians at McGill. So it is costly because it's not high throughput, but that's sort of the reality of having to return these things in a time frame that's meaningful for the patient.
One more question from Dr. Reynolds.
Yeah, beautiful presentation, great work. That's about the chemokine signature. It's really interesting. Is there anything that can be done to improve the chemokine signatures to combine with immunotherapy, so to make somebody with no signature or weak signature into a strong signature and combine the two concomitantly?
Yeah, it's a $1 million question, and I think you alluded to it in your talk as well. How do we make cold tumors into hot tumors? I think what's interesting about the chemokine signature that we found is that initially we were wondering if it's just another way to look at tumor mutational burden, which we know is predictive to some extent of immunotherapy response. But what's interesting is that it's actually not correlated at all. It's about 15% of patients that are chemokine high that have a high TMB above 10. So those things don't mirror one another. So we're not measuring the same things. And so perhaps combining these various surrogates or these various correlates can help us better identify patients who will respond to immunotherapy, because neither TMB alone nor C-score alone is perhaps as good as the combination of the both or combinations of other metrics, I think. Thanks.
Thank you for your excellent work, presentation, and question answering. Next up is Ludovic Moutet presenting his work on the sensitivity of cardiomyocytes to doxorubicin.
All right. Thank you for the opportunity to present my work on uncovering patient-specific responses to doxorubicin using donor-derived cardiomyocytes. So first things first, heart disease is the leading cause of death worldwide and second in Canada. And one type of heart disease is cardiomyopathy, which is a disease affecting heart muscle. And the most prevalent type of cardiomyopathy is dilated cardiomyopathy, whereby the ventricle, the muscle wall of the ventricle thins, leading to ventricle dilation and less blood being effectively pumped to the rest of the body. This is usually a progressive condition and results in heart failure, which has 50% survival after 5 years. There are many causes of dilated cardiomyopathy, such as genetic, alcohol, diabetes, infection, chemotherapy, and many others. But for this talk, we'll focus on the chemotherapy aspect. So anthracyclines, such as doxorubicin, are used in 60% of cancer treatments, and they're used to treat solid and hematological tumor cancers in both adults and children. And just to give a few examples, they can be used to treat bladder cancer, breast cancer, Hodgkin's lymphoma, among many, many others. And this is a very, very effective drug. However, it has a well-known side effect of cardiotoxicity, which damages cardiomyocytes. And this is a very big problem because cardiomyocytes are terminally differentiated, meaning they cannot regenerate. And once we've lost them, that's it. Another issue to remember is that patients respond differently. And actually, a study in Italy has shown that doxorubicin-induced cardiotoxicity occurs in 9% of cases, 98% of which occur within the first year. But these can also occur over a lifetime, as children are also treated with it. So how does this drug actually work in cardiomyocytes? So from animal models, we know that there are 4 principal pathways involved. The generation of reactive oxygen species, mitochondrial dysfunction, DNA damage, calcium overload, as well as other pathways are also present. Inflammatory mediator release, and regulated cell death pathways, autophagy, gene and protein alteration, as well as iron regulatory process interference. And I just like showing this image because it recapitulates what we see in the cardiomyocyte, where with all of these pathways are involved, but we don't really have an understanding of the main pathway, which leads to this cardiotoxicity in humans. So our objectives are to determine the central pathway involved in human cardiomyocytes in response to doxorubicin, and also uncovering patient-specific sensitivity to this drug. And so in order to achieve this, we use induced pluripotent stem cells, which allow us to retain patient genetics and also generate an unlimited amount of cardiomyocytes. Furthermore, to obtain these iPSCs, it is minimally invasive to obtain. And so we don't have to do a heart biopsy to just obtain a small piece of your heart tissue, which I'm sure we'd all prefer to avoid. I personally don't want the needle being stuck in my heart. So we collect blood samples from healthy donors who did not develop dilated cardiomyopathy patients, healthy donors who received doxorubicin but did not develop dilated cardiomyopathy, as well as doxorubicin-induced cardiotoxicity patients. We then isolate peripheral blood mononuclear cells, transfect them with pluripotency factors to obtain our induced pluripotent stem cells, or iPSCs, and we can then go on to differentiating them into cardiomyocytes, which gives rise to these spontaneously beating cells, which is very impressive when you see it the first time in a dish. So we also, if you remember, I said that the cardiomyocytes are terminally differentiated, meaning they cannot proliferate. And so we've actually worked on a protocol leading to the expansion of cardiomyocytes. And this is quite novel in the field. And so once we've expanded these cardiomyocytes, we can then do our injury model where we apply 0.5 micromolar of doxorubicin for 48 hours, and then perform these assays. So viability, metabolic activity, calcium flux, and cell area. So our first positive results come from our expansion, where we see a 2-fold increase in the number of cardiomyocytes per passage, and this is significantly different compared to our negative control. Also, interestingly, we see a change in morphology, whereby our cells initially are very small when we first differentiate them, but then they become larger, which is a suggestion of maturity. And this has also been quite a big issue in the field of iPSC cardiomyocytes. In terms of our results from our injury, in response to doxorubicin across all patient groups, we see that the cells are significantly affected in terms of their metabolic activity. However, interestingly, when we look at viability, in the healthy dox patient group, there is no significant difference in response to the drug. And also, when we look at the cell area, we'll again see no significant difference in our healthy dox control group. So this suggests that there are some pathways, there may be some pathways which lead to cell survival in this patient group. Also, I want to show our preliminary results from our calcium flux. So just what we have done so far. And we can see that the calcium is dysregulated where it becomes faster. The calcium cycling becomes faster. And also it is totally dysregulated in this patient where it's just all over the place. So we're still working on further analyzing these results, but I think it's just pretty cool showing the effects of the drug on calcium cycling. So in conclusion, I have shown a pipeline for iPSC cardiomyocyte generation. I've also shown that our expansion was successful, but that maturity still remains to be determined. Furthermore, we've established an in vitro model of doxorubicin-induced cardiotoxicity and seen differences in metabolic activity, viability, and cell area. And in the long term, this project will allow to study the development of novel therapies that target pathways in cardiomyocytes to prevent doxorubicin-induced cardiotoxicity for already affected patients, and also the optimal selection of cancer patients to receive doxorubicin therapy. I want to thank you for listening and also thank my team without who this wouldn't be possible. Thank you.
Thank you. Thanks. We have time for one quick question. I'm going to ask you one quickly. Did you see the same trends in depending on the sex of the donors of the cardiomyocyte that you used?
Great question. So unfortunately, we haven't been able to do that because we've only done one patient per group so far. So this is in my project plan to keep expanding and at least have more patients in each group so that we can actually have a look at these differences further along the way. Thank you.
Thank you. Okay, I'm gonna call the next speaker, Vala Lamandi from Doctors Lab Lab, Department of Urology. Thank you.
Good morning, everyone. Thank you for the opportunity to present to you today my research project, which is titled Precision Nutrition Increases the Efficacy of Radiotherapy in MYC-driven Prostate Cancer. Now, cancer mortality rates are decreasing. However, metastasis and relapse after surgery and adjuvant treatment still correlate with poor prognosis and represent the most significant challenges in the treatment. And in prostate cancer is not so different, as it was found that 1 out of 4 men who undergo radical prostatectomy they are at risk of developing biochemical recurrence, and 1 out of 10 men with biochemical recurrence are at risk of developing metastasis. Prostate cancer heterogeneity play a significant role in the relapse and the metastasis. This heterogeneity challenges the idea that one-size-fits-all treatment approach can be used for all the patients. Thus, there is an urgent need for personalized treatment strategies. And over the years, several epidemiological studies have been carried out to link diet with cancer. And in prostate cancer, studies have found that every 5% increase of saturated fat intake is associated with 2.8-fold excess risk of prostate cancer mortality. And replacing the energy intake by 10% from vegetable fat is associated with 33% lower risk of all-cause mortality. And in both studies, obesity was not associated with the mortality risk. Highlighting that there is a specific type of fat in the diet is associated with prostate cancer progression. Dr. Labey used the data from the 2 cohort, the HSPH cohort and PHS cohort, and he performed gene set enrichment analysis, and he identified MYC target V1 as one of the top target gene sets that were enriched in the saturated high-fat diet-fed group. And also there was an increase in the hallmark of the DNA repair genes. And when he was investigating the effect of high-fat diet on prostate cancer progression in genetically engineered mouse model that overexpressed the human c-MYC in the prostate epithelium, he observed an increase in the level of the DNA damage in the mice that were fed high-fat diet compared to a controlled diet. So we wanted to leverage that increase in the DNA damage, and we were wondering if we can use that to our advantage to sensitize prostate cancer tumors to ionizing radiation. And indeed, we found that the high-fat diet feeding kind of primed the tumor to the ionizing radiation and improved the tumor response to ionizing radiation, resulting in slower tumor growth rate. So this leads us to our hypothesis that short high-fat diet feeding associated circulating factor in the plasma might be mediating the improved response to ionizing radiation. And in order to validate our hypothesis, first we performed a hybrid in vivo in vitro experiment in which we collected plasma from tumor-free mice that were put on either short duration of high-fat diet feeding or controlled diet. We treated McCap cells in vitro with the plasma. And the first thing that we did is we wanted to see if we are able to recapitulate the induction of the DNA damage. And indeed, with immunofluorescence staining, there was an increase in DNA double-strand break, shown here by the increase in the level of the gamma H2X staining. Next, we wanted to know what are the mediators responsible for the induction of the DNA damage and the synergy to ionizing radiation. So we employed a comprehensive analysis to the plasma. We did lipidomic analysis, metabolic profiling, as well as tissue staining of the liver. So then the first thing we did is we looked at the lipidomic analysis, and untargeted lipidomic analysis identified several species of lipid that was enriched in the high-fat diet treatment. Specifically, there were 3 ceramides that were enriched in the high-fat diet group compared to controlled diet. The later 2 are clinically relevant as they are associated with poor prognosis in patients with prostate cancer. More importantly, hormone profiling showed only increase in serum peptide YY and serum leptin, which shows that there is an increase in the energy intake, and there was no significant increase in insulin level. In addition, tissue staining showed no signs of hepatitis, steatosis, or fibrosis. Lastly, we wanted to know if we use those lipids that we identified in the lipidomic analysis and we added them exogenously to McCap cells in vitro, can we recapitulate the induction of the DNA damage? And indeed, as you can see in the blue dotted line, we did single treatment and then we did different combination of ceramide treatment. And in all the cases, we were able to see induction of DNA damage, but the highest level of DNA damage induction was seen when we used the 3 ceramide together. So to summarize, we saw that high-fat diet induces DNA damage in prostate of MYC-driven genetically engineered mouse model. We also saw that short duration high-fat diet feeding is able to sensitize tumor in MYC-driven prostate cancer allograft mouse model. And the plasma from high-fat diet feeding is able to induce DNA damage in McCap cells in vitro. We also showed that short high-fat diet feeding is able to modify the lipid profile with limited hormonal disruption and hepatic lipid deposition. And when we treat McCap cells in vitro with those unique ceramides, we are able to recapitulate the induction of the DNA damage and the highest level we saw with our combination treatment. So it brings us to our conclusion that ceramide might be mediating the observed enhanced in the DNA damage or compromise in the DNA repair in response to short-term high-fat diet feeding. So for our future direction, we want to dissect the mechanism of the synergy between the high-fat diet and ionizing radiation. And we want to expand our study. So we want to investigate whether short high-fat diet feeding is able to also induce synergy with different DNA damaging treatment other than radiation. And if we understand mechanism, this will hold promise for the development of ceramide-based neoadjuvant therapy potentially leading to improved clinical outcome through enhancement of radiotherapy. Thank you. I would like to acknowledge my lab member and our collaborator and our funding agency. I'm ready for questions. Thank you.
Thank you. I think in the interest of time, we'll have to move on. Next up is Iris Kong from Thoracic Surgery.
Thanks for the opportunity. So gastroesophageal adenocarcinoma is a type of epithelial cell originated tumor that's located either at the distal junction of esophagus or the esophageal and gastric junction. The current standard of care treatment is the docetaxel-based triplet chemotherapy. However, there's a big problem. Around 40% of the patients do not respond to chemo upfront, and half of the initial responder develop to metastatic disease, leaving only 30% of sustained response rate. And currently, there's no established biomarkers or available efficacious alternative treatment options for those patients. So in order to understand that, one approach that we employ is through single-cell RNA transcriptomic analysis. So we recruited 26 patients for the study, and they're characterized into either good or poor response based on their pathologic treatment response. So for patients with tumor regression grade of 0 or 1 are considered as good responders, and for those with TRG 2 and 3 are considered as poor responders. So one of the biggest advantages of single-cell RNA sequencing is that it allows us to study patients' transcriptomic profile at a much higher resolution compared to the traditional bulk RNA sequencing. So we profiled more than almost 13,000 cells, and we can see distinct cell types. For my study, I focus on the epithelial cell population because GEA is an epithelial cell originating tumor type. So here you can see 26 clusters, and each cluster represents a cell population with a distinct transcriptomic profile. So the first question we have is how do we identify clusters of interest? So we did a differential abundance analysis, compare the good versus poor, and look for the clusters that were significantly more abundant in poor responders. We start by doing that for the treatment-naive tumor, and we were able to identify clusters 16, 12, and 0 that were significantly more enriched in poor. And we do the same for the chemotherapy-treated tumor collected at the time of resection. So in addition to the 3, we also identify cluster 7 that were significantly enriched. So then the next question is, what is going on in those 4 clusters? In order to understand that, we perform pathway analysis for individual clusters and focused on the 4 that I previously mentioned. So for cluster 0, the implicated pathway is the regulation of RAP, or for cluster 7 is implicated in neurotransmitter release cycle. For cluster 12 is synaptic classical pathways, and 16 is neurogenesis. So 3 out of the 4 clusters are pointing to the same direction, a neuroendocrinology related pathways. And there are publications out there demonstrating the relationship between neuroendocrine differentiation in adenocarcinoma with chemotherapy response and poor outcomes. So this type of agnostic single-cell analysis led us to hypothesize that there might be a subpopulation within the adenocarcinoma that display a caught neuroendocrine differentiation, and that might play a role in chemotherapy response. So in order to validate that, we use the marker chromogranin A, which is a clinically established neuroendocrine marker with the highest specificity. And when we look at the cells that express this marker in the single-cell data, we can see they're very localized to a specific cluster. So that cluster would have been missed from bulk RNA sequencing. And when we compare the good versus poor at the pretreatment time, we see this cluster were exclusively present in poor responders. So we validate that by doing the IHC staining of those markers on the patient sample. And I think the pattern is pretty evident here. And thanks to the longitudinal sampling method that we use, we're able to compare pre-treatment versus post-treatment. So interestingly, those chromogranin A positive cells are not only increasing numbers, but we also see a higher expression level as well. So again, we took the same patients, compare their pre-treatment IHC versus post-treatment IHC, and we do see this neuroendocrine-like population persist and expanded after chemotherapy. So we can conclude that there is a subpopulation of epithelial cells within GEA exhibits occult neuroendocrine markers, both at transcriptomic and protein levels. And this neuroendocrine population is enriched in pore responder before treatment and persists through chemotherapy. So the single cell RNA data allow us to identify those patients up front. So the next question is, what can we do for them instead? I'm gonna skip through some slides. So we have a model, it's called patient-derived organoids. It's a 3D mini organ that grow in a dish. And we have proved that those models can be used to reflect a patient treatment response. So of course, we're gonna throw whatever drugs available at this model, and we set up a robot to do it. So after the organoids generated and expanded, we plated them in those type of 384 plates. It takes a while for them to grow into a significant number in order for us to screen 3,000 drugs, but we made it happen. Then that's followed by media addition. We allow them to grow in the incubator for 72 hours. Then we perform the high throughput drug treatment. We let them be in treatment for another 72 hours and then evaluate the drug efficacy. So what is interesting is we did that in a pilot study for 3 patient-derived organoid lines, and one of the drug was an mTOR inhibitor that's due on top of the efficacy list. And when we integratively look at the functional drug treatment data with our single cell analysis data, we see the mTOR1 signaling pathway is also enriched in pore responder both at the treatment naive and post chemotherapy level. And we further validate the efficacy of this drug by testing a range of concentration and with combination of DCF. So together, this type of integrative analysis allow us to stratify patients with existing biomarkers, identify those patients up front, and also provided alternative treatment options for them, leading to a better future for those patients. Thank you very much for listening.
Thank you. We're calling the next speaker, Pegah Rahimidet from Dr. Prisby Lab.
Good morning, everyone. First, I wanted to apologize for my voice. I got cold and I'm recovering. Today, I would like to talk about the microRNA sequencing of leiomyosarcoma, identify as a marker of predictive of response of gemcitabine and docetaxel. Leiomyosarcoma is a highly malignant tumor which shows the smooth muscle differentiation. Approximately 10 to 15% of all soft tissue tumors are leiomyosarcoma. And about half of the patients face the local recurrence and distant metastasis within 5 years of diagnosis. Currently, surgery is the cornerstone treatment for this group of patients, and chemotherapy is using as an adjuvant therapy. But no clear guideline exists on who can be more beneficial from the chemotherapy treatment. The combination of the gemcitabine and docetaxel is the frequently first-line treatment for the leiomyosarcoma patient with the advanced disease. And as all of you know, gemcitabine is a cytidine analog, which can disrupt the DNA synthesis, which can lead to the apoptosis in the tumor cells. On the other hand, docetaxel can bind to the tubulin and assembly and promote the assembly and inhibit the assembly of microtubules in the cells, which can lead to the cell cycle arrest. Unfortunately, only a group of patients can only answer and have a good response to this kind of treatment. And right now, there is no clear biomarker for the response to the GemTax in leiomyosarcoma patients. Hence, in our group, we try to identify the microRNA as a predictive biomarker in a patient who are undergoing GemTax treatment, to identify the patient who are most likely to benefit from this treatment, and also to spare the toxicity of drug exposure to the group of patients who are unlikely to have a good response from this kind of treatment. For this, we tried to first collect 35 an archival untreated primary tumor from patients who then underwent the GemTax therapy. All of these tumors were localized at the diagnosis. And among these 35 patients, only 90 patients could respond very well to the GemTax, and 16 patients couldn't respond well. After that, we extracted the mRNA from the samples, and then we make the library and send these libraries to the sequencing facility. After receiving the results, we try to do the bioinformatic analysis, including the differential expression analysis, survival analysis, correlation analysis, and also we try to identify the candidate gene for the target microRNA. As you can see here, when we did the differential expression analysis, we found these 3 microRNAs are significantly upregulated in the non-responder groups. In the next step, we did the survival analysis, and we see that the recurrence-free survival of the patients with low expression of these 3 microRNA has a better recurrence-free survival in comparison to the patients who have a higher expression of these 3 microRNA. In the next step, we try to identify the target genes for the identified microRNA. For this, we try to use the MUTAR-based database, which is the database which has the experimentally validated candidate genes for the microRNA. And we could find this number of candidate genes for these 3 microRNA. When we did the correlation analysis, we see that only microRNA 79, 77 can have a significantly correlation with these 4 genes. For the next step, we try to find the role of these genes, and we see what is the possible role for these genes are. And we see that one of these genes could encode the heat shock protein in the cells, which can be involved in the stress response and also protein folding. Or, for example, the other gene can encode the zinc finger protein, which has the transcription factor function. Also, the other genes have a very important role in the fatty acid metabolism and RNA metabolism. This is the first study shows that these 3 microRNA could be a biomarker for response to GemTax in leiomyosarcoma patient. Our finding could be a variance for further studies to find the mechanism of this identified microRNA in the cohort study group. And in general, we could see that the microRNA, which has the association with the treatment response, could be an early indicator for the clinicians to modify their treatment plans, and also they could minimize the adverse effect of the treatment. At the end, I would like to thank my supervisor, Dr. Pijibil, and all of my lab mates and funding agencies. Thank you for your attention.
Thank you. Our next speaker will be Samira Rahimi Rad from Urology.
Hello, everyone. I'm Samira Rahimirad, and for my presentation today, I will talk about identification of genomic drivers associated with prostate cancer lethality in primary tumor and serially collected cell-free DNAs. A liquid biopsy is a source of cell-free DNAs. They are short fragments of DNA. They release into bloodstream following apoptosis, necrosis, or active secretion. Cell-free DNAs could release into blood not only from normal cells, but also from primary tumor and metastatic cells. And cell-free DNAs that they release into bloodstream from a tumor and metastatic cells, we call them circulating tumor DNAs. Beside prostate-specific antigen or PSA that have been used for diagnosis and monitoring prostate cancer progression, longitudinal collected cell-free DNA also have been useful to detect minimal residual disease, treatment monitoring, and detecting resistance. So with that, we believe that the genomics of primary tumors and serially collected cell-free DNAs will allow the discovery of molecular drivers and predictive biomarkers for lethal prostate cancer. One prostate cancer patient from Procure Biobank was selected, and from this patient, the DNA from primary tumor benign cells and DNA of white blood cell as a source of germline was collected. And also, the patient had 5 years after surgery. The trajectory was 5 years, and plasma was collected serially during his trajectory, and cell-free DNA was isolated from these longitudinal collected plasma. Cell-free DNA were sent for deep whole genome sequencing, and the bioinformatics analysis reported copy number variation, fusions, and mutations. So here, this is the trajectory of the patient. The patient had surgery, and there was a plasma for collecting cell-free DNA available at time of surgery. The case had recurrence short after surgery. And in this plot, the black line shows the PSA, and the blue line shows the testosterone levels. Also, there were following 3 visits available to collect cell-free DNA from this case. And between visit 3 and visit 4, the case had metastatic, and the disease progressed to MCRPC stage. And 6 months after the last cell-free DNA collection, the patient died from prostate cancer. Bioinformatics results revealed genomic alterations in oncogene KRAS, DNA damage response genes, and other genes with clinical significance in this patient. And these germline mutations have been found in all of his biosamples. Regarding the somatic alterations, we were able to compare benign and tumor cells of this patient. And as it is clear, there is no genomic alteration in benign comparing to the matched tumor. By comparing copy number variations in cell-free DNA, 4 visits on top, tumor DNA and benign DNA, we have been found exclusive alterations in tumor DNA that they were absent or detected as subclonal alteration in cell-free DNA at later stage. Also, we have been able to identify shared copy number loss at chromosome 8 in the tumor and later stage cell-free DNA. And most interestingly, we have found copy number gain at chromosome 10 exclusively in later stage cell-free DNA, and amplification at chromosome 8, again, only at cell-free DNA, absent in other time points. Looking into the genes that they were located in the amplified region at chromosome 10, we have been found there are some genes that they role in promoting neuroendocrine and stem cell phenotype. Also, at cell-free DNA later stage, there was amplification in androgen receptor, and this stage was disease at the MCRPC stage. So from copy number variation, shifting gears to mutations, we also have been able to identify mutations exclusively found in tumor, shared in tumor and cell-free DNAs, and exclusive mutations only detected in cell-free DNA at different time points. By color coding the mutations, we have been able to identify clonal co-occurrence and exclusivity at different time points. And like the CNV's mutations that were not detected in tumor, but discovered in later stages suggest a metastatic origin. So to conclude, by tracing genomic alterations, we have been able to identify alterations that they were only detected in tumor, So we believe these alterations important for tumor genesis rather than progression. Also, we found alterations in tumor and all time points of cell-free DNA. These alterations derive from same clones of cells. And interestingly, we found alterations in tumor and only at later stage cell-free DNA. We believe that there is because of the low tumor fraction at earlier stage, or these alterations originate from re-expansion of tumor cells containing these alterations. There are some alterations that we found absent in tumor, but detected at all cell-free DNAs. We believe that these alterations, they originate from clones that they were already beyond the prostate at time of surgery, and they're remaining throughout the progression. And on top of that, and the most interesting ones, they were alterations that only detected at later stage cell-free DNA, and these alterations originated from metastatic, and their nature speak for the different types of prostate cancer cell subtypes, including neuroendocrine, stem, and luminal cell. So these findings clearly speak for the critical importance of longitudinal collected liquid biopsies, and this powerful approach on cell-free DNAs may reveal genomic alterations in driver genes related to the progression and lethality of prostate cancer. And this work will be continued by doing deep whole genome sequencing on more cell-free DNA samples from more cases. With that, I would like to thank the patients that they generously donated samples. I would like to thank my supervisor, co-supervisor, team members, and all of the collaborators. Thank you so much.
Thank you very much. So we're gonna move on to the quick talks from the quick talk submissions. Megan DeMeo from Dr. Spicer's lab. See if you have a presentation here.
Hello, and thank you for the opportunity to present today. Over the years, lung cancer standard of care has evolved with immunotherapies targeting the adaptive immune system. However, innate immune cells can be interesting novel targets because they are first on the scene and much more abundant. Increasing evidence shows that lung cancer can be stratified based on immune infiltrate composition. A subset of patients with high neutrophil infiltration is associated with poor response to anti-cancer therapy and a lower disease-free survival. Moreover, neutrophils promote cytotoxic T-cell exhaustion, thereby promoting a tumor-permissive environment. Immune checkpoint inhibition, ICR for short, was discovered to counteract this interaction. However, response rate is still low. For this reason, we will look at the main neutrophil recruitment axis through the CXCR2 receptor, specifically in the context of lung cancer. Molecular testing of driver mutations is routinely performed when a lung cancer patient is diagnosed. Therefore, we aim to investigate whether linking genetic driver mutation to neutrophil recruitment could be a clinically feasible way to predict neutrophil infiltration in the tumor. We preliminarily found that KRAS mutated lung cancer cells had the highest expression of the most pathogenic CXCR2 ligands. Therefore, we hypothesized that KRAS mutation will be predictive of high neutrophil infiltration, and then inhibiting neutrophil recruitment in KRAS mutated lung cancer will augment ICR in these patients. We used a novel 2D microfluidic device to study immune cell recruitment to tumor cells through chemotaxis. We also used a 3D microfluidic device to model the egress of immune cells from circulation into the tumor. We first found that highest neutrophil recruitment ability was in KRAS mutated cells. When we blocked the mutant KRAS protein in the tumor cells, we saw a specific and significant reduction in neutrophil recruitment. We saw the same statistically significant reduction in neutrophil recruitment when we blocked the neutrophil chemokine receptor CXCR2. To determine whether neutrophil recruitment blockade will increase ICR efficacy in KRAS mutated lung cancer, we load neutrophils at time point 0 hours and cytotoxic T cells at time point 4 hours to mimic the innate versus the adaptive immune responses. After T cells respond, the model mimics a patient presenting to the clinic, and therefore at time point 8 hours, we add ICR. We first found that neutrophil addition to the system significantly reduced T-cell mediated tumor cell killing. We then noted that increased tumor cell killing with the addition of ICI was as expected. Neutrophil addition dampened the tumor cell killing effect that we saw. Finally, the combination of a neutrophil recruitment inhibitor with RCI counteracted the immunosuppressive effect of neutrophils, thereby resensitizing the spheroid to T-cell mediated killing. Targeting the genetic and mechanistic link between neutrophil infiltration and KRAS mutation can deliver a personalized and clinically feasible approach to improve patient selection and efficacy of ICI and neutrophil-directed therapeutics. Thank you very much.
Thank you very much for your talk. Okay. Thank you to all our presenters from this morning. It truly is wonderful to see all the amazing biomolecular research going on here at McGill and in all the labs.
We all did amazing time-wise, so congratulations all, and we can have a 15 minutes break now. Thank you.
Scene 6, in protecting the spermatozoa against oxidative stress and the participation of the peroxyredoxins in the regulation of ROS during sperm capacitation. Dr. O'Flaherty is an accomplished scientist with outstanding publication, peer review findings, and involvement in leadership of journals, learned societies in the field of andrology and reproduction. So today, he will share with us some of his findings in a talk entitled Novel Research Avenues to Tackle Male Infertility. Please welcome Dr. O'Flaherty.
Thank you, Jacques, for the kind introduction. And I want to thank the organizers for giving me the opportunity to share some of the work that we are doing in our lab. So infertility is not a life-threatening condition. However, it produces very significant burden for the infertile couple, not only psychological, but also emotional and economical. That is another problem we are facing in the world, is that infertility, human infertility is rising. The WHO recently submitted a report saying that 1 in 6 people are globally affected by infertility. The prevalence of the infertility worldwide is 17.5%. So it's 1 in 6 couples. We also know now that there are no difference among the regions of the world, with having similar prevalences. And importantly, in those infertile cases, in 50% of them, the causes can be traced to men. Here I show the causes, the known causes of male infertility, but we still are unsure, or we don't know the causes of infertility in 34% of the cases. We know that there are many factors that can influence and can promote or help to promote infertility, like genetics components and all this. But we still need to work in understanding the causes of male infertility. And believe it or not, the evaluation of the infertile men has not changed in over 40 years. We utilize a semen analysis to look for the sperm quality, motility, morphology, and amount, like concentration. We do a physical examination. Well, I'm not doing. The physician do the physical examination, determine the hormone profile, and in some cases, they determine the DNA integrity of the spermatozoa. So the solutions that the infertile couple have are very limited and are mostly assisted reproductive technologies like IVF, in vitro fertilization, and intracytoplasmic sperm injection. But these techniques are costly, have low success rate, lower than 33%, and importantly, put the burden on the woman because it has to be superovulated in order to retrieve the eggs, in order to produce these techniques. So it's clear that we need novel diagnostic tools to identify the unexplained male infertility, and also to design personalized treatments to help a man to father a child. In my lab, we are interested in the molecular mechanisms that drives the spermatozoon to fertilize the oocyte, particularly capacitation, which is the process that allows the spermatozoon to recognize the oocyte and fertilize it. And this information can give us the opportunity to develop diagnostic tools and also to design mild contraception, because those targets that can participate in physiological levels can be inhibited, can be prevented, and then you can have male contraception. And by the way, male contraception is a emerging field again, because there's a lot of demanding of good and effective contraceptives. We are also very interested in the relationship between the gut microbiota and its dysbiosis with the mechanisms that produce fertility. And recently, we started also to develop novel protocols for semen cryopreservation of species that are very difficult to cryopreserve, their semen, and they are, of course, of economical value. So we describe the family of peroxyredoxins that are antioxidants in mammalian spermatozoa. We found it in humans and rodents. And in a study, we, in collaboration with Peter Chan and Dr. Armanzini, we found that idiopathic men or infertile men with varicocele has lower levels of PRDXs and high levels of oxidative stress. And interestingly, the PRDX6 was highly inactive by oxidation in idiopathic infertile men, and almost in 60% of the infertile men with varicocele. We have a model in collaboration with Dr. Aaron Fisher from UPenn, and we characterize the fertility phenotype of these mice. And we found that they are infertile. They have increases embryo losses and pop mortality. Their spermatozoa have significant levels of oxidative stress and poor quality. And this phenotype worsens with age. When we do in vitro fertilization with spermatozoa from these mice, we found that the fertilization rates are reduced and they cannot produce blastocyst, which is usually the embryo that is transferred to the female. So PRDX PRDX6 is the most important antioxidant enzyme in human spermatozoa. I had no time to explain all the work that we have been doing, but utilizing the PRDX6 knockout mouse, we wanted to see if we can restore their fertility by a novel combination of antioxidants. Peroxynitrate, which is one of the free radicals that are produced during oxidative stress, is efficiently scavenged by PRDX6. Therefore, we utilize gamma tocopherol, which is highly efficient to remove peroxynitrate, which is also is more efficient than alpha tocopherol, the other isoform. And what we found is that the PRDX6 knockout mouse that were treated with the antioxidant cocktail have similar number of PAP than wild type, and of course improve for the control. We also be able to reduce the PAP mortality of these PAPs that were sired by these treated animals. We increase motility, and also we decrease the oxidative damage in the DNA of the sperm, in the membranes, in the lipids of the membranes, and in proteins by reducing the levels of tyrosine nitration. So indicating that the treatment was effective to reduce peroxynitrate, because peroxynitrate is the primary free radical that produces tyrosine nitration. We are, as I said, we are interested in sperm capacitation because currently this process is not evaluated at the fertility clinics. So I cannot go through all this slide, but I wanted to point out that we describe the novel lipid signaling in sperm capacitation, which is driven by sphingosine 1-phosphate. And this signal is important to produce nitric oxide that is necessary for capacitation. We also found that the citrate metabolite, which is a hidden metabolite used by spermatozoa, is also important to produce nitric oxide during capacitation. In collaboration with Dr. Ivan Good in UK, we described a novel translational protein modification called coalation, which is the binding of the coenzyme A to the protein that is trying to be oxidized in order to protect from oxidation. So it's an important antioxidant response, and it also participates in coalation in redox signaling, and you will hear from this more about in the next talks. So finally, we recently got a grant to study the gut microbiota testing that has been proposed, but the literature is very scarce and mostly are showing association between the gut microbiota dysbiosis with lower sperm count and sperm motility. So we are very interested in understanding the interrelationship between the gut microbiota and particularly the products that they can able to synthesize in order to see if they have an impact on male fertility. So in summary, we propose that PRDX6 and tyrosine nitration are novel markers for to evaluate oxidative stress, which is also currently not evaluated in the clinic, and that players of the sphingosine 1-phosphate signaling could be used as markers for fertility, but also can be target for male contraception. And that novel antioxidant therapy to treat male infertility is associated with is successful to try to treat infertility associated with oxidative stress. So with that, I'd like to thank all the members that participated in the work, my collaborators, the funding, and you for your attention.
Thank you, Dr. O'Flaherty, for your talk. So we have time for questions for Dr. O'Flaherty. Is there any role for germline alteration or inherent polymorphism or mutation in these pathways that could result in what you have?
Yeah, this is an interesting question. Thank you, Jack. Yes, indeed, there are some mutations that have been described that are associated with infertility. We are looking at mutations in PRDX6 to see whether or not they are. So far, we didn't find it, but we are keen to believe that yes, that could be a cause of infertility because the genetic component of infertility is very important.
Very interesting talk. Can I just ask you what your experimental hypothesis and model is for studying the microbiome and this pathway, please?
Well, we actually, in the grant that I didn't have time to explain, we are focusing on the impact of obesity in male fertility, but through the link with gut microbiota. So we know that there's a rise, an epidemic of childhood and young adults obesity. So I'm very interested in that period of time, that how can it influence the development of the reproductive system. And then when they are young adults, that they will be obese or adult, how obesity, but through the gut microbiota, will impact their infertility. So there's, as I said, there's no many studies done yet, and they are mostly associations, right? So just to say that dysbiosis is associated with low sperm count, it doesn't tell you nothing. But my idea, I propose to start the mechanisms. So through the products of the gut microbiota that are altered because of, in this case, obesity, but it could be diabetes, because my main objective is to study oxidative stress, right? So in obesity and in diabetes, for instance, there are an in vivo and systemic oxidative stress. So we know that oxidative stress promotes infertility, right? But is it the gut microbiota that contribute as a multi-layer factor with this infertility or not? Or if just obesity through the, let's see, cytokines that are released and all the, I don't know, deoxycholic acid, etc., is only the cause. So we think that it's not. And the gut microbiota is involved. I can tell you something. I didn't present because it's preliminary, but we found that when we treat mice with a treatment that produces systemic oxidative stress, we produce dysbiosis of the gut microbiota. And these animals are infertile. And the products that we measure are used by the spermatozoa to produce capacitation. And if I give you an example, if we treat sperm with deoxycholic acid, which is one of the products that you can find in obesity, we impair capacitation, right? So it's clearly that the gut microbiota is playing a role, and who is coming first, is difficult to say at now. But with if we treat it with the unoxidative stress, we produce gut microbiota dysbiosis.
Thank you very much, Dr. Frati, for your talk. And now we will move on with the student session. So remind, yes.
Okay, so as my co-chair, Dr. Lapon says, we have 8 presentations, 6 minutes each, plus questions. And I will introduce the first one, who is Alexandrine Dussault. I will remind you, please, to look for this square box and evaluate each of the presentations.
So, good morning, everyone. My name is Alexandrine, and today I'll talk about the ACL. So the anterior cruciate ligament is at risk of injury during high-impact sports. The standard treatment for ACL injury is reconstructive surgery using either an allograft or an autograft. However, as many of you may know, those grafts are associated with a lot of complications. Most importantly, the reduced mechanical properties of those grafts result in patients often being unable to perform their sport at a pre-injury level, which can result in a new injury and affect their quality of life. A way to resolve this issue is through tissue engineering. Tissue engineering uses a combination of cells, scaffold, and bioactive molecules. In our case, we focus on cell-seeded 3D printed scaffolds. For cells, we use ASCs, adipose stem cells, and HBM MSCs, human bone marrow stem cells. For scaffolds, we are interested in material-derived differentiation. We focus on 3 materials: PLA, a rigid material, and lay foam and lay felt, softer materials made of a flexible rubber-like material called TPE, and PVA, which is a soluble material. Another way of directing differentiation is through cyclical strain based on the principle of mechanotransduction. Mechanotransduction, in simple terms, is the process by which cells convert a mechanical stimulus into an electrochemical response. Many studies show that cyclical strain can induce synergenic differentiation and also promote cell and collagen fiber alignment and density, which are characteristics of ligament. Cyclical strain can also upregulate ligament markers such as tenecin C, which is a major matrix protein, and scleraxis, an important transcription factor for tenogenesis. Also collagens 1 and 3, which are the main collagens in tendons. So this brings us to our hypothesis, which is that MSCs, whether HBM or adipose, seated on PLA and lay foam 3D co-printed scaffold, will have an increased differentiation towards tenogenic lineage, so a differentiation toward a tendon lineage, than standard 2D cultured MSCs. And when those scaffolds are put through cyclical strain, they will also have an increased differentiation compared to the non-strained ones. So briefly for the methods, first part is, of course, to design the scaffolds and co-print them. So we can see here on the outer part, we have the rigid material, the PLA, and on the inner part, we have the lay foam. Then the scaffolds are put in water for a couple of days to wash away the PVA and get the flexible properties of the material. Some of them go for tensile testing. And most of them are seeded with MSCs. And then cell organization is evaluated with live dead, metabolic activity with Alamar Blue, and gene expression with qPCR. And of course, some of the scaffolds are cyclically strained for 3 days, and qPCR is performed on them. So for the result, here we can see scaffolds seeded with ASCs after 14 days. So we have a PLA only, we have PLA only, Layfoam only, Layfelt only, and then the combination PLA and Layfoam, PLA Layfelt, Layfoam Layfelt. So even if it's dim for some, we can see for all the scaffolds, we have a lot of live cells, so a lot of green, and almost no red, so no dead cells. So this is just to show that the cells are do thrive on all of these scaffolds, and even also with the combination of materials. Now for mechanical testing, the most important parameter is rigidity. So we can see for PLA only, we have rigidity that is way too high compared to native ACL, which is the orange band. And Layfoam only is way too low. My scaffolds are somewhere in between. However, they're still too strong for compared to native ACL. But this is just to show that with redesign, more appropriate design, and another ratio of rigid and soft material, we could approach the values of native ACL. Now for material, there are differentiation. We have on the left PLA and Layfoam. So the first 4 markers are the tenogenic markers. We have enough regulation of collagen type 3 and tenascin C for both materials. And we also looked at RUNX, which is a bone marker, and SOX9, a cartilage marker, to make sure that the cells weren't differentiating into other cell types. And we have a downregulation of those markers for Layfoam, but an upregulation of the cartilage marker for PLA. And for the cyclical strain results, we have an upregulation of collagen type 1 and tenascin C. This is only for a Layfoam stretch with a very simple straining protocol. And we see also, as with the material-derived one, a downregulation of the bone and cartilage marker. So in summary, co-printed scaffolds are promising for ligament repair. As we saw, MSCs do thrive on scaffolds. Also, materials and cyclical strain influence gene expression. And with an optimized design and an optimized PLA and Layfoam, so rigid and soft ratio of materials, mechanical properties could approach those of native ACL. So for future work is to, of course, optimize the design to approach better the mechanical properties of native ACL, and also optimize this cyclical strain protocol. Thank you.
Questions? I want to ask you, so what are the next steps in terms of translation your research in the tissue? Is it possible to have models, animal models to try?
Yes.
Oh, okay. So I was asking if what are the future steps for translational medicine in terms of which animal model can be used, and whether or not you are expecting to have reactions in the body that has to be, solved.
Right. So for the animal model, it would be probably a rabbit, because for the knee of the rabbit, it's kind of bigger, so we could use the scaffold at this place. And for the reaction, those materials are biocompatible, so I don't expect a lot of reaction with them.
Any other questions? Yes.
Yeah, very nice work. So is it the cyclical strain that's stimulating the stem cells to go to a tenocyte lineage?
Yes, it's both. It's the cyclical strain, but also just the material by itself, because this is compared to 2D culture with the same cells, and we get an upregulation only with the material, but this is preliminary data, but we still see that it's even better when we also strain them.
Okay, thank you.
Thank you.
Thank you.
Our next speaker from Dr. Philip Lab, Sanya Panami, impaired TGF-beta receptor internalization and associated with reduced TGF-beta receptor 1 caveolin-1 interaction in scleroderma fibroblast.
The green is the forward,
Yeah.
the red aqua, and the point is below.
Thank you. Good morning, everyone. Thank you for the introduction, Dr. Lepoint. I am Sanya Pamnani from Dr. Phillips' lab, and today I'll be talking about impaired TGF-beta receptor internalization associated with reduced interaction with caveolin-1 in scleroderma. First things first, let's talk about scleroderma. Systemic sclerosis or scleroderma is an autoimmune disease which is characterized by progressive fibrosis of skin. The skin, as you see on the left-hand side, is the normal healthy tissue, and that gets converted into thick, dense connective tissue. Now, this is happening mostly because there is an increase in the extracellular matrix protein, which is driven by TGF-beta signaling. TGF-beta signaling, when the TGF-beta ligand comes and binds to the receptors, like receptor 1 and receptor 2, it initiates the signaling cascade by phosphorylating the SMADs. By phosphorylating the SMADs, which then co-localize into the nucleus and activate the genes for fibronectin and collagen. Transforming growth factor is at the center of systemic sclerosis. And by previous studies, we know that this TGF-beta signaling is increased in the systemic sclerosis. But the exact mechanism of this is unknown. And hence, we try to study this, and our hypothesis is that increased TGF-beta signaling in scleroderma is due to impaired receptor internalization and degradation. Our objective was to determine the internalization in the diseased versus healthy fibroblasts and to determine the degradation rate of these. We also wanted to look at caveolin-1, which is an important component of the caveolae that mediates this degradation. There are two distinct pathways how the receptors get internalized. One is the clathrin-coated pit mediated, and which increases the signaling, and the other one is the caveolar mediated, which basically results in the degradation of the receptors. To determine these receptor levels, we radio-labeled the ligand and allowed it to internalize at 37 degrees Celsius. And then we studied the internalized and the surface-bound receptors through gamma counter. So when we looked at the internalization results, we saw that the internalized receptors are more in the healthy fibroblasts, and the surface-bound receptors are more in the diseased condition. This helps us conclude that the TGF-beta receptor internalization is impaired in the scleroderma fibroblasts. Now, further, we wanted to assess the degradation rate, and we used the same radio-labeled ligand and cross-linked it to the receptor to study it on a film, which leads us to these results where we have seen an increase in the protein levels of the diseased the receptors in the diseased fibroblasts. This makes us conclude that the degradation rate of these receptors is also impaired in the SSC fibroblasts. Now, like I already mentioned, that the caveolar pathway is important, and hence we wanted to look at one major component, which is the caveolin-1. When we looked at the expression levels, we can see that in the diseased condition, the expression of this caveolin-1 is severely reduced.
Now, to study this basically brings us to the next question: if this component and the receptors is also interacting, and also if this interaction is impaired. So we did a co-immunoprecipitation assay, and we saw that this interaction is also impaired in the diseased condition. So to summarize my results, we saw that in scleroderma, there are a couple of things that are impaired. One is the TGF-beta receptor internalization, the degradation of these receptors, and most importantly, to study the mechanism, we concluded that the caveolin 1 and the TGF-beta receptor 2 interaction is also impaired. So from my work, we have provided a mechanistic explanation for the increased TGF-beta signaling in scleroderma. And we hope that further studies targeting the caveolin 1 and the receptor 2 interaction will help develop targeted therapies for systemic sclerosis. At the end, I would like to take an opportunity to thank my supervisor, Dr. Annie Phillip, and my lab members, the founding agencies, and the selection committee to give me an opportunity to present. I'm open to questions now. Thank you.
Thank you, Sanya, for your talk. It's now open for questions. You mentioned in your conclusion slide that you would like to use this pathway to target for therapies. Can you elaborate a bit how you envision that?
Yes. So targeted therapies have already been developed for a couple of diseases. Like, for example, there's another targeted therapy called TMDM1, which targets the HER2 receptors in breast cancer cells. So, similar thing can be developed for systemic sclerosis, which targets the receptors, the receptor internalization. And also we feel that caveolin 1 has a major role to play. So something that targets the caveolar pathway can also be used to develop such targeted therapies.
Thank you, Sanya.
Thank you.
Our next speaker is Muskan Alat from Dr. Mwale Laboratory.
Good afternoon, everyone. It is a pleasure to share with you my work today. So intravertebral disc degeneration represent a significant unmet need in the medical field, with surgical intervention being the primary therapeutic approach. As there are no pharmacological-based treatment approved for managing this disease, and it continues regardless the treatment. Pain is the main symptom of disc degeneration that drives the patient to seek medical attention. This is due to the disc ability to induce hyperinnervation, causing release of pro-inflammatory cytokine, causing abnormal sensory input to dorsal root ganglion neuron. This persistent input at the peripheral level causes peripheral sensitization, and further at the central level causes central sensitization, leading to allodynia and hyperalgesia. One of the key drivers of this inflammation and hyperinnervation is the pro-inflammatory cytokine IL-1 beta. The inflammasome is the main factor that drives the IL-1 beta regulation and activation of caspase-1. Activation of inflammasome occurs through stimulation of toll-like receptors and by its cofactor receptor CD14. Various ligands such as damage-associated molecular pattern like matrix fragment and pathogen-associated molecular patterns like lipopolysaccharides causes the stimulation of toll-like receptor by CD14, leading to activation of inflammasome. Our lab works on a peptide known as LINCAN, which represents the 16 amino acid sequence derived from the N-terminal of the link protein, whose active part is known as short LINCAN, which are the first 8 residues of the peptide. It stabilizes the proteoglycan aggregate to hyaluronic acid in the disc, and this peptide is generated in vivo during proteolytic degradation during the tissue turnover. Our lab demonstrated its regenerative potential in a rabbit disc degenerative model. In vivo, a significant increase in disc height was observed 4 weeks after a single injection of S-lincoln, showing its anabolic-like agent. The immunohistochemistry data showed that the disc treated with S-lincoln showed decreased markers of pain. Based on these results, we aim to investigate the therapeutic potential of S-lincoln in modulating inflammasome activity and its anti-inflammatory effect in healthy IVDs. Using the same rabbit IVD model, we investigated the effect of S-lincoln on inflammasome. And as indicated here by IHC, the disc treated with S-lincoln showed decreased expression of the inflammasome marker NLRP3 in rabbit disc. When NP cells were incubated with LPS, a potent stimulator of toll-like receptor 4, which it causes activation of inflammasome factors, as well as inflammatory cytokine. However, co-incubation with SLN decreased their expression at as same as the control level. When NP cells, human NP cells were incubated with LPS, we saw changes in NF-kappa B as well as accumulation of caspase-1, which is active form, and the IL-1 beta secretion. However, when it was co-incubated by our peptide S-lincoln in dose-dependent manner, we saw decrease in activation of NF-kappa B as well as active caspase-1 and IL-1 beta secretion. So to determine if S-lincoln can interfere with CD14 activity, we perform immunoprecipitation experiment, where using dot plot, it was seen that S-lincoln could interfere with CD14 activity by pulling it down. Further, we also perform competitive immunoprecipitation assay with CD14 alone or in presence of unlabeled LPS and S-lincoln, and the Western blot analysis showed that both LPS and SLN were able to pull down CD14, and similar results were also obtained by in silico docking experiment of human CD14 with S-lincoln. It showed that S-lincoln binds in the same binding pocket as LPS on human CD14. So in summary, SLN inhibits LPS-induced NF-kappa B activation, caspase-1 maturation, and IL-1 beta secretion, as well as it regulates inflammasome activation, both in vivo and in vitro. Additionally, it inhibits IL-1 beta-induced effect in these cells through interaction with CD14. So to conclude, one mechanism by which SLN can inhibit inflammation and hyperinnervation of disc is by regulating the inflammasome. In presence of our peptide S-lincoln, this cascade of event which causes inflammation and hyperinnervation of the disc may be dampened or suppressed. Thank you to the audience for listening, and my supervisor and the funding agency. Thank you.
Questions? Do you think that in the disc degeneration there is a component for production of free radicals, and therefore an antioxidant therapy could work in terms to be a coadjuvant therapy with your treatment?
Like a combination therapy?
Yes.
I haven't looked into the radical oxidation stress therapy, but I know that inflammasome gets also activated through that pathway. So recently I'm working on mostly the CD14 driven pathway, but it will be interesting to know about the oxygen free radical. But I know there are other cell types also present in the disc degeneration. So for the further step, before going to the oxidative stress, we will be like to know about all the macrophages and the mast cells which are present in the environment, how our peptide is acting on them. And then that's the other pathway of free radical which can be looked upon. Thank you.
Our next talk is from Navid Nasumi, from Dr. Osha and Dagari, soft force sensor with neural calibration for international robotics.
And this is the point. Okay.
So, good morning, everyone. I'm Navid Masumi, and I'm here to present our study on soft sensors. I have no financial or engagement disclosure to declare relevant to this presentation. So, a little bit of background on the clinical need that we are facing here is that minimally invasive surgery, or MIS, has proven to be a reduced trauma and a really fast recovery method for the patients. And we also know that soft robots have exhibited a really good compatibility with such surgeries, and namely as bronchoscopy and cardiovascular intervention. But the main challenge here for physicians and surgeons is to achieve that high amount of accuracy in terms of sensing and feedback, which is a really critical point for physicians and surgeons in these types of procedures. So usually in these procedures, we're going to need a force sensing in the range between 0 and 2 newtons. And this is really crucial to have this range for the purpose of measurements. And on the screen, you can see a typical procedure of bronchoscopy, where we insert an endoluminal device into the bronchus. And in order to measure that force, we need to have soft sensor on the tip of the endoluminal device that we have here. And also, as we go further into the studies, and as the devices are getting smaller and smaller, we need to have a more accurate sensor. So a background on the sensors. Traditionally, we used to have force sensors like piezoelectric and optical sensors, but today our focus is on piezoresistive sensors. They're really easy to develop. They have a low cost of production, and they're really easy and simple to read all the electronic data from. In terms of functionality, basically what we're trying to have here is to apply mechanical stress on our sensor, and we're going to see some changes in electrical resistance. So these sensors are suitable to sense force, displacement, and chemical sensing. But right now, our focus is just to sense force. Also, these are great options for micro-scale applications like MIS, and they're really easy to integrate to have the high measurement in dynamics. So on the screen, you can see a prototype of our soft sensor. And the main part on our soft sensor, which is here, is the sensing element, which we made it with gelatin and graphite. It's a mixture of gelatin and graphite. This sensing element is surrounded with a soft body of Ecoflex. And for the purposes of validation and calibration, we applied some arbitrary forces on the tip. And based on the fact that I mentioned in the earlier slide, we're going to have 2 sets of voltages, and we're going to collect those sets of voltages data. Then we're going to transform those voltage data to forces into all the directions of X, Y, and Z. So one of the most important steps before using these types of sensors is to have the calibration. So, and the reason behind this is to have the maximum amount of accuracy while having the least amount of noise. So the 2 sets of voltages that I talked about in the last slide, we're going to have to transform them into images. Oh, we're going to have to transform them into images. And we call these images scalograms. And these are basically a graphical way to show the frequency time signals. Then we're going to feed these images to a pre-trained network that here we use a Google network. And what we did here was to reconstruct this network to a network that can kind of fulfill our purposes here. So what we did here was to replace the classifier layers at the end of this Google network with regressor dense layers. And then by feeding these images to the TranslatNet, we achieved the force estimation that we wanted for the force calibration. So in the three directions that I mentioned before, Fx, Fy, and Fz. So for the results, we achieved the resolution of sensing for the forces under 1 millinewton. And also we have an accurate force estimation for the forces between 0 to 400 millinewtons. And one of the most important parts of this study is to have the accuracy of calibration of 97%. So to conclude this presentation, we made a gelatin graphite sensor, which has a really low cost of production. We achieved a high accuracy of sensing, which was the most important part to be able to make this suitable for MIS and endoluminal procedures. And also, we introduced a novel AI-based calibration, which has a low amount of noise while having a high accuracy in force estimation. And in future, we're trying to improve the design of our sensor with extending the areas of sensitivity. We're trying to choose new materials and replace the old materials with more sustainable and while having the compatibility. And also, we're trying to increase the ranges of force sensing. And at the end, I want to thank all my lab members in Super Lab and also my supervisor, Dr. Amir Hushar. I'm open to questions. Thank you.
Thank you. We have time for one question. So what would be the next step to bring this forward, like associate with the company, or how do you put this in place?
Thank you for your question. So right now we have other robots in our lab. So basically soft surgical robots for cardiovascular surgeries or laparoscopy surgeries. So we're going to try to implement this sensor on those robots. And probably the first step would be to initiate the animal study with these types of sensors. Thank you.
So please don't forget to vote. Our next speaker is Matthew Zakaria from Dr. Harvey's lab. You have a forward, back, and then.
All right, hello everybody. My name is Matthew Zakaria, and I'm here to present some interesting research from our lab that looks into the effects of PTH therapy along with cold therapy and how that enhances fracture healing. So first thing to keep in mind, two big percentages, 10% and 40%. 10% of all fractures have been shown to lead to failure in healing, and 40% of fractures have been shown to lead to delay in healing. And now these are mainly due to comorbidities such as health risk factors, environmental factors, as well as the type of fracture and the severity as well. Now, the normal standard that's used is autografts in order to comply with this. However, due to a lack of consistent supply, other alternatives are considered. Now, these alternatives, though, they have conflicting degrees of success and failure. And as such, our lab looked into other possibilities through research and through looking into observations made. And one interesting observation was the development of bony overgrowths within ears of surfers that were exposed to cold exposure for a brief period of time. So then afterwards, we incorporated this into a cortical femoral fracture model. And therefore, we then were able to show that there was enhancement in the fracture healing process. But more specifically, there was an increase in the mineralization, as you can see here. And this was especially profound within femoral fractures, as there was an increase in the formation of bony callus formation. And then this led us to undergo a collaboration with a lab at the Lady Davis Institute to look into the expression of calcium sensing receptors, which are essential when it comes to osteoblast uptake of calcium and mineralization. And we were able to show that there was an increase in calcium sensing receptors within the bone injury site of both cortical defects and femoral fractures, and that this might have a big implication as to how it might be used in a synergistic way. And this is what made us consider the possibility of incorporating PTH, also known as parathyroid hormone, into the regime. And the main reason for this is that PTH receptors are found on osteoblasts and are essential when it comes to osteoblast differentiation, as well as for regulation of calcium. So with this in mind, several studies have shown that PTH injections has led to an enhancement of fractures. And this is mainly due to the incorporation or the extension of this anabolic window that therefore leads to a facilitation of the osteoblast process. And therefore, this creates that positive anabolic effect in the formation of new bone. However, one major downfall is the dosage. And that's one thing that the FDA keeps a close eye on when it comes to regulations. And usually the allowed dosage is 20 micrograms per kilogram. However, anything past that leads to a more effective effect. However, there's a severe negative downfall in that the hypercalcemia environment forms, and therefore this can potentially lead to bone cancer and other possible negative effects through a negative feedback cycle. There you go. So more specifically, the incorporation of PTH leads to the facilitation of the osteoblast pathway, which then leads to an enhancement of bone formation, especially within healing and fractures and whatnot. However, that negative effect, the negative effect to keep in mind is that this indirectly leads to the activation of two specific pathways. One is the indirect activation of osteoclasts, which then leads to the secretion of calcium through bone resorption, and therefore creating this hypercalcemic environment, which then leads to the development or the release of endogenous PTH to counteract this. And therefore, it creates a continuous cycle as well as the maintained elevation of calcium levels, which then severely minimize the effects or the positive effects of PTH incorporation. So this is where we think that the incorporation of cold therapy could help, and that it helps. We've shown that it increases the expression of calcium sensing receptors, and that this would then lead to the increase of calcium, specifically calcium uptake within osteoblast, thereby mediating this hypercalcemic effect and thereby maximizing this anabolic window for new bone formation. So with that in mind, our hypothesis is essentially that hypercalcemia from highly concentrated injections of PTH is significantly lowered via localized cold therapy, and formation and mineralization of bony callus is facilitated by cold therapy in conjunction with PTH. Now, when it came to the methodology, we incorporated 4 different groups with C57BL mice. And essentially, the first group consisted of no treatments. The second group consisted of a 40 microgram per kilogram dosage of PTH. The third group consisted of PTH dosage, as well as a cold water bath implication within one of the femoral fractured legs. And then the fourth group consisted of just only cold water treatment. The treatment lasted for 14 days within a bilateral femoral fracture model. And at days 7 and 14, blood was collected. So the results showed that pretty much the PTH and cold group led to a decrease in the calcium levels, thereby negating that hypercalcemic effect that PTH only injections created. And therefore, it meant that there was an uptake of that free calcium, and thereby that reduction of the hypercalcemic environment. Now, when it came to the additionally, micro-CT analysis was done, and we were able to show that the PTH and cold group led to an increase in the mineralization of the fracture region. And this is mainly, we hypothesized that this was mainly due to the increase of the uptake of calcium within osteoblasts, and thereby the increased mineralization in comparison to PTH only group, which did show a significantly larger callus, but less mineralization due to bone resorption. And pretty much what we were able to show was that the decreased calcium levels by the incorporation of cold therapy pretty much pretty much signifies that there was an increased uptake of that free calcium by the elevation of calcium sensing receptors, and therefore the increased mineralization and duration of the osteoblastic anabolism of bone. And lastly, this led to the extension of the positive impacts of PTH treatment, thereby increasing that time window. And so just some concluding remarks. Essentially, we were able to show that the hypercalcemia effect from high dosage PTH was mediated by the incorporation of cold therapy, and that the mineralization of the callus was enhanced from cold exposure. And some future directions we're taking is to emphasize more the role that CASR has by utilizing a CASR agonist, as well as assessing for histological and immunohistological markers such as ALP, CHOP, and calcium sensing receptors. I'd like to acknowledge my supervisors, our collaborators, as well as our lab members for their support and contributions. Thank you.
Thank you. For the sake of time, we will continue with the next speaker.
Thank you very much.
So our next speaker from Dr. O'Flaherty's lab is Chika Onochi. Protein coagulation is a novel post-translational modification involved in human sperm capacitation and antioxidant response.
Thank you for the introduction. Last year, for the first time in several decades, the WHO identified the rising infertility as a public health concern. And this goes beyond a problem for the couple. It has huge implications for the population of several countries, especially here in Canada, where the replacement fertility rate has not been attained in over 50 years. Even more concerning, although male factors contribute to half of all infertility cases, 34% of these men will never know why they are infertile. This is known as unexplained male infertility. And the problem here is that the routine parameters currently available for assessing infertile men, although they are able to detect defects in spermatogenesis or sperm kinetics, they do not include an assessment of the critical role of the sperm, its fertilizing function. Sperm capacitation is responsible for the sperm's fertilizing function. And within the female reproductive tract, the spermatozoa undergoes some additional maturational changes that endows it with the ability to locate and fertilize the oocyte. Before this process can take place, certain decapacitating factors are removed from the spermatozoa, and among several other changes, it results in an increased production of reactive oxygen species. These reactive oxygen species, it's a well-regulated process that ensures that several downstream signaling events can take place that are necessary for capacitation. And these include, for example, early on, the activation of protein kinase A and thereafter its substrate, or later on, an increase in the phosphorylation of tyrosine residues of certain proteins. However, we recently discovered a new kind of modification mediated by coenzyme A. This is known as protein coagulation. It is an antioxidant modification in human spermatozoa. And in this modification, certain proteins are reversibly conjugated to coenzyme A to form a sort of oxidation-resistant complex. And from our discovery, we found that certain proteins are maintained in this modification before capacitation. But upon inducing capacitation, the modification is reversed. And this is where my project comes in, to identify the role of this modification. Since it is mediated by coenzyme A, we believe the biosynthesis of coenzyme A could also modulate capacitation. And therefore, I'm going to identify the effect of altered coenzyme A biosynthesis on capacitation, as well as characterizing these proteins that are prone to this modification. Our experiments we recruit healthy human volunteers and we select the highly motile spermatozoa from the donors and culture them in different capacitating media. For my first experiment, we characterized the coenzyme A biosynthetic complex in human spermatozoa and characterized key enzymes like pantothenate kinase 2 and CoA synthase that are localized to the mitochondria, to the midpiece of the spermatozoa, which contains the mitochondria. And we found that by inhibiting coenzyme A biosynthesis through these enzymes, we could increase capacitation. For example, the phosphorylation of tyrosine residues. There is a significant increase in tyrosine phosphorylation. But even more interesting, earlier on in, did I miss this? Even more interesting, as early as 1 minute into capacitation, there is a significant increase in the activity of protein kinase A, even better than spermatozoa capacitated without coenzyme A inhibited. And the activity of protein kinase A usually wanes off within 60 minutes. But we found that with this inhibition of coenzyme A biosynthesis, there is not a significant decrease in the activity in the phosphorylation of this pKa substrates. Conversely, if instead we promote the biosynthesis of coenzyme A, there is the opposite effect, a reduction in capacitation, the tyrosine phosphorylation, as well as a reduction in the phosphorylation of pKa substrate and the kinase activity. So the question is, how is coenzyme A mediating these activities? If we take, for example, protein kinase A that catalyzes the initial step of capacitation, it exists as a tetramer, two catalytic subunits that are regulated by two regulatory subunits. Based on our previous finding that certain proteins, 45 kilodalton proteins similar to these units exist correlated before but not during capacitation, we propose that the tire groups of these regulatory units that are prone to oxidation exist in this protected form. But upon inducing capacitation, there is certain yet to be identified players who are responsible for reversing the modification and therefore exposing the tire groups to oxidation. And oxidation promotes the dissociation of these regulatory units, freeing up the catalytic units to regulate the downstream phosphorylation cascade. And so far, we have observed that by inducing capacitation with mild oxidative stress using 50 micromolar hydrogen peroxide, there is an increase in the phosphorylation of pKa substrate, as well as an increase in the formation of this dimer of the regulatory subunits. So in conclusion, what has my project found so far? That coenzyme A biosynthesis through protein correlation is a negative regulator of capacitation. So in this sense, it is a decapacitating factor that the spermatozoa has to surmount to reverse before capacitation can take place. And our future studies would characterize the key proteins that are prone to this modification. And how is this relevant? The problem right now is there are no suitable tools for assessing sperm function, sperm capacitation. So since protein correlation and levels of coenzyme A of correlated proteins are decapacitating factors, we could use this as a prognostic indicator of how likely spermatozoa will undergo capacitation. I'd like to acknowledge our volunteers who participated, my supervisor, Dr. Flaherty, and our collaborators and my lab members. Thank you too for listening.
Thank you for your talk. So for the sake of time, we'll move for the next talk. Thank you.
Our next speaker is Nikita Kalashnikov from Dr. Borsten Bosch Laboratory.
Thank you for the introduction. Forward, backward. So hi, everyone. My name is Nick, and I'm very eager to present my research comparing two biomaterials, one that's called polystyrene block isobutyl block styrene, or which I'll simply refer to as SIBS, and the other material being silicone. I have no conflict of interest to disclose. So if we look at silicone-based biomaterials, I'm sure most of you have used them in your careers. They're used in a lot of our various applications and surgeries, including breast implants, coatings for cardiac pacemaker leads. But 10% of these fail and require revision surgery. And it's become such a prevalent problem in the field of plastic surgery with breast implants that we even have a clinical term that's used to refer to the failure of these implants. And that term is capsular contracture. And in this image, you see a breast implant that is surrounded by this tissue that in some people can get very thick and get very contractile, leading to breast deformity and pain, which characterizes this syndrome and can even lead to breast implant rupture, which you actually see in that image. And that is ultimately caused by the foreign body response, which is the response of the body to any kind of foreign material, including things like biomaterials and implants. It's a complicated response, but really what it comes down to is absorption of proteins, which create a protein coating on the biomaterial surface, which then allows cells to come in and attach on that surface and then engage and respond to that implant to create that capsule. And the two main cellular players are macrophages in the first place. These are immune cells that can attach to the material, respond and sense the properties of the material, and then secrete various cytokines and molecules to then tell other cells to direct their behavior. So that could be promoting inflammation or anti-inflammation, promoting fibrosis. And that leads us to our second key cellular player, which is the fibroblast, which is an important connective tissue cell that is responsible for producing extracellular matrix like collagens, and also can also contract. And I want to highlight one important thing with the light, if I can, right here. In terms of cytokines that I mentioned, TGF-beta could also be produced in that environment around the implant, and that could promote the transition of the fibroblast to a myofibroblast, which has this enhanced functions of collagen deposition and contractility. So if we now switch gears and look at the other material that I'm interested in, that is SIBS, and it's got a very mouthful long name, but really it all comes down to two blocks in that polymer, styrene and isobutylene. Styrene being what's used in the lab often in terms of tissue culture plastic for cell culture, which is very hard and transparent. Isobutylene being more of a liquid-like polymer. And by combining these two blocks together, you can produce a material that is very similar to silicone. Hence why we're interested in perhaps comparing these two materials and replacing silicone with SIBS. And you'd be surprised to hear that it's actually used a lot in clinical practice, especially in drug-eluting stents. So metal wires that form the stents are coated with this material, and they've shown extremely good results, as you all might be aware of, and indicate that there's a very minimal foreign body response going on. And there's also some examples of good responses in glaucoma drainage implants and clinical trials. So the question I'm really interested in is try to see, does these findings in those clinical applications, do they translate to other areas of the body that could be implanted, the material could be implanted to, specifically areas in the body that are more inflammation prone or more immunologically active. So to study this, the first thing I did, that you can see in panel A right there, is I took macrophages and cultured them on my materials that I was interested. And what I noticed based on microscopy, I noticed that cells adhere equally well on SIBS, but are smaller and more elongated on SIBS, which seems to suggest that perhaps there's a phenotypic change going on. And so then I did some genetic expression studies to try to see, do we see some differences? And we do see some differences in inflammatory markers, and genes are a bit upregulated in the SIBS condition. But what was really interesting is that TGF-beta expression is actually lower, which led us to believe that perhaps this could affect fibroblasts. So what we did then is we took the conditioned media from these experiments and gave it to fibroblasts, and then did also some genetic testing. And so what we saw is that the expression of extracellular matrix-related genes were actually not significantly different, which was actually kind of disappointing at the beginning. But then we decided, oh no, I went too far. What was interesting though is that we noticed that inflammatory genes were actually upregulated. And so that was very interesting because it coincides surprisingly with something that's called the senescence-associated phenotype that we've talked about, that we've heard in previous talks about, which might suggest that these fibroblasts are actually perhaps becoming more senescent. And so then I wanted to see if there's functional implications to this. So we took these fibroblasts and now we put them in these collagen gels and let them sit there for a few days with that conditioned media from those macrophages and those SIBS. And what we noticed is that the collagens get smaller, because the fibroblasts remodel the gel and contract the gel. But what was really interesting to see is that contraction wasn't as high in the SIBS macrophage conditioned media condition, which suggests that perhaps the fibroblasts are actually less contractile. So if we take all this information together, there's an interesting story that emerges, is that when we have these macrophages and we put them on this new material, they secrete conditioned media that leads fibroblasts to be less contractile, which has potential, very good potential in perhaps having an alleviated foreign body response that could avoid that capsular formation and that contraction. And so obviously I'd like to validate this in mice in the future. And I'd like to finish off my presentation just kind of a little bit of a call to actions to highlight the role of surgeons in all of this, because surgeons use these materials on a daily and then end up doing revision surgeries, and they have a unique opportunity to go in and do work in the development of these biomaterials to try to prevent, improve outcomes and prevent the need for revision surgeries. And that's it. Thank you for your attention.
Is there any question?
Thank you very much.
Our next speaker from Dr. Haglund Lab is Saber Ghaziadeh. Regenerative approaches to treat disc degeneration and low back pain.
Fraser. Okay, thank you so much. Hello, everyone. I'm Saber, a PhD student under the supervision of Dr. Lisbeth Haglund. Today, I'm gonna talk about the chronic back pain. Chronic back pain is the second most common medical condition in North America and worldwide. 10 up to 15% of all the population suffer low back pain at some point in their life due to intervertebral disc degeneration. So in this slide, you can see a non-degenerated disc, while on the other side, you can clearly see a degenerated disc. This degeneration leads to increased protease production and making an inflammatory environment and loss of some crucial compounds such as cells, proteoglycan, and collagen network in these degenerating tissues, which makes the accumulation of senescent cells in these tissues. But what is these senescent cells? So senescent cells are viable that can no longer divide, and they are releasing a range of proteins and inflammatory factors called as SAS factors. These SAS factors can be triggered by different factors such as aging or even stress. And this stress can be oxidative stress, UV, or DNA damage. My lab previously tested two different senolytic drugs, RG7112 and ovanillin, that can target and eliminate these senescent cells. RG7112 is a pure senolytic drug, and ovanillin is a natural senolytic drug. So after successfully demonstrating the efficacy of these drugs on human samples, now it was time to move to the in vivo model or animal model. So for animal model purpose, we use the Spark null mice, which is a validated animal model of low back pain. And they have progressive age-dependent intervertebral disc degeneration and low back pain starting at 4 months of their age. So the main aim of this study was kind of prevention. So we started at 3 months of their age. We treated them by ovanillin, RG7112, and the combination of these drugs for 5 months. So during that 5 months, we assessed their pain by using the axial discomfort, grip strength, acetone test, and Wonfray test as well. So at the beginning of the experiment, there was no difference between wild-type animals and the Spark animals. But during that 5 months, the Spark animals are getting worse, but wild-type animals remained at the same level. But when we treated them with these single drugs and the combination of these two drugs, we could reduce their pain that they feel. And also we looked at the Wonfray and acetone test, specifically the radiating pain, and we found the same pattern and the same results that I explained for the grip test. Then we came with that questions that can we make some effects on the IVD volume by using and treating these animals with these senolytic drugs? So for this reason, we use the micro-CT technique to measure the IVD volume. So when we look at the wild type and the spark animals, we found that the spark has smaller IVD volume compared to the wild type. But when we treated them with single drugs and combination of these drugs, we could improve these IVD volumes, which the combination showing the best. And the spark null mice is known to have osteopenia. So for that reason, we also looked at the bone parameters in the specifically in the trabecular and cortical part of the vertebral body. So when we look at the trabecular part in terms of bone volume, tissue volume percentage, for example, we found that there was a significant difference between spark animals and wild type animals. But when we treated them with single drugs and combination, we only found the combination was significant compared to the spark group. And also we looked at the cortical part as well, and we found the same pattern and the same results as I explained for the trabecular part. And in the last step, we measured also these inflammatory factors, SAS factors that can be released from the IVDs. We looked at 15 different proteins and inflammatory factors. For example, one of the cytokines and chemokines, interleukin-6 and 6-CL10. There was a significant difference between wild type and spark animals, means the spark has a much higher level of these inflammatory factors compared to the wild type. And but when we treated them with single drugs and the combination of these drugs, we could reduce these level of these inflammatory factors. And this heat map is showing all of the different 15 proteins, the wild type and the spark, and the pattern is following the same pattern as I explained for these two examples. So overall, in conclusion, senolytic drugs have the potential to prevent and improve IVD tissue health and to reduce back pain, which the combination of these drugs may target and eliminate these senescent cells. And I would like to thank my supervisor and my lab mates and the collaborators for their collaboration. Thank you.
Thank you for your talk. Any question? Thank you for.
So now is the time for the 3-minute talk. It will be given by video by Erfran Asghar-Sadeh, and the supervisors are Drs. Hosiar and Baralet. If we can have the video, please.
I have no disclosures to declare regarding this presentation. Robotically assisted laparoscopic surgery offers several advantages over conventional surgery. Using these systems, surgical procedures can be performed remotely. Ergonomic design of these systems allows surgeons to have more productivity and more comfort. Human tremor can be filtered also, and other advantages. Despite all of this, there are a few challenges that we need to address when designing these systems. In laparoscopic surgery, usually instruments are inserted through a few small incisions in the abdomen. The point at which these instruments are inserted to the body is called remote center of motion, as you can see in this image. The instruments are usually manipulated by being pivoted around these points, so we don't want to have big sudden movements at these points to reduce trauma for the patient. Also, as the surgeon is manipulating these instruments inside the body, they are not aware of what's happening outside the body. So there's a risk of collision between robotic arms. Here you can see the overall control scheme that we propose to address these challenges. On the left side, you can see an image of the surgical console that we developed for this purpose. Also on the right side, you can see the robotic arms, the instruments, and the phantom. Due to the redundancy of the robots, we can achieve secondary objectives while performing the main surgical procedure. Here, you can see a block diagram of the proposed control scheme. Motion planning box is where we developed an analytical method to ensure the RCM constraint is met, while the robot follows the desired motion of the surgeon. Also, in the optimization box, we can achieve secondary objectives. Using the proposed method, the robot performed a certain task. Here you can see a visualized multi-body model of the robot and the instrument. These blue lines here represent the surgical instrument at different time steps. As you can see, all of them intersect at the RCM point, which means that the RCM constraint is met. Also here we can see the trajectory of the tip of the surgical instrument in the 3D space for the regular and optimal case. By regular here, we mean that there was no secondary object. For the optimal case, the secondary objective was to ensure that this point of the robot gets close as much as possible to a certain target point in the 3D space. And in this diagram, you can see that throughout the whole trajectory, in the optimal case, the distance to the target point is reduced. And at the end, the distance is 40 millimeter for the optimal case as opposed to 80 millimeter for the regular case. Now, using this method, we can achieve other secondary objectives. For example, we can maximize the distance between different robotic arms. This way, we can avoid collision and improve the safety of the surgical systems. This means we can reduce complications, which ultimately leads to shorter recovery times.
Thank you. Is there any question? Yes, please, go to the microphone. Can you? Yes, thank you.
It's pretty weird, but anyways, so a very nice presentation. On the plot you got on, I think the one to the last slide, the optimized path and the, can you go back?
Yes. No, it's a video, so.
Okay, so anyways.
Video? With the mouse, with the mouse.
Yeah, I think I can just ask it. I just wanted to clarify why that optimized path was reduced, basically. So you had a shorter distance between these two robots, or what? Like, what were you exactly trying to optimize there? I couldn't catch that.
So basically, there were two objectives here. The one that you're mentioning was to make sure that at a certain point of the robot. So first of all, we had one single robot here. So the goal was to make sure that a certain point on the robot reaches a certain point in 3D space. And then when we have this, then we add more robots, second or third robot. And then when we have this, we can make sure that we can define a cost function for the distance of the 2 points on the robot and make sure that they are maximized during the whole trajectory. So there is no collision between them as the surgeon is performing the surgery. Thank you for your question.
Any other question? Okay.
Thank you.
Thank you very much. And so with this, we conclude session B, and now is the time for lunch.
So thank you for coming back after lunch. This is our lunch symposium, but we're not allowed to eat, obviously, in the new Ozer amphitheater. So it's our postprandial lunch symposium. And I thought seeing Professor Reynolds' bio and experience and how broad his experience is, but that it was grounded in, I think, 3 years of training in immunology in the lab, and informs work that's translational, but there's still some basic science work, clinical trials, and of course, as a surgeon, how that inspires our work as scientists. But specifically, and we see in our day-to-day, we have examples, of course, of some more fundamental research. We have translational research, we have innovation, we have clinical research, we have education research. But I wanted this to focus really on, in general, starting just to frame our panel, the really, I think, the unique role for the surgeon scientist, and some of the speakers today actually touched on this a bit. you know, the strength of being able to formulate research questions based on we have a unique experience and opportunity as surgeons. The way that we interact with patients is unique, and it's very direct. And that poses a unique opportunity as surgeons to ask and then to be able to answer research questions based on that experience. Being that bridge, people mention this as well, reframing biologically interesting findings into clinically relevant findings. We saw a bit of that this morning as well. And of course, as surgeons, it could be said that we have the personality, work ethic, and training to lead research teams, and in the same way that surgeons lead teams in other areas like the operating room. But increasingly, the concern and the threat is the increasing complexity of basic science research, the long training period required, growing systemic pressures in funding and so forth on surgeons specifically, and each system has its unique specific threats. So for example, in our neighbors to the south, the surgeons are the economic engine of the hospital, and the time there's a lot of pressure to perform in that way. But if, and so the question is, you know, the academic surgeon, especially running a basic science lab, is really performing two jobs, each of which is arguably a full-time job. As an academic surgeon, clinical care, teaching, administrative duties, mentoring is certainly one job, and running a research program is a whole other job. Getting funding, writing papers, running the lab, the personnel, the HR issues, presenting, traveling, presenting work, supervising students. And then, of course, that doesn't face the rest of life as well. And that's another topic for another symposium. And this is a question that's come up and has been addressed. This is one example. This is a survey from a few years ago from one of the academic research-based specialty societies, SUS. And although 60% of respondents thought that basic science research was a priority, 68% thought it was unrealistic for surgeons to be successful in basic science research in today's environment, including more than half of surgeons who themselves were already successful, meaning they were extramurally funded and running basic science programs. More than half of them didn't think it was realistic for surgeons to continue to follow that path. Some of the themes: insufficient time, inadequate support, lack of their own internal motivation over years, difficulty with funding, and then extrinsic pressures of having two jobs, a work-life balance, which was a higher trend in younger faculty because that sort of shifts. That's very, very relevant. As in the beginning of our careers, we're starting our clinical practice or research programs. It tends to be the time where we have younger families. Administrative responsibilities take on later in one's career. I can certainly speak to that. And that was more of an issue for senior faculty in trying to maintain a research program. And then, of course, clinical demands, that was experienced by everybody. And a declining proportion of surgeons doing basic science research and training. So I did want to say, though, that there are a bunch of Nobel Prizes that have been awarded to surgeons. There's actually 9. But 3 are more in ophthalmology and neurosurgery. But these 6 are Nobel Prizes awarded to surgeons. Coker for figuring out what the thyroid gland does. Alexis Carrel, you know, every vascular anastomosis that we do seems so simple. Someone figured that out. Of course, Sir Frederick Banting from Toronto discovering insulin. Heart catheterization, hormonal treatment of prostate cancer. So endocrine approaches to cancer. That's a surgeon who figured that out. And of course, Joseph Murray, who was the last surgeon in 1990 to receive the Nobel Prize for organ transplantation. So these are all great examples of why we should continue to do this stuff. So I wanted to get perspectives from 3 people at different stages of their careers as surgeon scientists. I asked Dr. Wang to talk to us as someone just entering her adventure as a surgeon scientist to talk to us from that perspective of why she's interested in doing this and taking on these challenges. And then I asked Dr. Kassouf as a senior surgeon scientist to talk about ingredients for success. So answering some of those survey issues, what are ingredients for success that he thinks are important for nurturing surgeon scientists. And then to finally to hear back from Professor Reynolds talking to us about nurturing science as a department head. And then if we have some time for discussion, then hopefully we can touch on any other issues that come up. So I think we're going to start with Dr. Wang.
Thank you, Dr. Feldman. Good afternoon. It's a distinct honor to be part of this lunch symposium today, and thank you all for being here. My name is Yifan Wang. I'm a fifth-year general surgery resident here at McGill. I did my PhD in the lab of Dr. Zagopoulos, and I'll be sharing with you some of my experiences as a surgical trainee, embarking on translational research and some of the things that I've learned. Oh, yes, I have not learned this. Okay, so start with choosing HPV surgery, because it all stems from there. As a first-year medical student, I had the great opportunity to watch a Whipple procedure. It was quite fascinating. Thought it was the greatest thing. A lot of technical finesse, complexity, and pretty much decided I wanted to be a hepatobiliary surgeon. Fast forward to surgical residency, start seeing patients who have pancreas cancer, start seeing patients who have resectable pancreas cancer, who get textbook surgery, who complete all of their adjuvant therapy, and you see them back in clinic a year later and they've recurred. And you see another patient like that, and then one more. And then you start thinking, well, is there even a point to this? And certainly what I didn't know at the time is that I didn't have the tools to even begin to understand a little bit deeper or ask the right questions. But I was fortunate to be training here at McGill, where there are a lot of opportunities for academic development. We have the surgeon scientist program, the clinician investigator program. And we're lucky in Quebec to have really robust career development streams for clinician scientists. And so trying to figure out at this time, well, how can I take advantage of these opportunities to try and learn something about pancreas cancer? And so then, around that time of the year, people start asking you, are you going to do clinical research or are you going to do basic science research? And frankly, for the longest time, I thought I should probably do clinical research. I would be building upon some of the clinical things that I learned during junior residency, and I've done a bit of clinical research in medical school, and I felt like I had somewhat of a foundation. And basic science research was like this. I had not done an undergrad degree. I really had no preparation for lab-based work. So it was quite a steep slope, it seemed. But I took some advice from mentors, and I went to various lab meetings. And when I went to Dr. Zagopoulos' lab meeting, that's when I first got introduced to the concept of translational science, translational research. I really couldn't understand everything that was being said at that first meeting, frankly. I was just trying to keep my head afloat, but I could see that sort of tied back to a patient. And whatever discoveries were being discussed, there was an implication for the patient at the end of the line. And that was pretty interesting to me. So I decided to embark on this translational research journey. And really, my thesis work was really at the intersection of clinical research and basic science research, trying to help accelerate bringing innovation to the patient in a way that's safe and effective. Here's some things that I've learned. I was really fortunate to join a research program that had established infrastructure. When I was joining the lab, the Quebec Pancreas Cancer Study, which is the central research resource in our lab, which is a registry where all patients with pancreas cancer get enrolled to, this was already a mature enterprise. They were up to 1,000 families, biospecimen repository with blood, with tissue, a PDX library, a xenograph library. And there was a whole database of clinical, epidemiological, genetics data. And all this enterprise was maintained by a lot of people, a lot of research coordinators, genetic counselors, lab technicians. And these are the people that helped me get started, taught me, how to hold a pipette, and it all started from there. So I was very fortunate to have this infrastructure to lean on. One of those formative things I think that I learned through pursuing research is the power of collaboration, the value of research networks and consortia. And this cog diagram is just meant to sort of depict a little bit the breadth of the program and all its various components. At a more concrete level, one example I can give you is the COMPASS trial. So we talked earlier a little bit about the biliary tract cancer trial, but this is a sort of a sister study that was run across Canada for patients with advanced pancreas cancer. And one thing that came out of this trial, which was run when I was in the lab, is these molecular tumor boards that were across Canada. So you meet once a month with all these smart folks who are thinking about pancreas cancer and precision oncology across Canada, and talk about interesting cases, talk about accessing targeted therapy. And it was just so valuable to be able to tap into that resource and tap into that knowledge and research power. Another example is the PROCEED Consortium. This is a consortium that focuses on early detection and surveillance of pancreas cancer for high-risk individuals. And it's up to 55 sites now across the world, but it wasn't always so big. I had the opportunity to tag along for the first inaugural meeting, which was in a room like this, with 20 odd people thinking about how we could tackle the problem of detecting pancreas cancer early. And I was a fly on the wall, didn't say anything, didn't do anything, but I was in the room. And every year thereafter, there's been a bigger and a bigger meeting that I've had the chance to go to, and I've had a chance to contribute now in more meaningful ways. But the point is, I was there and I saw how you build a research, get people together to build a consortium, saw how you harmonize a research strategy, harmonize a data collection strategy, see how you engage patient partners, engage industry partners. And those are all invaluable lessons that I was able to learn. I think as a surgical trainee, one thing that's become quite apparent to me is the importance of having a feasible project, that's deliverable within the timelines that we have and the constraints within. And that's not always something that's been apparent to me, especially earlier on in training. So I think that's something that's really important. The other thing is, having a project that has direct patient relevance. We're clinicians, and it's very motivating to see some of the work that we're doing in the lab, quote unquote, actually have an impact on patients. And it can be something really simple. I was really proud to see, when at the HPV tumor board list that gets circulated every week for hepatobiliary, during my time in the lab, we added a molecular tumor board component. Simple thing, but it was a way for our team, our genetic counselors, to return genetic testing results to the providers, for us to discuss as a multidisciplinary team what certain molecular findings, molecular profiling results meant. And just having that little thing there was a win. So I think little wins like that are motivating. Our lab focuses a lot on providing genetic testing to patients with pancreas cancer, and for the longest time, we were doing this in the lab ourselves because there was no funding to do this through the government. And through some of our work and other people's work, in 2022, the RAMQ actually agreed to provide coverage for this type of point of care ordering for patients with pancreas cancer. I think last, but certainly not least, is how important and how lucky I was to have a very, very generous and very broad mentorship that spanned institutions, spanned disciplines. And, you know, when I was preparing for this talk, I was trying to come up with a creative way of illustrating what that meant to me. And I'll share with you one example. So I think in my earlier years in the lab, I had this brilliant idea that I was going to make a metastatic mouse model where I was going to implant tumor into the tail of the mouse pancreas, and then I was going to do a distal pancreatectomy, and then it was going to metastasize to the liver like it does in humans. And why wouldn't it? And then I'd be able to study it and treat those mice. So it was a brilliant idea. And then I worked on it for 3 to 6 months. I can't remember because it's too traumatizing now. And at some point I came to the conclusion that it wasn't going to work. So I went to Dr. Zagopoulos and I said, look, yeah, unfortunately, I don't think this is working. And he said, yeah, I didn't think it was going to, I never thought it was going to work. So I'm not surprised. So, okay. But the point is, he wanted me to try. And it was important for me to try to go through the exercise and to learn from it, learn from the failure, so that I could design a smarter experiment the next time around. And I think having mentorship that allows you to grow, gives you space to grow, but also, you know, make sure that in the bigger picture, you stay on track. And it's been super important for me in my development. These folks on this slide, Dr. Folks, geneticist here at McGill, Dr. Gallinger in Toronto, Dr. Gao, who's now chair of pathology at UBC, and Dr. Simeone, who's now at UCSD, he's a surgeon. Okay, so finished in the lab, and here I am back on clinical service. And you know, I get consulted one day, pretty soon after coming back from the lab. I get consulted to see this patient, young person with pain, and you know, has had a scan, had a PE, and had a CT scan that looked like this. Pretty concerning for metastatic pancreas cancer. So I go see him, I admitted him, I organize a biopsy, started him on anticoagulation, and then I give Dr. Zagopoulos a call. So I did X, Y, Z. That's that. And he said, okay. And the only thing he asked me is, did you sort out bloods for genetic testing? Which obviously I forgot to do, and I did not do. And the point of that is, this is me, you know, a month after coming back from a PhD, just falling directly into the valley of death where research innovation goes to die. And not because I wasn't well trained, but just because, you know, it's, you know, it's not, you're following clinical channels and it's not always obvious, you know, how to think about integrating research in the most effective ways. So sure enough, this patient had a germline CDKN2A mutation. And, you know, it's surgically relevant because we were actually able to enroll, to test his brother and enroll him in our high-risk surveillance clinic. And so this was an important lesson. You know, I think the years after coming back, the senior clinical years are not clinical years, actually. That's what I've learned. They're maturation years. They're years where I've had to learn to take what I know clinically or what I've learned clinically and what I've learned research-wise, just try to put it all together for every patient that I see. And that takes practice. And I didn't do well here, but I'm learning. It's not easy. Professor Reynolds talked earlier about surgeons being bridges to cross the valleys of death, which is good because I put bridges here. But I think, you know, there's a lot of it has been said about how to overcome the valleys of death. And we'll talk about some of these points as we wrap up. Making sure research is patient-oriented at all stages, widening engagement, novel clinical trial designs. Novel clinical trial designs is interesting because, as many of us, some of my colleagues are here, and we read a lot of NCCN this year. And the NCCN has this one section that appears on every single page across every single cancer type. It says that the NCCN believes that the best management of any patient with cancer is in a clinical trial. Well, clinical trials nowadays, this is a paper from a few years ago now, but basically showing the evolution of oncology clinical trials over the past 25 years. And you can see that in the past decade, about 3/4 of oncology clinical trials involve a targeted therapy or an immune agent. So this is pretty much mainstream. And I think it's important for surgeons, surgical trainees, to be at that table for that discussion. Because as surgeons, we can champion some of these efforts and can participate in them meaningfully. We talked a lot about bench to bedside and back. And I think there's another element to that. And it's something that has been really important for our lab, and it's engaging the community. I think that without the community, the bench to bedside, it's hard to make it happen. And what I mean by community is, engaging all the stakeholders, engaging the patient, engaging clinicians, nursing, allied health, trainees across all stages, scientists. We need all of that community to raise those bridges and overcome the valleys of death. So I think it's bench, bedside, and community, and that's really been a focus of our research program is, engaging the community here at McGill and beyond. This is my last slide. So I think there is reason to be optimistic. I think I've learned that hope is not broken. I think as surgeons, we play a really crucial role in catalyzing translational research. Patients put a lot of trust in us. We developed a special bond with them over the years. And over my experiences, it's not uncommon that patients will come to you and say, hey, what do you think? I was asked to participate in so-and-so biomarker trial. What do you think? And it's important that we're part of that conversation and that we help guide those conversations. I think one of the barriers or the perceived barriers about pursuing a career in translational research is, the demands of ultimately running a wet lab oneself. And while that may be true, I would argue that the knowledge and the skill set and the experience gained from being in the lab, for whatever it may be, a year, 2 years, 4 years, gives you a unique perspective and a unique skill set to think about problems a little bit differently. There are many ways that people with this training and with this understanding can contribute. And that doesn't have to be by running a lab. It can be by helping enroll patients in a biomarker-based trial. It can be by participating in a molecular tumor board. It can be by telling your resident to get that genetic testing done. And I think ultimately it's becoming apparent that this is just part of our surgical language now. The same way that you wouldn't operate on a patient without reviewing their CT scan yourself. Well, I mean, there's a radiologist, there's a report, it's finalized, but we still look at the images ourselves because it gives us a deeper understanding of what's going on. In the same way, I think we can review and try to understand the patient's biology. And I think this is coming of age. And finally, I think trainees are a vital part of this translational research community. I think, it's really important to invest in the pipeline. I think ways to do that, and we'll probably discuss it a bit more later, but making sure there's early and longitudinal exposure, the translational research and the impact that that has on patients, and integrating some of these skill sets, how to run a clinical trial, how to write a grant, how to develop a biomarker, integrating these things into the clinical teaching curricula, and that can be helpful as well. So thank you all for being here, and I look forward to this discussion.
Okay, thank you, Leanne, for the opportunity here. Here are my disclosures. And I think when Dr. Feldman asked me to give this talk about success for cellular scientists, I paused and asked myself, well, what is a career success defined? In my opinion, it's probably a combination of clinical excellence, impactful research, contributions to medical education, and leadership. But specifically to the surgeon scientists, I will focus on the sustained competitive extramural funding and publishing the research in high impact journals, because that is probably unique to that specific track. How did I start with this? Well, I think back in residency, there was a 3-month mandatory rotation where you do wet or basic science research. At that time, I did this with Armin Aprikin, who was one of my first mentors and actually continues to have that role as of now, along with Dr. Simone Chevalier, who took me under her wing. What this rotation did, it gave me a bit of a litmus test. That's something that I would like to pursue in a career later on. It channeled to a small publication that as a resident we're all proud of, and started that career thereon. So I did a fellowship at MD Anderson. At that time, I did a 3-year fellowship, 2 years of basic research, 1 year of clinical fellowship. I think if you really want to run a lab, you really need to do at least 2 years of basic research. You need to develop that skill set. You need to be competitive because you are applying and competing against full-time basic scientists in the future. So I came back to McGill, and I would say 12 ingredients to building a surgeon scientist career, and I look forward to hear of other opinions too, is as follows. I think the number one, first thing is environment. You need to work in an institution that's strongly supportive of research. You need to be recruited in a department, in a division that's committed to, but not just committed to, has a track record of supporting and nurturing surgical investigators. You could be successful in a department that doesn't have a track record, but your chance of success is much lower. Number two, start a package. You need to kickstart your laboratory. You need to maintain it for at least 3 years. Why? You need to generate those preliminary results, support applications for competitive grants. You need access to resources, access to shared equipment, grant management staff, technicians, core laboratory facilities, dollars for reagents, salaries, technicians, and so on. And more importantly, try to establish those key collaborators early on. And don't just make it unidirectional. You want to show them what you bring into the table. You want to show the collaborators that they can benefit from you as much as you can benefit from them. Number three, we touched upon that earlier about selection of appropriate mentors. Be deliberate, be targeted. Good mentors are rare, but they exist. Look for mentors with track record of productivity of independent research, a history of mentoring other young scientists, not necessarily the same as your division chair or department chair, but anyone can fulfill that role. And keep in mind, peer mentors or early stage investigators can also be valuable. Build yourself multiple mentors from different departments, disciplines, institutions, and keep in mind, nothing is written in stone. Mentorship network and team may be restructured over time as your needs and goals change over time. Number four, we always advocate for that. Protect your time. You need to be off clinical duties to really focus on a lab. And I would say 50% of clinical duties is a fair number. In my situation, I do not want to take more than that. I felt that I need to maintain that surgical skill set to deliver the best care of my patients, although I would love to continue with lab research. So I think 50% is a nice balance. Some would advocate more. I'm not particularly on that camp. I was lucky to be recruited in a member of a group practice plan, so that helped a bit financially to support my time. But more importantly, we're lucky here in Quebec. I think there's an unparalleled support with the FRQS track that doesn't exist anywhere in Canada. The junior 1, junior 2, senior, they give you solid clinical protection, solid financial protection to focus 50% of your time to what you love. I was fortunate to receive the Chercheur Boursier de Mérite, and that gave me an extra 4 years of protected time. But I think that at the end of the day, once you finish that track, you really need the institution to kick in and support you beyond the FRQS. And I think I'll leave Dr. Feldman and the faculty to discuss that later. So I came back 2006 and started my lab, awarded my first grant 2007, really building on some preliminary data that I had during fellowship. Cancer Research Society, 2 years, formed that basis of our program. Next, I need to build a team. I realized that I'm not going to be there in the lab all the time. I need to have someone reliable, dependable, a partner in crime so that we can kind of grow together. And that's really where I was fortunate and blessed to recruit a senior research associate, Jose Manchur. I recruited Jose in 2007, and we've had a successful, productive partnership since then. And I think that was critical to establishing a growing laboratory. A year later, we were awarded our first CIHR grant, and things start rolling then on. Number 6, open your eyes. That's at different levels. First, embrace novelty. Don't be afraid of challenging dogma. I came from MD Anderson, and I would tell you the only method of bladder preservation is putting in formalin. I came here, I finally met Louis Suhami. Louis Suhami, I don't know if you know him, he's a rat-on, but he has that Woody the Woodpecker style. If you want something, make sure you buy into it over time. And I did. I bought into bladder reservation, I bought into radiation, and I capitalized on them. Based on that, we put together a CIHR grant, and at that time, not many research had gone in bladder, particularly preserving the bladder with radiation. Got awarded our second CIHR grant, 2012, so on. Open your eyes. Another level, find strategic alliances that build your own strength and the strengths of those at your institution. I can say there's 2 people that I reached out to collaborate with. Dr. Chiriaco Piccirillo, he's an immunobiology expert. John Spicer here in the room, he's an expert in electrophysiology and surgeon. We put together some grants and we were successful. Awarded CIHR 2020, DOD 2021, led to high impact publication, Nature Communication 2021, and so on. What about funding? One of the mentors at MD Anderson, Colin Denny, he always mentioned to me, hey, Wes, if you want to catch more fish, you need to throw more poles in the water. And it's true. You want grants? Right. Consider both intramural, extramural funding. Local peer review prior to grant submission, not just for early investigators, even if you're a senior, you can always benefit from that. Don't submit poor grants because you know what? Reviewers will remember you for that. Prepare for rejection. It's possible, but it's actually probable, and it's part of success. Most importantly, you don't give up. Persist. Individual and group grants are equally important. Make use of your networks from cross-appointed basic sciences department. They really write beautiful grants, but you can have that good translational part that they may not be able to do. In my situation, I made sure every single CIHR grant is tagged for a clinical trial that directly translated from my CIHR finding. That resulted in 4 investigator-initiated grants. One of them actually we opened in Canada, UK, and Spain, randomized trial. Every single one stemmed from CIHR grant and partnered with industry to make that happen. Lastly, we founded the prospective Canadian Bladder Cancer Registry, which collected bladder cancer patients across 15 centers and Canadian to help kind of solidify our grant proposal where we have this prospective cohort of valuable patients. This actually was modeled by a successful adventure that Simon Taguay took with kidney cancer, which I learned from and adopted and made it into bladder cancer. Number 8, persevere. I put this quote because I like it. You know, failure is not the opposite of success. It's part of success. Failure is part of the process. Papers will be rejected. Grants will go unfunded. Hospital administration will turn you down. But if you truly believe in your ideas, persevere, don't give up. Number 9, work-life integration. You know, find your own optimal work-life balance. There's no magic formula. If you want academic success, you need to work hard for it. But Make sure the cost is acceptable. Make sure you're surrounded with good social support because it's important, family, friends, and make sure you don't burn out. Number 10, learning to say no, but don't always say no. I really find a willingness to say yes always opens doors. It allows in fresh ideas. It brings in new people into your sphere. But I can tell you, as of now, my no barometer has been going up as I get busier and more senior. Number 11, get involved, get engaged, be present, get involved in multiple research projects, get actively involved in specialty society, not just being a member. Recruit actively clinical trial. They will seek you out after. Be involved in multiple committees. Be a peer reviewer for manuscripts and grants. Balance it out, but you learn a lot from being a peer reviewer. And number 12, don't forget, remember your patients. They are why you do what you do, and they remain the first priority in my mind. Dedication to optimal patient care drives all research, service, and education activities. Academic pursuits should strengthen and never compromise patient care. And lastly, be passionate, share your passion, and more importantly, have fun throughout the process. So, when I prepared this talk, I figured let me canvass a few successful surgeon scientists just to get their opinion, to see if there's something I haven't covered. And I kind of copy and paste some of the posts they emailed me, which I found interesting. Build your network and give to your network. Don't weigh every collaboration. Plan regular meetings with your basic science collaborators and their students. Do not work in silos. Be attentive in clinic and surgery. Non-classical disease behaviors can lead to new research hypotheses. If you fail, try again and again. And if not, they were right not to fund you from the first place. Be nice. It's nice to be important, but important to be nice. Seems simple, but I think it's key to success as it invites and sustains collaboration. Avoid the noise. Check your ego at the door. Make solid collaborations with like-minded collaborators. Put your head down and grind. Give a lot, take a little. Realize some ideas are not ready and need to be abandoned. And lastly, success can only be accomplished with the help from your trainees, which includes students, residents, and fellows. I've put together some references here that help frame my talk as well, and that'd be useful to read if you're interested. Thank you.
I think those are two really amazing talks. I'm very glad they're recorded because I think, they'll be a great reference for many people. And we're going to have Professor Reynolds tell us about how he nurtures science as a department chair.
Thank you very much. So just to echo very much those 12 top tips, fully endorse and agree. But I think what Dr. Wang said is really highlights for me what it's all about. You heard a student who's in the operating room environment. Surgeons are engaging with her and they're seeing something amazing like transplant or Whipple's, in this case from esophageal or whatever, robotic prostatectomy, whatever. They just connect with it. But the environment, the people, the environment creates a stimulus for the surgeon, prospective surgeon, to know more about the disease, the biology of disease, just the competencies required. It's great to see it, and we're seeing it more often. And I'm going to refer basically to a little bit to my own experience and experience in Europe, just for your information and for discussion purposes. But so much of it is down to the individual and medical students nowadays, for me anyway, are much brighter than they were back in my time. And it always astonishes me why the most, academic, bright young people who are fantastic in physiology and immunology and biochemistry and all these things they learn through medical school and ACE understand it, don't almost automatically want to go deeper science when they graduate, rather than just go straight through fast track training programs that skills and competency based, and they have that ability and knowledge. But I understand that is the real world. My kids go mad when I say back in the day, but back in my day, apologies. Everybody had to do research in Ireland anyway. We had to go to America to do research because there was no research going on in Ireland, for a country at the time. And also, even to get on the training program, beyond basic surgical training, you had to do research. So many people who have aptitude or interest had to do laboratory research. I was fortunate enough, and many others, to find a nice home for research in Philadelphia. If I'd gone to my professor a week beforehand, I would have ended up in Boston, working on a burn model in mice, and who knows. So I just was lucky in that regard. Things are very, very different now in that not everybody has to do research. You can get on the surgical training program with 1 or 2 papers, or occasionally none at all. For the college, the Royal Colleges, to administer the training program in Britain and Ireland, there certainly was a time, certainly since the crash, in the early noughties, but even before that, where it was just more convenient to have a kind of a utilitarian model, same for everybody. You don't want people going on to do PhDs and MDs or whatever. It just wasn't. It's easier to manage the way it was, and the senior administration, to their, I'm not proud of it. Really defeated the professors, if you like, in terms of creating that sort of culture. Many people went through that, but I think there was a loss for many, and many people who went through that would acknowledge it. But now things have recovered to some degree, not doing too much. The other thing that's worth mentioning, this is about basic science, nurturing basic science. So think about under the hood of laboratory science, and they've seen some beautiful genomic and immunology work and scaffolding, all that sort of beautiful work that was presented this morning. But a lot of research in Europe, higher degrees of PhDs, is awarded for surgeons who just engage with research. It might be a clinical trial, it might be a PI in a clinical trial, they might have one major publication for a PhD that might be in the New England Journal of Medicine if they're allowed to lead a clinical trial, or they can compile papers that are based on clinical research or clinical audit, and if they're reasonably, cognate and connected and cohesive, then that they can be awarded PhD. So many times I've been in the Netherlands or Belgium or Sweden, I'm sure other European countries, whereby PhDs are awarded for research in a different. It's research about a patient. It's not science as we know it, but it's research, and it's a hugely positive thing. It's a hugely positive thing. So what am I to say? So my background, I'm not going to go through, I mentioned it before, and I was lucky. It just happened to be tumor immunology, and down the road, Stephen Rosenberg and NCI was down the road, and the world was just so exciting about the immunology of tumors and high-dose interleukin-2 and black cells and TIL cells. It was absolutely wonderful time, and Penn was a wonderful institution, Children's Hospital next door, and just their institution. I would just, anyway, had an absolutely wonderful grounding there in my salad days, so to speak, before I went into higher surgical training. And I did it in part because I needed it to get on higher surgical training, and I did it in part because I just felt it was the most natural thing in the world, if you're academic, to go test yourself, discover yourself, do it in the right environment. The thing that's changed hugely from then to now is that the environment is so much better now. As people are doing it with the environment, the structures, the bridges have been built. The best academic centers like here are incredible structures compared to what even the best US centers would have been like 30, 40 years ago. So that's a very powerful thing. Dr. Feldman's talked about this paper, and these are the headline aspects of it. I'm not going to go through it, but I'm afraid it's the same over, and some of it is just real world issues. Young people are different priorities. There's all sorts of things, and we respect individuality and individual choice. and whatever. And this is not sure there's any answers to this, but I do see, in my own world anyway, I do see a recovery. The younger surgeons deciding themselves often, but with proper supports and professors and others and the hospitals, the institutions, the universities, creating the right structures to go back. So I do see a recovery, and I'm very optimistic about that. So what we have to do to enable and nurture science is the surgeon and others create the right structures for alignment of science and medicine in an academic or medical center. And that's really what we try to do. And if the surgeon scientist who wants to do science, we're putting that person into the right structure with right mentorship, right scientific sort of supervision. And a few things that are peculiar to our country, which reflects to Ireland, that reflects an interest in getting structures right to enable more certain scientists and also scientists to do translational research. I'll allude to one is the national program, the Irish Clinical Academic Training Program, national support from the College of Surgeons for Surgical Research Centre, Irish Surgical Research Collaborative, and so the best thing I've done, I think anyway, and was in Trinity in my time, is create structure. So tenure to create the opportunity for us to go from one laboratory scientist to 5 tenured scientists, because that is creating the environment, the training, the potential for supervision, proper supervision on laboratory research for anybody who wants to come in, be it science, be it medicine, oncology, surgery. It's all the same. It's all about research, translational research, and research around the patient. And the other dimension of structure that we've built is with research around patient, and studying that is to bring in physiotherapists, dietitians, nurses, and so on. It won't be over in the lab, but they're doing clinically very, very important research. So a few things that are peculiar to Ireland, and I'm sure you've much the same here, and I think you have from what I heard. Irish Clinical Academic Training is an opportunity for somebody on a training program to do a PhD, and it doesn't have to be surgical. It's usually medical, and so it's a 4-year. It's embedded within the run-through training program. The first year would be predominantly clinical, academic, and writing up the proposal and developing it, and the supervision and everything within it. Year 2 and 4 is predominantly laboratory research, and year 5 you're back on your clinical training program, but you're 20% protected sort of academic time. So as Nicola Raftery, she's about to start with it. She's going to be doing work on circulating tumor cells and hopefully cell-free DNA, particularly in the HER2 population of gastric and gastroesophageal cancers. But she's the first surgeon who's wants to do upper GI surgery. This is an opportunity, it's competitive, and I think she's probably the first GI surgeon to get it. It's only in existence for about 3 or 4 years, and one of our orthopedic surgeon has done it before, but predominantly it's medically, but at least it's an opportunity, it's enabling, it's funded. The other problem we have, and it's better here and in America, is endowments and all of. So we don't have so much of that. So for somebody like Dr. Wang to come to the lab and work with us, we would have to have a grant for you. Whereas we just don't have that sort of culture within the country where we have a lot of money to work with the families and so on. So it's a tough environment. But having said that, it has to be well worked out, funded grants. So it's a good. Another thing that's happened over the last few years is the national centre, it's College of Surgeons of Ireland, the RCSI, and that's the training body. It's also a medical school, and they've set up a national surgical research centre with very good people in it. And the aims is to support trainees in research, and they don't have to be doing laboratory research, they can do clinical research. They don't have to have any protected time. It can be full-on clinical training in general surgery, breast, anything, but they have support to be able to ask research questions and get statistical support, organizational support, and admin support. And it's very, very good, and it's very, very helpful. And it's relatively new, but again, this just reflects the, if you like, the academics within the country, you know, getting some a better environment for surgeons like Dr. Wang who are in our training programs who'd like to take protected time or like to do research with or without protected time, just to enable it. And it's a very positive thing. So my new colleague, Jessie Elliott, only appointed a couple of weeks ago. She has a PhD on GLP-1 and anorexia and survivorship, all that sort of thing I talked about in part this morning. But what this surgical research center is helping her in is a randomized clinical trial. It's called Surround 2. She's the PI for Ireland. Shiraz Mahar, which some of you might know, is the PI for the UK. Jessie's for Ireland and Europe. And so here's somebody who's only just appointed herself, PhD, developed this clinical trial with colleagues, and the national body will help support that and administer it. And that's about to start. So something very positive. Another thing, started by the trainees, the surgical trainees, called the Research Collaborative. They started it. They got together, they have their committee, they have their rotating chairs. They work in conjunction with professors and also with the NCRC support center, run by trainees, and 2 randomized clinical trials. Noel Donald, another colleague, post-PhD, laboratory science, who I've appointed to our center, and he's the PI on one of the trials that relates to different types of wound closure, vacuum-based or standard. So all very, very positive. And this is, you know, I think the young, very bright, ambitious trainees finding a voice themselves through their own group, their own peers, and their own network. It's a really, really positive thing. They're very tight and connected. And I can only see that growing because of structure. These are national structures. The other thing that's very ambitious is all of the universities in the country have got together to create collaboration called Precision Oncology Ireland. So every single university is working together, and within that environment, there's a huge amount of funding and funding potential and actual funding. So again, if a trainee wants to do, you know, state-of-the-art breast cancer research in absolutely leading academic environment, then there'll be opportunities through grants, through Precision Oncology Ireland to do that. Again, it's just that's you know, government funded, and that is again hugely positive. And the final thing, which is again another very positive thing, and this, interestingly enough, originally developed from the Bill Clinton administration and the Trevelyan that existed in Northern Ireland back in the day, and Senator George Mitchell was given some kind of a bridge towards creating what's called the Good Friday Agreement, and kind of thankfully peace in that domain. But with that came a huge amount of US opportunity to fund all Ireland collaboration. So if I want to, based in Dublin, if I want to collaborate with Belfast, Britain, in Northern Ireland, then there's big opportunities through that North-South US funded network as well. So it's called the All Ireland Cancer Research Institute. The reality is that a huge amount of the leadership that exists in Ireland, this mainly in medical oncology and radiation oncology, everybody's come from really wonderful backgrounds in the best institutions abroad. But once you become a consultant, Now, for the first time, you don't have to be a chair, you don't have to be running a lab, but there are mechanisms whereby 50% of your time can be funded through major international cancer society. So, which is again, a very, very positive thing. And more surgeons, certainly two surgeons that are becoming to work with me will get some protected time through funding through this type of organization. So I mentioned earlier on about the bridge, and I do think that what proposes most is to create the metaphorical bridge, but also to build a building between the hospital, between the patient and the science. And in terms of team science, that's all about wonderful scientists that come through, but it's fantastic to see surgeons come and work within that environment and to really advance their career. And all I can say is from personal experience and from anybody I know who's done research and done laboratory research or done a PhD in clinical research is the sooner you do it, the better. And it's never, whether you become a department head or have a lab or a lab of your own, it's never something that diminishes in terms of its real value to you as a professional. You understand the science, which is fascinating, of the disease, of the clinical conditions that your patients struggle through, that you want to both treat and also better understand and make advances. So whether you're a department head or whether you're just supporting research and asking questions and that sort of different role, or some, it's not critical, but that will be my my final words to on that. I hope it's of some value. Thank you.
All right, I think that we probably could talk about this a lot more, but we'll have to talk in the hallway a little bit after, and we're going to move to our afternoon session, which will be focused on outcomes, clinical research and education research. I think Dr. Crump, I'm afraid I don't know who's co-moderating, but I'm sure Dr. Crump will introduce his co-moderator.
Okay, I gotta look up who is cool. Perfect. You want to come up and introduce yourself then? Great.
Hi, everyone. My name is Tony Ahn. I'm a doctoral candidate supervised by Professor Jason Hurley. I will be moderating this session.
Great. Yeah, I think I'm leading off this, here. Nice. Okay. Well, as I say, and now for something completely different. Not only am I not a surgeon, I am also not a wet lab researcher. So you're going to be getting some data and some thoughts, I suppose. But thank you very much for the opportunity to present to you this afternoon. I don't have anything to declare. So today we're going to be focusing on a policy issue, which is probably near and dear to all of your hearts, which is wait times for planned surgical care. And I'm going to I'll probably be using the word planned and elective interchangeably. I apologize for that if I do, but essentially I'm intending them to mean the same thing. Okay, so I first want to start by giving you a little bit of rationale for this work, this presentation. As many of you in the room are probably well aware, we're facing a crisis in terms of accessing surgical services in Canada. The Canadian Institute for Health Information, CIHI, reports on an annual basis the wait time status of 3 elective surgeries, 2 in orthopedics and 1 in ophthalmology. And fewer than 70% of patients in Canada are meeting the appropriate benchmark for care. And let's be honest here, the benchmark is a pretty low benchmark to reach. We're talking half a year to time of surgery for orthopedics and 4 months for ophthalmology. Not exactly what I think most patients would consider timely. And this isn't a new problem. This is something that dates back decades. CAI reports data as far back as 2010, and you can see that the wait times have been steadily trending upwards, and then hit the high road come COVID. But even then, we failed to come back to where we once were pre-pandemic. And this is all despite the fact that we've invested billions of dollars on supply side issues like increasing operating room hours, CapEx expenditures, and new surgical resources, and contracting with private surgical facilities. In fact, the cash bonanza goes back to 2004 when the first ministers met and agreed to a 10-year transfer agreement in order to improve access to care, including surgery. And this has all been for naught. The Commonwealth Fund on the graph on your right demonstrates that Canada is the second worst performing country amongst 11 developed nations in terms of its performance to spending ratio. And that's particularly or especially driven by poor access to care numbers. So it's time to consider other approaches. And one that I'm proposing here today is that we take a look at the demand side for surgical services, and not in lieu of supply side, but in addition to. Now, this isn't all theoretical. We do have a conceptual framework from which we're working. And here I'm presenting data from a research project that is ongoing with the Vancouver Coastal Health Region. This is a project that myself and my colleague Jason Sutherland at UBC started back in 2010. And what this demonstrates are the pre and post-operative health gains, pre and post-operative health status, and the change in that health status as a result of elective surgery. And we, for the sake of brevity, I won't get into the details, but essentially we collect these data using patient-reported outcome measures, both generic and condition-specific measures, at the time that patients are enlisted on the surgical wait list or the surgical registry, and then at the appropriate time after, where we think that the patient should have fully recovered. And what we see in here is these wide variations in health gains, demonstrating that for most patients, or for many patients, surgery has a negligible benefit. Now, this is a concept that my PhD mentors had discussed in a seminal paper over 20 years ago, where they came up with this preference sensitive, which are those clinical situations where there are multiple valid treatments and the variation of the potential risks for harms and benefits exist with each of those options. And it's widely advocated that in these situations, these preference sensitive situations, that the ultimate choice or the best choice should depend on patients' preferences and values for their health. And you could say that plan and elective surgery certainly fall into this preference sensitive context. For many patients, surgery isn't the only option, just the one that where they seem to have landed on. And that patients should weigh the risks of potential benefits for surgery against the options that are available to them. Okay, so getting into some of the demand side solutions. Well, first, what we're talking about here is really better managing the number of patients seeking surgery. And we have to do so within the confines of the Canada Health Act, if not in explicit terms, certainly in explicit terms, and the societal norms that are expected therein. So co-pays, things like cost sharing, those things are obviously off the table. But we can look at prioritizing those patients who would benefit most from surgery, and we can look at setting expectations. So those patients who opt for surgery, they should know that you know, they may not have returned to full quality of life, or they may not have fully restorative function after the procedure. There was a study here a couple of years ago from a group in Alberta that did a systematic review of these different options that are available for wait time management. And I think what two observations that are most relevant to this presentation that come out of that study are one, there's very little empirical evidence to support these demand side options. In fact, if you look closely, you can see it. The study that has the most, or the option that has the most, is just prioritizing patients. The others have literally two studies that have looked specifically at their intervention and the effect that it has on wait times. The second issue that comes out of the study is that wait times are defined very differently across these different studies, and that makes comparison and aggregation very, very difficult. Okay, so that being said, I think there are three potential options that should be considered in a future research program. And the first is informing patients about their treatment options. Now, historically or traditionally, we've done this through patient decision support, like decision aids, decision coaches, or counselors. But these have really failed to gain widespread traction in healthcare systems, in large part because they're costly to update and maintain or staff. And really, there's no obvious place to for those interventions to take place. It's not really meaningful to have them done in a hospital or at the point of at the time of surgical referral, because obviously the decision to have surgery has essentially already been made. And primary care certainly doesn't have the resources to either staff a decision coach or offer decision aids. Some health systems like Alberta Health Services and BC HealthLink offer patient decision aids, but the uptake is very, very small. Now, perhaps future technologies like artificial intelligence, specifically large language models, can offer an alternative, a cost-effective, more efficient alternative to support patients or across the care pathway in understanding their treatment options and the risks associated therein. The second demand side option to consider is to elicit patient preferences. Now, again, conventionally, we would use, say, patient-reported outcome measures or these quality of life surveys to do this, at least to measure, quantify patient symptoms and their functional status and the impact that those have on their quality of life. But those don't elicit patient preferences, and they don't tell you of the many symptoms that they may measure, which ones are most important to patients. And so an alternative could be a sort of a next gen of patient-reported outcomes, called patient-reported outcomes 2.0, where patients are asked to rank order the symptoms and the importance of symptom relief. And that would help clinicians, surgeons set expectations and understand if the procedure is actually going to be of benefit to the patient and meet their preferences. Now, of course, we have operational challenges associated with this because even regardless of what kind of patient-reported outcome you choose to use, whether it's an old one or one of these new generational ones, I think clinicians and organizations really have not yet addressed how they're going to collect this in a systematic and ongoing fashion. There are very few exemplars of groups that are doing this well and on an ongoing basis. And the third and final one is changing the way that we currently triage patients for planned surgery. For the most part in Canada, we use a first in, first out policy where surgeons have some consideration for prioritizing their patients. But this is not exactly the most equitable system. It may be procedurally just, but it is not distributively just. And the other countries are exploring need-based algorithms with which to prioritize their patients, particularly New Zealand and Australia, where they're incorporating other factors aside into how they triage patients waiting for surgery and how those who should be put at the head of the queue. This is probably more aligned with our Canadian values of equity and who should receive healthcare resources, but there are obviously challenges with this as well. Okay, so in conclusion, I think we're reaching our limits in terms of what supply side options and investment in expanding surgical resources can do. Certainly within the confines of the Canada Health Act. I'm not suggesting we go from that debate. And so there's a need for more rigorous research, more strict study designs, examining the potential impact that demand side options can have on better managing patients awaiting surgery. And I think that the three options that are being presented here today, that these are both feasible and realistic for the Canadian healthcare system to implement, and provided that the evidence supports them. Thanks very much.
Yep. So
First up, we have Nagar Mountain on harassment and medical education, psychosocial, psychophysiological perspective through the analysis of electrodermal activity.
Yeah, I think green is part of the country.
Great. All right, everyone. Hi, and good afternoon. My name is Nagar, and I'm very happy and excited to be here today to present to you harassment in medical education. a psychophysiological perspective through the analysis of electrical activity. Medical education is often accompanied by certain challenges and issues, and some of them are more well-known and more talked about, such as the high stakes of patient care, as well as the rigorous demands of learning, to name a few. However, less visible yet highly impactful below the surface exist issues such as harassment. Harassment is an ongoing issue in medical education, with up to 3 out of 4 medical trainees having reported to have experienced at least one form of it. It's been found to have a negative impact on the trainees' well-being, academic success, and also program retention by increasing mental and physical health issues, leading to issues such as job dissatisfaction, as well as higher turnover rate. It therefore becomes critical for us to discuss and explore the effective measures that we could take to not only deal with harassment, but also stop it. Which brings me to the concept of bystander intervention, which is an empowering approach that encourages individuals that are not directly involved with inappropriate behavior that's going on, such as harassment, to intervene. This could take many forms. The bystander could perhaps directly intervene and stop the harassment. They could distract the harasser. They could perhaps seek help from someone with more authority in the room, or they could also check in and support the victim after the fact. In the healthcare system, despite explicit policies and reporting mechanisms and also training programs that include lectures, workshops, and seminars that have been found to be tedious and repetitive and engaging, it creates a knowledge gap. And this knowledge gap highlights the need for more effective and dynamic programs. And to bridge this knowledge gap, our approach integrates simulation-based education accompanied by a series of videos, which aims to train and engage the trainees and residents more effectively. During the simulation, of course, residents may experience a range of emotions, such as excitement, happiness, sadness, anger, or fear. We therefore, and of course, this could affect their learning outcome and performance. And we therefore draw upon Pecker's control value theory, which suggests and posits that emotions that are shaped by one's appraisal control and task value could significantly impact their performance and learning outcome. This theory also posits that emotions are categorized by 2 aspects, such as valence and arousal. Arousal is a physiological readiness of the body in response to certain stimuli, and this has been found to affect memory, decision-making, as well as the retention of knowledge. So certain stimuli, as I mentioned, so they could be internal or external, they could activate the sympathetic nervous system, which in turn increases the circadian activity, which in turn affects the conductance of our skin. And this change in the conductance of skin could be quantified and measured by the signal of electrodermal activity, or EDA, which itself can be categorized into 2 components. One is a tonic component, which slowly varies over time, and the other is a phasic component, which here on I will call as SCR, or as a skin conductance response, which is a direct proxy of the sympathetic arousal. We basically wanted to see in our study whether the arousal level of the residents in our simulation, which is an anti-harassment simulation, is impacted by observing harassment or not, and whether this in turn could affect their decision-making in response to harassment events. So therefore, our study was guided by the following questions. We wanted to see whether medical trainees, one, training sequence group, so whether they were part of a simulation first group or video first group, which I will get into in a second. 2, the time point when their EDA was measured, so whether this was during or after harassment events, or 3, the interaction between the 2 predicted their EDA. We also wanted to see whether medical trainees training sequence group and also EDA during harassment events predicted their likelihood to intervene. As mentioned earlier, our study has 2 experimental groups. One is the video first group, which watched video lectures prior to participating in the simulation, and the sim first group, which experienced these in reverse order. During the simulation, a junior resident was present, who was our participant, while they were completing a central line insertion. A senior resident, who was an actor, was present and was verbally harassing a medical student who was also an actor. Generally, our sims lasted from anywhere from 10 to 12 minutes. Our data channels included video data, which we used to identify and code harassment events initiated by the senior resident, who, as initially mentioned, was an actor, followed by the intervention behaviors initiated by the residents. This was accompanied by EDA data from year 1 and year 2 internal medicine residents, 18 of whom were randomly assigned to the first group and 15 of them were randomly assigned to the video first group. The EDA and video data were then aligned, followed by the EDA processing followed by the EDA processing being completed on MATLAB in order to deconvolve and separate the tonic and phasic component, allowing us to extract the STR variables. Finally, a moving window was applied in order to calculate the average frequency density of SCR peaks per 5-second segment, allowing us to complete a mixed affect multi-level regression for research question 1 due to the nested nature of the data, as well as a logistic regression with cluster robust standard errors for research question 2. So what did we find? We found an increased arousal levels among learners during and after harassment events when compared to their baseline, which suggests a significant emotional impact created by observing harassment incidents. This, of course, reflects the learner's recognition of harassment severity in clinical settings. And we also saw that the video first group exhibited heightened arousal levels during harassment incidents compared to after the harassment, which was likely heightened by prior video training, as they were the video first group, which suggests that a preliminary video that contextualizes harassment can perhaps better prepare the trainees to recognize and address it. This was, of course, seen in research question 2 and supported in research question 2, where video first group was seen to be more likely to intervene in harassment scenarios. And finally, and yet interestingly, we saw that emotional arousal did not predict their intervention behaviors, which suggests to us that factors other than immediate psychophysiological responses may play a more pivotal role in decision-making processes following harassment scenarios. To give you a quick summary, our study ventured into a new territory by using psychophysiological methods to explore harassment effects in medical training on internal medicine residents, and by monitoring EDA during anti-harassment simulations, we assessed arousal levels, and provided a robust methodology for EDA analysis, and also explored the links between harassment, physiological responses, and also bystander intervention methods followed by harassment incidents. This has never been done before, and it's the first of its kind, and we hope, given the prevalence and importance of the issue, to set the stage for advancing anti-harassment training research in the future. Thank you, and thanks to all my. Thank you.
All right, so thank you for that, Megar. I think the next presenter we have is Sasha Williams.
Okay, this is fine. This is not. This one. Yeah, it's not.
This previous speaker stuff. Yeah. Nice. Oh, everything's that I want. Yes. All
right. Good afternoon, everyone. My name is Sasha Williams, and I am a PhD candidate in the Publisher Lab here at McGill. I am happy to have the opportunity to present our work involving gender equity in Africa. And we have no disclosures. Currently, 1.7 billion children globally lack access to safe, affordable, and timely surgical care. And that abysmal state of affairs is particularly felt in low and middle income countries where children and adolescents make up a disproportionate fraction of the population. In Africa, where the population is comprised of approximately 50% children, the surgical burden of disease is significant. Yet surgical care is an aspect of child health that remains underutilized, despite having the potential to prevent death or disability. Gender is defined as characteristics, roles, and behaviors ascribed to perceptions of what is masculine or what is feminine. And historically, gender has played an important part in hierarchical power imbalances, whereby the female gender has been deemed inferior. In fact, in certain African communities, gender inequities have given rise to social and structural barriers negatively impacting females. And this appears to be reflected in recent reports that suggest in certain African societies, women are less likely to seek care for their surgical conditions, and those who do tend to have worse outcomes. So a gender gap in global surgical care has already been documented in the adult population. However, the potential for this has yet to be clearly elucidated for Africa's children. All of this has fueled our research question. Are there gender disparities in pediatric surgical access and outcomes in Africa? To answer this question, we conducted a systematic review of African pediatric surgical studies, followed by a random effects meta-analysis. Our caveat here is that since most global registries and studies still characterize the cohorts according to sex, as opposed to gender, sex was used as a proxy for gender, particularly in cases of conditions that should not have any differences by sex or that are sex neutral in nature. And this methodology was validated by a number of sex and gender research experts, DEI or EDI advisors, and our African counterparts. So of the over 12,000 records initially retrieved, 54 were selected for final inclusion. The majority were retrospective, single site in nature, stemmed from Egypt, Nigeria, Ghana, or Ethiopia, were published in 2010 or more recently, had study cohorts of 200 children or fewer, study durations of 5 years or less, and focused primarily on GI conditions. Our meta-analysis yielded odds ratios that suggested surgeries were performed 3.6 times more frequently on boys than girls, and mortality was 1.6 times higher for girls than boys. And this is for conditions that were sex neutral in nature. So in terms of study limitations, we have the following. First, these results, albeit striking, may not give us the full picture. Stemming from a systematic review, they're a snapshot of the data in the literature during a discrete period of time. Moreover, this is not a commentary on African values, the family unit, healthcare providers, intentions, or capabilities. Next, generalizability. Only a third of Africa's countries were represented in the study. The sample size itself, 54 studies. Although most studies were published in 2010 and more recently, 3 were published prior to the year 2000. During the meta-analysis, moderate to high heterogeneity was observed. And all of the included studies had a risk of bias in at least one domain. And lastly, of course, the potential for confounding. In terms of next steps, we're embarking on a deeper dive into this issue to better understand the nuances, the barriers, facilitators, all of these types of things via a multi-site mixed methods approach. And this will hinge upon strong collaboration with our African collaborators. So in summary, this study demonstrated first-time evidence of gender disparity in African pediatric surgical care. And as I mentioned, this issue, as well as other causal factors, will be explored in further detail in the next phase of the study. Very quickly, I'd like to thank my team for their support, the Jean-Martin Haberge Global Pediatric Surgery Fellowship, and all of you for your attention. Merci.
Okay, next up we have Youssef, Kawa Association of Early and Delayed Type 2 Endoleak with sac eruption. Patients undergoing elective endovascular aneurysm repair. This one? Yeah. Yeah.
Good afternoon, everyone. My name is Youssef, and I have 6 minutes to talk to you about aneurysms and endoleaks. So, abdominal aortic aneurysms, traditionally treated by open surgical repair, developed by Dr. DeBakey in the early 20th century. And more recently, in the past 3 decades, the development of minimally invasive endovascular aortic aneurysm repair, or EVAR in short. Now, this accounts approximately 2/3 of contemporary abdominal aortic aneurysm repairs with a proven safety profile. Now, patients who undergo endovascular aortic aneurysm repair undergo lifelong or long-term imaging surveillance. And we monitor their aneurysm sac behavior or aneurysm sac dynamics. And we characterize them. And so patients can either have an aneurysm sac expansion, which has been found in multiple studies to be an independent predictor of rupture and mortality, regardless of the presence of endoleaks, which we'll talk about next. Well, and the other aneurysm sac behavior is aneurysm sac regression, which has been identified in multiple trials to be a marker of treatment success and associated with improved survival and reduced reintervention rates. Aneurysm can also have a stable aneurysm sac, which is basically a change within 5 millimeters of the baseline diameter. This has also been recently found to be an independent predictor of mortality. So looking into this type 2 endoleaks. So type 2 endoleaks are the most common type of endoleaks, and they are basically resulting from retrograde aneurysm sac filling from a patent, either IMA, lumbar arteries, median sacral, or an accessory renal into the aneurysm sac. This is the most common type of endoleak, and in these type 2 endoleaks, at least 50% will resolve spontaneously. However, persistent type 2 endoleaks beyond 6 months have been associated with inferior sac regression. And also the development of delayed type 2 endoleaks during follow-up was associated with increased reinterventions and concomitant type 1 or type 3 endoleaks. So the problem here is that we wanted to investigate, given this information, whether there was a temporal association between the onset of type 2 endoleaks and aneurysm sac regression, and whether that had an impact on sac regression and on overall survival. So we looked at all elective endovascular aneurysm repairs between 2010 and 2019 at 2 academic centers. We had 578 patients, of which 38% developed type 2 endoleaks. These patients were divided into patients who had an early type 2 endoleak, which was identified during the index procedure, and a delayed type 2 endoleak, which was identified during surveillance imaging. The primary outcome was aneurysm sac regression, looking at also at reinterventions and overall survival. Our median follow-up was 42.5 months. Looking at baseline characteristics, there were no significant differences in the two cohorts, with a mean age of approximately patients in their late 70s, who are predominantly male with an aneurysm, mean aortic aneurysm diameter of between 57 and 58 millimeters. So initially, we performed a Kaplan-Meier analysis between patients with early type 2 endoleaks and delayed type 2 endoleaks, and we found that patients with early type 2 endoleaks were more likely to have aneurysm sac regression. Now, we wanted to further characterize this data. So we performed a multivariate regression analysis model and divided our early type 2 endoleak patients into patients who had an early endoleak that resolved spontaneously, and patients who had an early endoleak that persisted, and patients who had a delayed endoleak. And what we found, interestingly, was that male patients were more likely to have aneurysm sac regression. And the interesting finding here was that patients who underwent reinterventions, actually, this was associated, undergoing reinterventions were actually associated with, was negatively associated with sac regression. Okay, so we wanted to look into this further, and we know that most reinterventions in these patients are most likely for concomitant endoleaks, and so we looked into this further. Okay, we found that patients looking at patients with concomitant type 1 endoleaks, which is basically an endoleak secondary to a proximal or distal seal issue, predicted reinterventions, which we knew. However, what we found was that despite reinterventions in these patients, there was no influence in aneurysm sac regression, and it did not impact type 2 endoleak onset. We looked at overall survival in these cohorts, and we found that there were no significant differences in overall survival between early and delayed type 2. And of course, this was a retrospective analysis with data limited to what scans available in the EMR or documented in the patient's charts. In conclusion, what we found was that patients with delayed onset type 2 endoleaks were less likely to achieve aneurysm sac regression. However, an increase in reinterventions for non-resolving type 2 endoleaks actually did not improve aneurysm sac regression rates. And type 2 endoleak, regardless of onset, had no impact on overall survival and was not influenced by the presence of a concomitant type 1 endoleak. These findings suggest that conservative management of type 2 endoleaks, including delayed onset subtype, is an acceptable approach in these patients. Thank you very much.
Sorry,
Oh.
The data extracted from EMR for is that what did you do with missing data or those that kind of fell spectrum brain?
So most of the data that we used in our analysis, like patient characteristics, mortality was available. It was more of like the granular data, for example, like cause of mortality that wasn't characterized. And so we looked at basically overall survival. Was the patient alive? Like we looked at yes or like mortality, yes or no, instead of the cause of mortality. That was a bit missing, but more or less the other data, which was like comorbidity, smoking status, medications, more or less that was available.
Right, so next up we have Jonathan Huberman. I'll give you 1 minute.
Perfect. Thank you for the introduction. Okay. Today I'll be presenting our research on the impact of adjunct medical therapy on survival after spine metastasis, in which we conducted a systematic review and pooled data analysis. I have no conflicts of interest to declare. Metastatic spine disease is a common complication in cancer patients, affecting up to 40% of those with systemic cancers. The challenge today is that traditional prognostic scoring systems, such as Tokuhashi and Tomita, were developed when systemic oncological treatments were limited, and therefore they often fail to account for the recent advancements, which have shown to improve survival and quality of life for patients with various types of cancer. We sought to take a look at the 8 primary cancers that most commonly metastasize to the spine, as they're listed here. And the purpose of this was to consolidate evidence for approaches to treat metastatic spinal tumors and guide the decision-making process by investigating the current state of the literature and treatment options, with a focus on advancements in systemic therapy compared to the conventional management of metastatic spinal tumors. Of note, this comprehensive systematic review is the first of its kind to encompass 5 different primary cancers that most commonly metastasize to the spine, while investigating 5 different treatment modalities. The systematic review was conducted following the PRISMA guidelines. It involved 2 independent reviewers and a librarian who together developed a comprehensive search strategy for the Medline database. Okay, so I've included here a picture from our paper of our inclusion and exclusion criteria. Because I wanted to highlight that we only included papers in which they reported the survival outcomes for both treatment and control groups, which seems like an obvious thing, but was very apparent that it was missing in many papers. With this data, we were able to pull together and calculate median overall survival as a weighted median of medians using normalized weights proportional to sample sizes. And with the multivariable Cox hazard ratios, we were able to meta-analyze them using inverse variance random effects method to generalize the impact of different therapies on survival. And all of this analysis was done with R. Initially, we identified 1,834 studies, which was narrowed down to 28 that met our inclusion criteria. Among them, there were 16 articles focused on primary lung cancer, 5 on breast cancer, 3 on renal, 3 on melanoma, and 1 on thyroid cancer. They included a mix of retrospective and prospective designs with levels of evidence ranging from 3 to 4. And we used Cochrane Review's bias of risk assessment tool to determine a low to moderate risk of bias. I've also included a slide here of the patient demographics, which covered a total of 3,238 patients, the largest subgroup being lung cancer, and within lung cancer, non-small cell lung cancer. And I've included this slide because I just want to highlight and emphasize the diversity in patient populations that suffer from spine metastasis and underscore the need to develop these personalized treatment approaches. So for some of our findings, we'll focus first on targeted therapy. So within the lung cancer subgroup, patients who received targeted therapy actually had a pooled median overall survival of 5.7 months 21.4 months with targeted therapy compared to 5.7 months for those without. And for breast cancer patients, those who received targeted therapy
had a median overall survival of 83.2 months compared to 32.9 months without. And the hazard ratios that we pulled together also confirm the effectiveness of targeted therapy. For example, in the lung cancer subgroup, the pooled multivariable hazard ratio was 0.395, which indicates a 60.5% reduction in risk mortality for those who receive targeted therapy. In the interest of time, I'll just highlight some of the other key findings we found among other treatment modalities that we investigated. For chemotherapy in the lung cancer subgroup, patients who received chemo had a survivalship of 5.7 months longer than those who did not, and this is also shown by the hazard ratio. And for radiation therapy, all three subgroups that reported monotherapy of radiation therapy showed improved survival with this treatment. And here I've included a slide from our paper, and you'll notice that there's a lot of blank spots. And this is important because these are all areas or subgroups for which we were unable to calculate a pooled median overall survival or pooled hazard ratios, simply because this data was not reported in the original articles. We also took a look at the impact of receptor status on overall survival. And I'll just highlight that for the lung cancer subgroup, patients who have the epidural growth factor receptor had a hazard ratio below 1, which aligns with our results for those who were treated with EGFR TKIs. So what does this all tell us? Well, for targeted therapy, it's definitely demonstrated a clear survival benefit, especially in lung and breast cancers. And we also see that the potential of combining targeted therapy with other modalities of treatment, such as chemo or immunotherapy, could further enhance outcomes. We were also able to reaffirm something that we already know. While targeted therapies can improve survival, surgical and radiation interventions remain crucial for local tumor control and symptom management. And to take away from all of this, what I can say is that scoring systems like Tokuhashi and Tomita need revisions to incorporate genetic and molecular advancements. And furthermore, we should be creating an environment where clinical guidelines and scoring systems can be easily and regularly updated to reflect the latest advancements in treatment. Our study did have some limitations, most notably the heterogeneity in data reporting across included studies, as well as selection bias and patient eligibility for treatments. And I'd like to finish off by concluding and summarizing that many of the papers we looked at simply did not report fundamental data for both treatment and control groups, which made meta-analyzing them or synthesizing that data very difficult to do. So we encourage, Dr. Wang mentioned that many of the latest trials involve in some way targeted therapy, but it's also equally important that the papers also report all the data so that we can make meaningful conclusions out of this and provide the best guidelines for clinicians. Thank you.
Any questions? I think we have time for some questions. I've got a question. Oh, I had it, and then I lost it. Sorry. Sorry to hear the. All right, I'll ask you.
No problem. Thank you so much.
Yeah. Next up, we have Jason Corbin, patterns of clinical demographic and kinematic jumping parameters amongst prospective cohort of elite varsity athletes, non-contact ACL.
Hi, everyone. My name is Tanya. I'm a third-year medical student here at McGill, and today I'll be presenting on the behalf of Dr. Corbin. Our study, the patterns of clinical demographic and kinematic jumping parameters amongst a prospective cohort of varsity athletes with non-contact ACL tears. As many of us know, ACL injuries are very common here in North America, accounting for about 50% of knee injuries, 40 to 80% of which occur due to a non-contact mechanism of injury. Why this is important? In our elite athletes, studies have shown that they miss a significant amount of playing time due to these injuries, on average about 216 days of playing time, and it leads to decreased performance for 2 seasons after return to play. Also, these same athletes are at high risk of re-rupturing in the ipsilateral and contralateral leg. We know from previous studies that poor neuromuscular control and certain lower limb biomechanical factors are risk factors for non-contact ACL injuries. Therefore, this is a target for intervention. A study done in 2005 by Hewitt showed that females that did drop vertical jumps, after analyzing their lower limb biomechanics, we found that those who tore their ACL with the non-contact vectors in the injury had higher peak and initial coronal abduction angles of the knee and smaller peak sagittal angles, which means that when these people jumped, they had more knee valgus and less knee flexion upon landing from their drop vertical jump. The gold standard for motion analysis has always been the Vicon motion system. However, it's quite expensive to use, averaging about $400 per person, and it's very complex to set up, making it difficult to implement in day-to-day life. Luckily, there's the Microsoft Xbox Connect, which can be programmed to analyze lower limb biomechanics during a drop vertical jump. And a study from 2019 found that there's no significant difference between the Xbox Connect and our gold standard Vicon motion analysis. The purpose of our study was to look at the clinical demographic and kinematic risk factors that are associated with non-contact ACL injuries among male and female athletes in elite collegiate athletes. So we had a total of 778 athletes in our study, ranging across 10 different sports, and we followed them consecutively for 4 seasons. So we prospectively collected the data, but retrospectively analyzed it. We looked at their clinical demographic parameters, so their age, their sex, their BMI, what sport they played in any previous lower limb injuries. And then we also did a kinematic assessment by having them perform 3 consecutive drop vertical jumps. And we looked at the lower limb biomechanics. So in total, we had 21 non-contact ACL tears during this study. In order to perform a binary logistic regression, we matched each of these 21 athletes with 3 healthy controls. Our studies showed that in the end, only the peak sagittal angle during the first drop vertical jump was associated with non-contact ACL tears. So we found that people who actually had larger peak knee valgus were at higher risk of tearing, and there were no other parameters in our study that were associated with these injuries. Using the same linear regression, we also tried to predict who would be at high risk of tearing using the first drop vertical jump peak sagittal angles, and we're able to predict 83% of the outcomes correctly. So something that's very interesting is that in our study, we found that an increase of knee flexion is associated with ACL tears. There's a risk of ACL tears, whereas in Hewitt's original article, we found that less knee flexion is associated with ACL tears as well as increased knee valgus. It's interesting that we didn't find that in our study, and it puts into question whether or not elite athletes follow the same parameters and have the same risk factors as the general population when it comes to non-contact ACL injuries. Of course, there may be a lack of significant association with our other parameters due to our smaller sample size, leading to a type 2 error. And one thing that would be interesting to look at would be to use machine learning in order to help us identify trends and other risk factors in this population group. So in conclusion, we had, for a limited cohort of prospectively followed athletes, we found that peak knee flexion angle differed between those who tore their ACL and non-contact mechanism of injury versus those who didn't. However, as we mentioned, this data highlights that there may be room to finding other risk factors in this population group, seeing as how our results differed from those previously published. And it would be important to prospectively follow more athletes in the future to see if this trend holds true. Thank you.
Any questions? So the next speaker we have is McGill.
So thank you so much for the introduction and opportunity to present today. So I'm going to be discussing our study titled Rate and Predictors of Opioid-Free Analgesia After Hospital Discharge Following Colorectal Surgery, a prospective cohort study. And I received scholarships from the FRQS and CIHR to conduct this work. So as we all know, North America is facing a devastating crisis of opioid addiction. Canada is has the second highest rate of opioid prescribing per capita in the world, after only the United States. In the year 2022 alone, there were nearly 7,500 opioid-related deaths that occurred across the country. So virtually all patients that undergo colorectal surgery are prescribed an opioid prescription at discharge following their surgery. And this practice leads up to 10 to 15% of patients to continue using opioids for over 3 months after their surgery. Importantly, up to 71% of the opioids prescribed to these patients go unused and become a potential source of diversion to recreational use within the community. In addition, opioid-related adverse drug events, including nausea and vomiting, constipation, somnolence, and respiratory depression are common and may hinder recovery after colorectal surgery. So opioid-free analgesia typically comprised of acetaminophen, non-steroidal anti-inflammatory drugs, and non-pharmacological pain interventions are being increasingly used and may minimize the use of opioids post-operatively. Opioid-free analgesia is commonly used internationally after surgical discharge, and recent knowledge syntheses conducted by our group do challenge the superiority of opioid analgesia after postoperative hospital discharge when compared to opioid-free analgesia. However, there is still currently limited evidence available regarding the rate and predictors of opioid-free analgesia after discharge following colorectal surgery. To bridge this knowledge gap, we aim to estimate the rate of patients who do not consume opioids after discharge following colorectal surgery, and to estimate the extent to which patient and care characteristics predict opioid-free post-discharge analgesia. So this was a prospective cohort study that was conducted at 2 academic hospitals in Montreal, Quebec, Canada. We enrolled adult patients undergoing elective colorectal surgery. And preoperatively, participants responded to questionnaires that focused on potential prognostic factors for difficult pain control and need for analgesia. So these included pain expectation, measured using a numerical rating scale, as well as inpatient opioid consumption over the first to third postoperative day, measured in morphine milligram equivalents, and opioid pills prescribed at discharge. Post-operatively, patients self-reported their analgesia consumption weekly for up to 1 month after surgical discharge using electronic questionnaires. And finally, rates of post-discharge opioid-free analgesia were analyzed descriptively, and predictors were identified using stepwise logistic regression with multiple imputations for missing data. So in total, 344 patients were included in this study. 64% underwent a laparoscopic surgery, 69% received a peripheral nerve block intraoperatively, and the median length of stay was 3 days. So patients received discharge prescriptions for non-opioid analgesia. So 92% received a prescription for acetaminophen, 38% for a non-steroidal anti-inflammatory drug, and 2% for a gabapentinoid, as well as 92% of patients receiving a prescription for an opioid drug. And overall, at 30 days after surgery, 51% of patients reported using no opioid after their surgical discharge. And these rates were similar amongst patients undergoing surgery via open, laparoscopic, or via stoma approach. So after backwards stepwise elimination, these were the variables that were included in our final logistic regression model. And which indicated that there was so patients were more likely to not consume an opioid post-discharge if they had an older age, lower pain expectation, lower inpatient opioid consumption, and fewer opioid pills prescribed at discharge. So this study does have some limitations that are worth discussing. The first being that opioid consumption was patient reported. So this does lead to a risk of recall bias and the potential for inaccurate reporting, especially considering cultural stigmatization of opioid use. Additionally, the study was conducted in Canada at 2 academic teaching hospitals. Therefore, our findings may not be fully generalizable to other countries or other settings of care. Additionally, contrary to current recommendations in enhanced recovery guidelines, only 21% of the patients in our study, 21% of the patients in our study did not receive a peripheral nerve block, and 62% did not receive a prescription for an NSAID. So further optimization of patients' multimodal analgesia strategy might have increased the amount of patients not consuming an opioid after their discharge. So although opioids do remain a mainstay for pain management after colorectal surgery, approximately half of colorectal patients in our study did not use an opioid drug after leaving the hospital. Furthermore, patients with older age, lower pain expectation, lower inpatient opioid consumption, and fewer pills prescribed at discharge were more likely to consume no opioids after surgery or after surgical discharge. So therefore, post-discharge analgesia with no opioids may be feasible after colorectal surgery and should be further investigated in future randomized trials. Thank you so much for your time and attention.
We have time for one quick question. If no one has any question, I would like to ask a question, and that would be, I think you mentioned one future or limitation was there could be biases in self-report measures, right? So for future studies, how would we remedy that?
In terms of having more accurate measures of patients' actual consumption?
Exactly.
So we did use several methods of sort of trying to triangulate this data in our study, asking patients different ways about their consumption, how many pills they consumed, how many were left over in the bottle. But this is definitely something to consider in future trials. Potentially, there's like a larger role of just culturally destigmatizing patients' use of these drugs in terms of getting more accurate assessments. But I think definitely triangulating by like asking multiple questions and eliciting patient responses in different ways could help to overcome this.
Amazing. Thank you.
Thank you.
Okay, next up we have Community Topi G. Joshua, development of priorities assessment tools for shared decision-making in rectal cancer patients undergoing restorative. Excellent.
Thank you for the introduction. So today I'll be presenting to you developments of a priority assessment tool to support shared decision-making in rectal cancer patients undergoing restorative prostatectomy. I have no disclosure, so just a little background. Shared decision-making is important in rectal cancer surgery. And so when you hear shared decision-making, what comes to mind? So this is an approach whereby the clinician and the patient share the best available evidence when they are faced with the task of making a decision, and where the patient is well supported to consider all available options to make an informed preference. So the diagram there just illustrates the process of shared decision-making. So what do we know about rectal cancer surgery? We know that there is high incidence of bowel dysfunction after rectal cancer surgery. So restorative prostatectomy has been linked to bowel dysfunction in up to 80 to 90% of patients. And this has an important negative effect on their quality of life. So one way to support shared decision-making is by using priority assessment tool. So what is a priority assessment tool? This is a dynamic system or device that helps patients articulate their personal preference, goals regarding their medical condition, treatment, and related decision-making. So prior studies have used priority assessment to share decision-making, such as ovarian cancer, but not to assist in rectal cancer. Therefore, our objective is to develop a patient-centered priority assessment tool for patients with mid and low rectal cancer to help them prioritize their personal preference, goal of treatment, enhance communication, and increase patient satisfaction. To do this, we designed a prospective study conducted in a single rectal cancer. So it's of note that this is still an ongoing study. We included adult patients diagnosed with rectal adenocarcinoma undergoing restorative prostatectomy. We defined the rectal tumor as any tumor less than 15 centimeters from the anal bulge. We excluded patients that have metastasis, recurrence, or any form of neuropsychiatric condition that might impair them from answering the questioning. So we designed an 11-item index rectal cancer priority assessment tool. This was based on the response to the patient-generated index from our previous study. So in this previous study, patient completed the PGI, that's patient-generated index, which asked participants to list 5 most important areas affected by rectal cancer treatment, in particular bowel dysfunction or permanent colostomy. These 11 items included in the priority assessment tool was the most commonly reported domains in the patient-generated index, after which we gave the participants these two and asked them to rate the importance of these 11 potential daily quality of life, and then to mark their top 5 priorities. So this is the tool. And then you can see like the 11 items, and it's graded from 1 to 5, how important it is to them. So 1 being not important, and 5 very important, after which they're going to indicate their top 5 priority in the box, in any order. So our primary outcome is to look at the priority assessment to content validity and feasibility. And we assess this by administering it to the rectal cancer patients during their surveillance clinic visits. This was immediately followed by a post-activity feedback form that was used to assess the patient experience with the priority assessment tool. So for our results, a total of 30 patients were included in this study, and the mean age was 62.7. The mean tumor height is 8.4 centimeters. 56% of the patients underwent neoadjuvant radiotherapy, and 51% had diverting stomach. So in terms of the educational level of the patients included, most of them had a form of education, and a lot of them have university degree. So this is something to bear in mind when interpreting the results, as this could be a potential limitation of the study. So this figure here illustrates the top concern for the rectal cancer patients completing the priority tool. And you can see my sleep, my mood, my physical appearance, performing usual physical activities, regular and predictable bowel movements, sexual function, ability to use transportation, ability to stay clean and wash myself, ability to take care of chores at home, ability to perform my work, employment, and social life. You can see the ability to stay clean and wash myself is reported in over 60%. Also, my sleep and regular bowel movements was equally highly reported as important. All participants reported that the tool captured their preference, value, and was easy to complete and understand, and 83.3% completed this tool in 5 minutes or less. All participants were able to stratify their priorities and identify their top 5 treatment-related priorities, and also reported that the tool aided in identifying their current goals and priorities. So to conclude, this rectal cancer patient-centered priority assessment tool was easy to complete and also helped patients prioritize their personal preference and goal of treatment. Also, this priority assessment tool among rectal cancer patients has the potential to improve patient satisfaction, communication, and encourage shared decision-making. The use of the parts has the potential to also optimize patient-centered care management of rectal cancer patients. So I would like to thank my supervisor, Dr. Lee, and also my co-supervisor and every member of the team. Thank you all for listening.
All right, do we have any questions?
Thank you. Thank you. How was how do you accept the news when it's I guess it's been saying we use it to help discuss their decision making between prospective versus PCR.
That's right.
So can you just give me a sense of how that would be used in that context?
Okay, so this will be used especially to newly diagnosed patients that's coming in, and then them being able to see what previous people that already had the disease thought important, and help them guide their decision in, for example, let's say if bowel dysfunction, bowel movement is extremely top priorities to them. So maybe they could opt for having a permanent colostomy in that regards, and that so that will enable them to have that discussion upfront with their clinician, and then decide which of the treatments is the best approach for them based on their preference. Okay. Thank you.
Next up, we have Hassan Alawari. Oh, 1 minute heads up when your time's up.
Is this the clicker?
Yeah, it's the green button.
Good afternoon, everyone. My name is Hassan Al-Hawari. I'm a PGY4 in plastic surgery. And today I'll be switching gears a little bit. I'll be talking about surgical education and specifically about ambidextrous surgical education. Before I start, I'd like to thank Dr. Gerardino for supervising this project. Don't disclose this. So we know from previous literature that being surgically ambidextrous is associated with many advantages. For example, it's been associated with improved outcomes in laparoscopic surgery and different types of spine surgery. And in general, it's associated with easier management. I think someone's on Zoom, maybe can you? Thanks. So in general, it's associated with ease of maneuverability in the operating room, especially when working in close spaces and when working with multiple teams. The question begs itself, why aren't we being trained to become surgically ambidextrous? And the easy and simple answer to this is that it's difficult, it's hard. So what I did is I looked at athletes. A lot of athletes that are ambidextrous. So I thought to myself, are these athletes ambidextrous because they're trained to be ambidextrous, or are they born ambidextrous? And it turns out that there's a lot of athletes that are ambidextrous that are trained to be ambidextrous. For example, this gentleman, he's Rafael Nadal, who's one of the best tennis players in the open era. He's born right-hand dominant, but his coach insisted that he practices with his left hand, with his non-dominant hand, before his right hand. And once he became proficient with his non-dominant hand, he was able to easily transfer these skills to his dominant hand and become ambidextrous. So I thought to myself, are we able to take this model from the athletic world and apply it to surgical education? And this is where this study comes in. So the goal of this study is to assess the efficacy and the feasibility of training junior medical students to become surgically ambidextrous. And specifically, we're trying to see whether skills acquired with your non-dominant hand, are they transferable to your dominant hand? So in terms of methodology, this was a pilot RCT where we had junior medical students with absolutely no surgical experience participate in the study, and we randomized them into two different groups. The control group, and they came to our session, they came to a suturing session, a very standard suturing session, and they practiced with their dominant hand. And then the interventional group, the non-dominant hand training, they came to the same exact session, but they were instructed to practice only with their non-dominant hand. And then we assessed their surgical skills before and after the session. Again, it was a very standard suturing session according to the literature. First 10 minutes were surgical residents explaining how to do different surgical techniques. And for the next 50 minutes, they were allowed to practice. They were allowed to ask any questions that they had. And then before and after the session, we assessed their surgical skills using this rubric. And this is a validated rubric from the literature. It looks at different technical aspects of suturing and gives you an overall score of 8. In terms of results, we have 43 participants in our RCT, or in our pilot RCT. 25 were randomized in the interventional group, which is the non-dominant hand training group, and 15 in the control group, which is the dominant hand training group. And at baseline, there was no difference between both groups. In terms of perception, at the end of the session, we asked them whether they liked it or not, and we asked them several other questions about the session. And in general, it was quite well liked. Approximately 84 or 83.7% of the participants felt that surgical ambidextrous training, if effective, should be standard of education in medical education. But now looking at surgical skills acquisition. So here we have a graph
The blue line is the dominant hand group, so that's the control group, and the red line is the non-dominant hand group, and that's the interventional group. So what we see is before the session, the non-dominant hand group, the dominant hand group, which is the control group, their surgical skills was rated at a 1.8 out of 8, and that significantly increased after the session to a 5.4. And then when we look at the non-dominant hand group, which is the interventional group, they started at a 1.1 out of 8, and they also increased to a 5.4 out of 8 after the session. So what that tells us is that when you take a junior medical student with absolutely no surgical skills before, and we teach them either to practice with their dominant hand or with their non-dominant hand, they're able to acquire skills at a similar rate. Now that's interesting, but what would be more interesting is to see whether your non-dominant hand skills acquired, are they transferable to your dominant hand skills? And this is what we see here. So here we're focusing on the interventional group, the 25 participants that only practiced with their non-dominant hand. They never practiced with their dominant hand. And then we assess their dominant hand skills right after the session. And here we also see that their dominant hand skills, although they never practiced with it, it also improved from a 1.4 before the session to a 4.9 after the session. And that was a significant increase. In terms of confidence, both groups had a significant increase in their own confidence in their surgical skills after the session. Obviously, there are some limitations in the study. So it's a pilot RCT, small number of participants. And more importantly, that we only assessed simple surgical skills, simple suturing techniques. We did not assess any complicated or complex techniques such as laparoscopic techniques or robotic techniques or microsurgical techniques. So it would be interesting in the future to see whether this model also applies to more complicated techniques. So in conclusion, we think that ambidextrous surgical skills training is effective, it is feasible, and we have preliminary evidence that shows that your non-dominant hand skills, if acquired early on, can be easily transferred to your dominant hand. And I can't finish this presentation without thanking all my co-authors who definitely played a very important role in this project. So thank you very much.
We have time for a couple of questions. Great presentation. Thanks so much. It sounds like you're hearing me, so I'll stay here. I would get and really what you're looking at, whether there could be differences in ideas from the latest study would be our not but we may just one say the back end and versus for some tasks in the Bible.
I can repeat the question. So the question is whether it would be interesting to control for certain people are completely lateral and other people use both hands to a degree. And would it be interesting to control for that? And I think it's a great question. So we actually did control for that. So we asked them pre-session whether they were ambidextrous or whether they used both hands in everyday life. And we excluded all these participants. So we actually had 54 participants. 9 of them, they mentioned that they use both hands. So we wanted to exclude them, but we actually wanted lateral participants and see whether we can acquire non-dominant hand skills. Thank you. Thanks, everyone.
Yeah, next up we have Abdulaziz Kakam Ali, ambulatory bariatric surgery, a prospective single-center descriptive study.
Everyone. My name is Ali Safar. I'm going to present this on behalf of Aziz and the rest of the bariatric group on ambulatory bariatric surgery as a prospective single-center descriptive study supervised by Dr. Andali. I have no disclosures. So in the last 2 decades, there have been progressive efforts to decrease hospital length of stay post-elective procedures. And bariatric surgery had definitely followed this path with significant reduction of postoperative length of stay. This goal has been facilitated by a number of factors, including advanced skills in minimally invasive surgery and the utilization of ERAS protocols. And as many of you know, that during the COVID pandemic, access to beds for many surgical patients got significantly affected, and this included bariatric patients. On the other hand, the importance of ambulatory surgery in reducing healthcare costs and reducing risks of inpatient complications had already been established in the literature. And I just want to give you some context. So 1 or 2 years ago, the group here at McGill has published on ambulatory sleeve gastrectomy as a feasibility study when only 56 patients agreed to undergo ambulatory sleeve gastrectomy out of 229 patients who met the eligibility criteria, and the success rate was impressive at that time, with a rate reported to be more than 90%, around 95%. And nowadays, with a well-established SDD protocol, we have more and more patients agreeing to undergo ambulatory bariatric surgery, not only sleeve gastrectomy, but also Roux-en-Y gastric bypass. So in this prospective single-center, single-cohort follow-up study, we performed a descriptive assessment of all eligible patients who chose to undergo a same-day discharge primary sleeve gastrectomy or gastric bypass between March 1st, 2021 and February 29, 2024. And we looked at the trends in same-day discharge surgeries as a proportion to total primary procedures over 6 discrete 6-month intervals. So these were the inclusion and exclusion criteria included. I just want to tell you that we have expanded the inclusion criteria to include patients with BMIs up to 65. And we also include patients who undergo or who are planned for concomitant procedures like hiatal hernia repairs and cholecystectomies. So the primary endpoint was successful discharge on the day of surgery without any visits to the emergency department or readmissions within 24 hours. And I just want to mention a few specifics about the same-day discharge protocol. So all of our patients were getting TAP block during the surgery, transverse abdominal spine block, in addition to laparoscopic guided posterior rectus sheath block that we started since August 2023. The second thing that I want to mention, that all of our patients get complete blood count done 4 hours after arrival to the recovery room to make sure that there is no drop in hemoglobin by more than 20 grams per liter. And all of our patients get 2 close follow-ups. So 1 follow-up on the night of surgery, and the second follow-up is on postoperative day 1 in the morning to screen for any alarming symptoms and to give patients also some reassurance. So during the study period, we had a total of 1,136 primary bariatric cases, the majority of which were sleeve gastrectomies. And 1/3 of the sleeve gastrectomies were done as same-day discharge surgeries. On the other hand, only 6% of the gastric bypass cases were done as same-day discharge cases. So looking at the patient's characteristics, the most prevalent comorbidities were hypertension and obstructive sleep apnea, with the majority of patients classified as ASA class 2. There were no conversions to laparotomy in the entire study cohort, with minimal blood loss for every single participant. So the success rate for the same-day discharge sleeve gastrectomy group was 89%, and the success rate for the same-day discharge Roux-en-Y gastric bypass group was 90%. The main reason for a failed same-day discharge protocol in the sleeve gastrectomy group was nausea or vomiting, followed by inadequate pain control. And we also looked at the median hospital length of stay among same-day discharge sleeve gastrectomy patients, which was only 6 hours, significantly lower than the median length of stay in the same-day admission group, with no significant difference in 30-day postoperative morbidity, including readmissions or reinterventions. Similar findings were observed when comparing same-day discharge and same-day admission Roux-en-Y gastric bypass cases. And the rate of readmission within 30 days for the entire cohort was only 1.5%. And I just want to conclude by showing you the distribution of the sleeve gastrectomy cases over time. So as you know, during the COVID pandemic and even after the COVID pandemic, the total number of sleeve gastrectomy cases has been lower than the total number of cases, which is potentially affecting patients' access to bariatric surgery. However, the proportion of same-day discharge sleeve gastrectomy cases has been increasing. So now we are reaching a proportion of 40 to 50% of total sleeve gastrectomy cases being done as ambulatory cases. So in conclusion, the same-day discharge protocol for laparoscopic bariatric surgery shows a favorable safety profile marked by high success rate and notably low readmission rates. And this has led to incremental increase in ambulatory sleeve gastrectomies performed over time. Now, there are a number of limitations associated with this study, including the inherent selection bias with the SDD protocol. And just as future considerations, we think that there is some reluctance on the part of surgeons and patients to perform ambulatory Roux-en-Y gastric bypass. And however, the identification of specific preoperative and intraoperative factors linked with a failed SDD protocol may facilitate further optimization of the existing protocols. Thank you very much.
Please begin with microphone. Face the round.
Yep. Great, Ali, good presentation. It's interesting because nausea and vomiting, obviously, it's more common after SIEV and it's less common after Roux-en-Y. So why, and since failure to send the patients home from the PACU was so low, it's going to be hard to find any intraoperative factors. So how do you think it should be addressed, this reluctance?
Yeah, that's very interesting. I think now with the numbers that we have, we are starting to recruit more patients or to do them as same day discharge cases. What I mean is more in the Roux-en-Y gastric bypass group, because as you said, nausea and vomiting are less common. And in fact, if you look at the failures in this Roux-en-Y gastric bypass group, there were only 2 failures and none of them were related to nausea or vomiting. One patient we couldn't win them off oxygen, so that's why they stayed. And the other patient had a positive leak test at the gastrojejunostomy site, which required surgical repair. And then patient was admitted and stayed overnight for observation. And even you can argue, even that patient could have potentially left the hospital. Yeah, exactly. So I think nowadays, or with these data, at least we are more encouraged to include more patients in the same-day discharge Roux-en-Y gastric bypass group. I think the reluctance partly comes from the technical, challenges of the procedure itself compared to sleeve gastrectomy, especially with creation of the pouch and having 2 anastomoses. So I think that's where the concern comes. But at least with the preliminary numbers that we have, we are more encouraged to do more ambulatory Roux-en-Y gastric bypasses. Okay, thank you very much.
So the next speaker is actually myself. So I'll just go ahead and time myself. Alrighty. Hello, everyone. My name is Tony An. I'm a doctoral candidate supervised by Professor Jason Hurley. And my presentation is titled, How Do Residents Intervene Harassment During a Clinical Procedure? A Content Analysis of Simulation Debriefing. So harassment in medicine continues to be an issue. In fact, the oldest, empirical documentation of harassment in medicine spans over for 40 years. Actually, my slide looks a little bit different from what I expected. Sorry, I'm a little bit caught off guard. Sorry about that. I think this quote illustrates, the continuation of harassment in the field of medicine. It's one of my favorite quotes from this qualitative study featured in Safran et al. Study, where it says, due to harassment, I would never want my children to do medicine. And harassment, as you can see, is a very negatively emotionally charged experience. And because emotional safety is patient safety, and because harassment can compromise emotional safety, we can conclude that harassment is a big issue as it compromises patient safety. So our response to this ongoing issue was to create our own anti-harassment educational intervention. There were 2 components to this intervention, one of which was a series of instructional videos that covered specifically how to intervene in harassment situations as a bystander. And the other component was a simulation training, where the participants could practice being an effective bystander. This particular research focuses on the simulation component, where the setting for the simulation was for the participants to conduct an internal jugular central line insertion. So as you can see, our participant here is getting ready to do the C-line, and the participant will be joined by an actor acting as the senior resident, and he'll also be joined by another actor acting as the medical student. In the simulation, the participant, while doing the C-line, will witness harassment, and the harassment will come from the senior resident targeting the medical student, and it's going to be in the form of basically verbal harassment or verbal abuse. And when the participant witnesses such harassment, they can intervene in different ways. One of the most straightforward way is to directly confront the harasser, but the participant could also follow up with the victim once the harassment is over. In our simulation, we ended the sim with the senior resident storming out of the room due to frustration, which provided an opportunity for our participants to follow up with the victim one-on-one. After the sim, we provided semi-structured sim debriefings, where I asked feelings about the simulation, feelings about realizing when the harassment occurred, and etc. So within this context, we asked a couple of research questions. What were the residents' emotions during the simulation? And second, were emotions linked to specific interventions? And to answer these questions, I conducted what's called a content analysis. I followed Bengtson and McQueen's guidelines. My content analysis was deductive based on the control value theory of achievement emotions, which my colleague Megar covered earlier, and my content analysis was also team-based. For the results, we found that the most commonly reported emotions were anxiety, followed by compassion and confusion. And seeing whether these emotions were related to specific intervention behaviors, we found that shame and confusion had significant results. Specifically for shame, we saw that it was connected to directly confronting the harasser, and for confusion, it was linked to checking in with the victim. If we look a bit closely, we found that shame was negatively correlated with directly confronting the harasser, which meant that residents who felt shame were less likely to directly confront the harasser. Sorry, this isn't working as well as I thought it would. For confusion, we saw that it was positively related to checking in with the victim after the harassment. So we concluded that residents who felt confusion, or I guess uncertainty on exactly how to intervene, uncertainty on why the harassment was happening with such intensity, they were more likely to opt in for checking in with the victim after. While this is a pilot study, there are a couple of, I guess, more concrete conclusions we can take. One of them is addressing harassment in a clinical setting, especially, is intensely emotional. Anxiety as a dominant emotion is consistent with past simulation education research. And educators should pursue emotions-aware training. Emotions can be linked to different harassment intervention responses, and to further anti-harassment education, I believe, or to coach specific intervention behaviors, educators should be aware of emotions and emotion regulation strategies that could be applied. So that was my presentation. Thank you so much for your time.
Do you have any questions?
Yeah. That's a great presentation, Tony. Very interesting study. I'm just curious as to how well were people able to describe their emotions?
I think that was very, I think it varied quite a lot, to be honest, between the participants. Some participants were very vocal about what they felt. From my experience, I think some residents needed a little bit more probing. So that's why I think we went with the semi-structured interview style, so that if we felt that the residents were a little bit more reserved, we could ask follow-up questions. I'll just quickly add, residents also, I think, they tend to rely on just everyday lingo. So if we ask them, oh, how did you feel about the harassment? They might be like, well, I mean, it wasn't that bad, but what does that really mean? So I would additionally ask what that would mean. So we would dissect their experiences, they would describe their experiences, and based on those phrases and keywords that they've used, we would apply the content analysis. Does that answer your question? Amazing. Thank you so much.
Okay, next up we have Anthony Bozo. A multimodal neural network model with gradient blending improves predictions of overall survival and risk of distant metastasis in soft tissue sarcoma.
Thank you. It's my pleasure to present today based on my colleagues at Memorial Sloan Kettering, where this work began, and my collaborators here at McGill now. Our work entitled The Multimodal Neural Network with Gradient Blending Improves Predictions of Overall Survival and Risk of Metastases in Soft Tissue Sarcoma. No conflicts of interest. Grateful for support from the Montreal General Hospital Foundation and Cedars Cancer Center. So I'm an orthopedic oncologist, and I work with patients who have soft tissue sarcoma. There are over 70 subtypes, each with varying genetic aberrations, translocations, and prognoses. Despite this heterogeneity, treatment for all of them is typically radiation and surgery, and sometimes chemotherapy is added. But the decision to use chemotherapy varies based on the city. It could be different in Montreal, New York, and Toronto, whether to give chemotherapy at all or which agents. Survival isn't great. It's just 65 to 70% at 5 years. And importantly, this has not improved in the last 3 decades. So new methods of matching patients to the optimal treatments are needed. What do I mean by this? Previous prognostic models have been shown to affect the decision of a multidisciplinary tumor board to prescribe chemotherapy or not. If we had accurate predictions on a patient's risk of metastases, a surrogate for the aggressivity of the tumor, perhaps tumor boards would be more likely to recommend chemotherapy. That was the conclusion of that paper. Moreover, their subsequent work showed that in the patients shown to be at the highest risk of metastases, when chemo was used, they did have a survival benefit. So there's a signal there. Secondary, after the tumor has been resected, how can we follow our patients? A previous randomized control trial and now an international multi-center randomized trial are trying to find the one best way to follow our patients after surgery. However, what if the best way to follow our patients is more individualized? There may not be one way, but rather a way that is more matched to that patient's risk of metastases. So what is out there so far today? Sarculator is one of the most extensively validated models, and it's used today. And it's based on just 4 clinical variables: age, the size of the tumor, the grade, and the subtype. At Sloan Kettering, work by Marie Brennan, who Dr. Reynolds mentioned, has produced other nomograms, predictive models as they were called. But when I was there, we didn't use them very often. And that's because a few clinical variables do not capture the whole picture about that patient. And importantly, all of these models do not consider data from other modalities. The main author of Sarculator himself says that these models typically capture the mean outcome of patients, but individual variability cannot be caught. What if we include image features? That has a lot of personalized data. We then get more individualized predictions. So far, there is no multimodal model in sarcoma, and our objective was to develop a multimodal neural network model that analyzes MRI images of the patient's sarcoma, as well as their clinical variables, to output their risk of metastases and their prediction for overall survival. We compare this model to previous clinical variable-only models like Sarculator, and to radiomics, and to unimodal deep learning models. So we include adult 18 and over patients with biopsy-proven primary soft tissue sarcoma. And all patients had to have complete outcome data and a T1 post-contrast sequence and a T2 FATSAT sequence of their sarcoma. All of these images were de-identified and then segmented. We had a total of 9,380 MRI slices prior to data augmentation that were used in the training of our models with high ICC and DICE coefficients between myself and the staff, musculoskeletal radiologist. Pre-processing was done to remove differences in sequences between different MRI acquisition parameters so that differences in MRIs as they relate to our outcomes are more due to differences within the tumor as opposed to differences between how this MRI was acquired. So firstly, our simplest model, the clinical variable model, we had 2, one using the same 4 variables in the well-established and validated Sarculator model, and then a larger clinical volume where we added 7 additional variables. We had a radiomics model. And to take a brief step back, how does radiomics extract features from an image? You can imagine with the image you see here, if you replaced the color of every pixel with a number, you would get a grid of numbers where every number represents the color in that pixel. And then radiomics combines those numbers in different ways to get different features from your input image. Some features are interpretable to humans, like contrast, texture, and heterogeneity, and some features are not. There are some called like log sigma 2.0 busyness, which has no clinical relevance. But in radiomics, you get about 100 features that are predetermined by humans, and the radiomics package will try to see which of those features in your images are most related to those outcomes, but you're limited to what's in the package. In contrast, our multimodal neural network model, as we see here, when we pass the MRIs, there are no predetermined features. It extracts the features that are most related to our outcomes, survival and risk of metastases. Our model will get a vector in the end that represents the features the best, and it combines this with a vector from our clinical variable model, and these are combined, and this gives us the multimodal predictions, some from images, some from clinical. We applied data augmentation, and training was done for 200 epochs, meaning there were 287 patients in this study, 44 were held out in a test set, but for the other patients that this was trained on, they saw every MRI 200 times. And gradient blending, as I'll describe a bit more later, was the key to enabling a multimodal model. So one of the problems in multimodal models is that, for instance, the clinical variable subnetwork might be easier to train because of lower number of parameters and might start to overfit while the image subnetwork is still learning and training. So gradient blending ensures that both subnetworks in our model converge optimally without one overfitting. C-index is how we track our outcomes. It represents the portion of included patients whose survival times can be ordered, such that those with higher predicted survival times actually survive longer. We split our training set into 70, 15, 15 between train, validation, and testing. And so you can see here, and the key is that for both the radiomics and multimodal neural network, 44 patients were never encountered in training. And so the results we present are based on just final test data on unseen patients. So 287 patients, median follow-up 4.1 years, 30% of patients perished in this follow-up time, and 38% developed distant metastases. How did the different models do at predicting these outcomes? Well, here's our data set. As you can see, a lot of subtypes. Exploratory data analysis shows patients with larger tumors do worse. Just the sanity check that our data is true for it. So how did our models do? First, it was pretty similar performance between the two variables based on just the two models based on just clinical variables. When we look at the models with radiomics, we do see that there's a lift when the images are combined with clinical data. These are both a lot better than the image-only model. And lastly, when we look at our multimodal deep learning models, again, we see a lift from including multimodal data compared to unimodal neural networks, and it was our best performing model. But the key was gradient blending. When we did a multimodal neural network without the gradient blending, the results weren't that high. So overall, what do we take from this? Multimodal deep learning can give us the best predictions, and gradient blending is key. Or do we, to peel back the black box, we are also able to ask our deep learning model, which pixels did you pay the most attention to when making the prediction? And what we like to see is that our heat maps are not in the corner with the empty padded pixels, but it actually is looking at pixels within the tumor volume when it makes its predictions. So PERSARC has shown to influence the ability or the tumor boards in their decisions, and some benefit in the patients deemed at highest risk if we give them chemotherapy. Before we can get there, we're externally validating our model now using something called federated learning, where the algorithm in the cloud can train on data from multiple centers. We're doing this now here at McGill with the help of brilliant young generation of John Huberman. And ultimately, to help our patients the most and have the most accurate predictions, we need multi-center, prospective, high-quality data. We'd love to be able to give subtype-specific predictions, and using genomic data can really help us too. Thank you.
The next presenter we have is Zamid Nafis.
This here. All right, 6 more minutes. All right, so bonjour à tous. Je vous remercie pour cette opportunité. So my name is Zainab Nafis, and I am presenting to you the usability of Pediatric Generated Index, PGI, insights from children, young people, and clinicians for esophageal atresia follow-up. So in today's patient-centric healthcare landscape, patients play a pivotal role in decision-making and actively managing their care. Accurately assessing health-related quality of life hinges on patient-reported outcomes, which provide direct insights into an individual's overall well-being. PROS capture patients' unique perspectives and experiences, facilitated by tools like patient-reported outcome measures, PROMs. These measures quantify various aspects of a patient's health status, including symptom burden, functional abilities, and overall quality of life. Our study aimed to evaluate the feasibility of using the patient-generated index, a personalized PROM, in the context of esophageal atresia surgery. This is a congenital condition where a newborn's esophagus is improperly developed. We compared the PGI to standardized measures like the EQ5-DY and PROMIS while assessing clinicians' perceptions of its usability. Our hypothesis was that personalized PROMs like the PGI offer superior insights into pediatric surgical patients' unique experiences and concerns compared to standardized measures. The patient-generated index is a self-reported tool that allows patients, including children, to identify and prioritize the specific areas of their life. Yeah, sorry. I think I skipped a slide. Whoops. Okay. Yeah, we're good. So the patient-generated index is a self-reported tool that allows patients, including children, to identify and prioritize the specific areas of their life most impacted by their condition or disability. Patients rate these areas on a scale from 0 to 10, generating an overall score from 0 to 100 that reflects the gap between their current reality and desired state. Standardized measures like the EQ5-DY and PROMIS assess predefined domains. Our study evaluated the quality of life of children up to 17 years old who had undergone EA surgery using both standardized and personalized measures. In phase 1, we identified key quality of life factors considered important by patients and their families. In phase 2, we assessed the alignment of individualized and standardized measures. In phase 3, we conducted cognitive interviews with children and parents to assess their experience with the personalized PGI. In phase 4, clinician interviews helped determine the most suitable outcome measure, and we aligned our findings with the International Classification of Functioning, Disability, and Health, the ICF framework, and we also used the Voyant tools for text analysis to unveil prevalent post-surgery themes and patterns. The study assessed post-surgical quality of life in 25 pediatric EA patients, so 16 males, 9 females, with a mean age of 9.88 years throughout the 4 phases. Phases 1 and 2 employed the PGI, the EQ5-DY, and PROMIS measures with surveys that were administered in English and in French. Phase 3 conducted 10 cognitive interviews, 6 child self-reports, and 4 parent proxies for deeper insights. And phase 4 gathered 6 clinician feedback. The analysis of 104 text threads revealed 58 unique codes, with 9 related to impairment, 7 to participation and activity limitation, 2 to environmental factors, and 1 to health-related factor. And the most prevalent code was looking after one's health. These codes were then condensed into 7 bodily systems. Voyant tools text analysis highlighted topics like eating, reflux, and school. The PGI reflected a lower average quality of life score, but higher variability among pediatric patients who underwent EA surgery.
In comparison, the standardized EQ5-DY and PROMIS measures showed a higher average quality of life score with lower variability in this patient population. And weak correlations were observed between the PGI score and both the EQ5-DY and PROMIS measures. Participants provided varied feedback on the patient-generated index. While some found it intuitive and engaging, allowing them to identify and prioritize areas of concerns, others struggle with the coin allocation system used for prioritization. Healthcare professionals had varying preferences for quality of life measures. 3 favored the personalized PGI for capturing condition-specific EA concerns and tailored assessments, and 2 preferred the standardized EQ5-DY for clear explanations and quantitative capabilities, enabling comparisons, and 1 opted for the PROMIS due to its focus on daily functioning and rehabilitation context. This study aimed to provide evidence that the patient-generated index is a usable and valuable tool for individuals with esophageal atresia, highlighting its patient-centered approach and unique insights. Despite its small size limitations, variations in quality of life scores emphasize the PGI's importance in guiding personalized treatment decisions and improving patient-provider communication. Je vous remercie de votre attention et je suis heureuse de répondre à vos questions. Questions? Thank you.
You don't have any questions? I think the patient most of them found the maybe a little bit is fine to kind of
Absolutely. And this was the result of the cognitive interviews we did after they use the tool. We asked them what was difficult about it. And some patients found it hard to understand the concept of allocating the coins to the different disease, the different categories of the condition that they identified were important. And so I think what we can do is possibly create a different way to express how those coins or those tokens can be allocated to those conditions. And we're going to work on that to improve the patient's understanding. Thank you so much.
Okay, now I believe we have a quick shot winner, right? This is Syed Azir, emotional responses to challenging events in virtual simulations, integrating psychophysiological measures and qualitative insights.
So today I'll be presenting the work on emotional responses to events in virtual simulations. This research was conducted in supervision by Professor Jason Gurd. First, give some background. Simulations in medicine are commonly used as a tool to train healthcare professionals prior to having them treat patients. Simulations are delivered either in person or virtually. Virtual simulations predominantly include headset-based virtual reality, which is shown here, and screen-based VS that is shown here. When it comes to the literature, it has been shown that virtual simulations are effective in helping students learn. There has been quantitative work in the past comparing modalities. However, there is a lack of qualitative investigation. The quantitative work uses technology non-specific tools and doesn't provide guidance on which aspects of the VS need improvement, a gap in the literature. So we sought to address this by qualitatively identifying discrete VS elements for improvement, and today's presentation adds quantitative support for that work. To do this, we collected data from 20 nursing students enrolled in a clinical course, 10 used headset VR and 10 used screen-based VS. All students went through a tutorial to get familiar with the system and then did a virtual simulation dealing with an emergency room patient. During the simulation, audio-video data was collected as well as electrodermal data in the form of skin conductance, also known as EDA. We specifically wanted to see if our qualitatively coded challenges encountered by nursing students resulted in emotional arousal and if specific challenging event categories were more important than others. For reference, these were the challenge categories generated by our qualitative coding: software-related restriction and bugs, confusion/lack of success, negative affect, technical errors, neglect of instruction, and other.
To see if challenging events result in emotional arousal relative to before the event, we use repeated measures on cohort with students' baseline EDA as a covariate. We found that there was a significant increase in participants' post-challenging event EDA, emphasizing the emotional impact of challenging events and providing support for our qualitative work. Then to see if specific challenging event categories were more important than others, we used a multiple regression with cluster robust errors. However, we found that no event categories' EDA elevation was significantly different than the other event categories. Our findings showed that there was a significant elevation in emotional arousal after encountering challenging events, but when coded into categories, changes in emotional arousal across the categories is similar. This suggests that VS developers need to focus on minimizing overall VS-related challenges rather than targeting specific challenge types. Our qualitative work adds to the literature by generating challenging event categories, which can help develop technology-specific tools to assess usability in virtual simulation. Furthermore, our quantitative analysis of EDA adds value by illustrating that the categories are equally as important to address. Overall, we offer critical insight into the emotional needs of nursing students using virtual simulations, aiming to optimize their efficacy and ease of use. Thank you all for listening, and I'd be happy to take any questions.
Oh, here it is. Perfect.
Any questions?
So I have a question. Did you measure, I couldn't get it, I mean, it was very quick, presentation. Did you try to measure, whether these nursing students will respond, how they responded to these challenging events before, like at baseline? I mean, don't some people just thrive in challenging events and others kind of wither?
Yeah, for sure. That's a great question. What we did is we took a physiological baseline of every participant while they were doing a pre-simulation survey. So this was when they were just sitting down at the computer during the survey before the study actually kind of started. And what we wanted to capture during that time is we wanted to capture the people that were hyper responders and people that were hypo responders. So for example, some people naturally have heightened EDA, and those people tend to respond, their EDA reflects those high sort of elevations when they encounter challenging events. So because we were able to capture that baseline, we were able to control for it as a covariate. Another thing that we did, that's not really mentioned in the presentation because it was a 3-minute talk, is we also standardized the EDA within the participants themselves. So we use Z-scores for every EDA average that was taken from a participant. So that allowed us to basically account for the intra-participant variability when we're comparing it from participant 1 to participant 2.
Thanks.
Yeah, thank you. Yes.
What did you mean by saying developers should focus on the challenges as opposed to challenges?
Yep. So my qualitative coding generated a bunch of, these are positive experiences. I don't know why that's there. This is about negative experiences. Let me go back. Oh, okay, I can't. So I will say we had 6 negative event categories that were generated from the qualitative coding. And the initial hypothesis was that some of these categories will be more, significant than others in terms of increasing EDA of students. And what that basically translates to would be that some categories are more important to address by VS educators and developers when they're making these virtual simulations. But as I mentioned, our results showed that there was no significant when we looked at across categories. So what I mean by when I say that they're all equally as important is I say that it's not actually beneficial for us to hone in on one specific challenging event categories, let's say software-related bugs, for example, where we should instead be looking at overall across categories. So for example, providing good instructions to students is just as important as negating software-related bugs when it comes to these virtual simulations. Thanks. Okay, thank you.
Okay, so we're kind of on time-ish, and so let's begin by thanking all of the presenters today and congratulate them all. So we had 33 selected from over 100. So you did pretty well if you made it today. And the winners of each session will be announced at the graduation banquet tonight. So we'll find out later. Professor Reynolds, thank you again for your great talks, and the chairs and co-chairs and speakers, thank you all. And it's been a great day, and I look forward to seeing you later on. I'd just remind you, however, if you forgot to vote in this session, now you've got about 3 minutes to get your votes in. I think I'd like you all to vote 5 for ability to answer questions, because that didn't initially kind of go as we'd like. So I'd like to kind of counteract for that. Dr. Feldman, do you have any other? No. Perfect. Okay. Well, thanks a lot. We'll see you later. Okay. Thanks. Bye-bye.